예, 안녕하십니까. 대한고혈압학회 총무이사 이혜영입니다. 2022년 하이퍼텐션 서울 2022와 57회 추계 학술대회에 참석해 주신 모든 분들께 감사의 인사 말씀 올립니다. 지금부터 추계 학술대회 시작하기에 앞서 대한고혈압학회 임상현 이사장님의 인사 말씀과 학술대회 소개가 있겠습니다.
대한고혈압학회 이사장을 맡고 있는 가톨릭대 임상현입니다. 오늘 이렇게 만나뵙게 돼서 대단히 반갑습니다. 먼저 영어로 간단히 인사 한번 하고 시작하도록 하겠습니다. Good morning, everyone. I would like welcome to all you to opening ceremony on Hypertension 2000 Seoul 2022. I'm 상현님 from Catholic University of Korea and President of Korean Society Hypertension. Finally, we are holding now the conference face-to-face. On behalf of Korean Society Hypertension, I would like to thank all participants. Enjoy the conference until tomorrow. Thank you. 예, 감사합니다. 사실 엊그제 지난 토요일 날 그런 이태원 참사로 인해서 이번 유명을 달리하신 분들이 있어서 그런 분들의 명복을 빌고 또 부상자들의 빠른 쾌유를 빌면서 간단히 시작하도록 하겠습니다. 추계 학술대회에 대해서 간단히 말씀드리면 여러분들도 아시다시피 지금 오프라인으로 개최하고 있고요. 3층, 5층, 6층에서 지금 시행되고 있습니다. 그리고 평점은 여기 나와 있듯이 6점, 6점, 2점 이런 식으로 지금 부여되고 있고요. 주요 세션을 말씀드리면 주로 내일 있는데 프로네리 세션에 현 ESH 회장이신 크루즈의 레노 프로텍션 매터 인 더 매니지먼트 오브 아트리얼 피브릴레이션을 강의가 있을 예정이고요. 스페셜 렉처로 이도 교수의 MR 브로케이드 인 하이퍼텐션 트리트먼트가 있을 예정입니다. 그 외에 총 21명의 오버시 인바이티드 페이컬티가 참여할 예정입니다. 그리고 또 어워드 세션을 3개 준비됐는데요. 클리니컬 리서치 어워드, 또 영 인베스티게이터 어워드, 또 베스트 이 포스터 프레젠테이션이 있으니까 여러분들 많은 참여 부탁드리고요. 또 이 포스터는 특히 이 포스터 스테이션은 스튜디오 5, 그러니까 6층 플로어 6에서 있는데 이때 저자들과 댓글 의견 교환이 가능하니까 여러분들의 많은 참여 부탁드립니다. 그리고 여러분들이 받으셨을 수 있겠는데 팩트 시트하고 2022년 또 고혈압 진료 지침이 발표되었습니다. 여러분들이 책으로도 받았지만 온라인상에서 홈페이지를 통해서 다운로드가 가능합니다. 예, 대단히 감사합니다.
임상현 이사장님 감사합니다. 회장님의 개회 선언에 앞서 학술대 이벤트를 간단히 소개해드리겠습니다. 다음 슬라이드 부탁드립니다. 첫 번째로 학회 현장 참여하신 분들 대상으로 스탬프 투어 이벤트를 진행합니다. 많은 회사에서 우리 학회를 도와주고 계신데요. 현장 안내 데스크에서 받으신 스탬프 투어 용지를 지참하셔서 각 전시 부스를 방문하셔서 많은 정보를 받으시고 스탬프를 받으시면은 이제 바로 전원에게 스타벅스 쿠폰을 증정하려고 합니다. 다음 슬라이드 부탁드립니다. 두 번째로 경품 추첨을 진행합니다. 학술대회에 참석하신 분들이 내일 오후에 이제 총회에 많이 참석하실 수 있게 하기 위해서 추첨을 통해 1등부터 5등까지 다양한 경품을 준비하였고, 단 이 네임택 뒤에 있는 쿠폰을 내일 3시에서 6시 20분 사이에 위치한 럭키드로우 이 응모통에 제출해 주시면은 총회에서 이제 추첨해서 다양한 경품을 드리도록 하겠습니다. 이제 더불어민주당 최고위원이신 서영구 국회의원이 우리 국제학술대회를 축하하며 축전 영상을 보내주셨습니다. 함께 시청하시겠습니다.
안녕하세요. 저는 더불어민주당의 최고위원 서영교입니다. 서울 중랑구갑 국회의원입니다. 제57회 대한고혈압학회 추계학술대회를 진심으로 축하드립니다. 대한고혈압학회의 박창규 회장님, 그리고 임상헌 이사장님, 그리고 편우범 KMMM 위원장님, 오늘 이런 자리를 만들어 주시며 진심으로 감사의 말씀을 드립니다. 오늘 학술 발표회를 하시는 관계자 여러분, 대한민국 국민의 건강을 지켜주십시오. 세계 사망률 1위가, 그 요인의 1위가 고혈압이라고 들었습니다. 그리고 1년에 1,000만 명이 사망한다고 들었습니다. 그럼에도 불구하고 우리는 이 조용한 고혈압으로부터 위험하다고 느끼지 못하고 대책도 세우지 못하고 있습니다. 얼마 전 제가 심장이 두근거리면서 고통스러운 날이 있었습니다. 편육범 선생님으로부터 좋은 조언을 받았고 대책도 말씀드렸습니다. 그리고 그것을 인연으로 편육범 회장님과 대한고혈압학회는 국회에 와서 300여 명에 이르는 사람들에게 상담을 해주시고 또 전문적인 지원도 해주기로 하셨습니다. 다시 한번 감사의 말씀을 드리면서 대한민국 국민이 건강할 수 있도록 저희 국회에서 입법으로 할 수 있는 일이 있으면 입법으로 지원하겠습니다. 그리고 예산 또는 정책으로 함께 할 수 있는 일이 있다면 함께 하겠습니다. 부디 가깝게 들리는 심정지 또는 뇌출혈 이런 소식이 들리지 않도록 저희들에게 길을 제시해 주시고 또 학술적으로 많은 연구를 해 주시길 부탁드리겠습니다. 다시 한번 대한고혈압학회가 더 큰 일 할 수 있도록 화이팅!
예, 감사합니다. 마지막으로 대한고혈압학회 박창규 회장님께서 나오셔서 개회 선언을 해주시겠습니다.
네, 안녕하십니까. 대한고혈압학회 회장으로 재직하고 있는 박창입니다. 상상할 수 없는 어처구니 없는 사건으로 꽃단 우리 청춘들이 지난 주말에 많이 아슬아져 갔고요. 그걸 지켜주지 못한 저희 어른으로서 굉장히 책임감을 통감하고 슬픔을 느낍니다. 저희 이제 고혈압학회 회원들은 국민의 안전을 지키는 또 하나의 커다란 축이 되겠습니다. 우리가 이런 학술 여러 가지 행사나 어떤 이벤트 여러 가지를 통해서 국민의 안전을 다시 한번 지키는 계기를 삼는 것을 마음 새기면서 오늘 하이퍼텐션 서울 2022년 국제학술대 개최를 선언하겠습니다.
예, 감사합니다. 이상으로 이번 학술대회 개회식을 마치겠고 잠시 후 45분부터 A룸부터 D룸까지 각 룸에서 정규 세션을 시작하겠습니다. 감사합니다.
Good morning, everyone. I'm so happy to open the first session of Hypertension, Seoul 2022. My name is Jin Han, chaired this session with.
I am Jin Ho Shin from Hanyang University.
Okay, I will guide first two speakers and final two speakers chaired by Professor Sin. We have excellent scientists from our society as of panels who are Hae-moon Jung from Gyeonggi University, Dong-hyuk Jo, Korea University, He-ran from Hanyang University, Uk-jin Chiar, Sunway University, Malaysia. So please welcome our excellent panelists. So I would like to introduce first speaker, who is Young-woo Jang from Gachon University, who will give a talk about the association among fat distribution, insulin resistance, and hypertension risk. Professor Jang, please.
Thank you, Chairman, for your kind introduction. My name is Jang Young-woo from Gachon University. I work as a interventional cardiologist. Today I'll be talking about the association among fat distribution, insulin resistance, and the hypertensive risk. I have no disclosures. So I'm going to start out with a case of a 45-year-old male who I received a consultation from infection for his symptoms of dyspnea on exertion and hypertension. He has also had some headaches. So as you see, he had very high blood pressure. His LDL levels were low, very high. HDL was low, high TG, borderline diabetes. He was diagnosed with diabetes and he had microalbuminuria. So he was newly diagnosed with hypertension and diabetes. He had various forms of inflammatory diseases, including cellulitis, myositis, atopic dermatitis, and psoriasis, NAFLD, and so on. His BMI was very high, 37. He was highly obese. As you can see in his CT, he had a lot of visceral fat. You can see in this ECG he has LVH. And his this is his echocardiography, and as you can see, he had tachycardia, and in this image you can see that he had a flattened left ventricle, which means that the pressure is very high in the right ventricle. So it suggests that he had some pulmonary hypertension and also some epicardial fat and pericardial effusion. So if you look at the tricuspid regurgitation, he had very high RV pressure, which is suggested by the high TR velocity, and his IVCs was dilated, which means that he will have some edema as well. So the summary of the echocardiography report is that he had concentric LVH, probably due to his hypertension. He had very bad diastolic function, and this diastolic dysfunction may have led to the moderate pulmonary hypertension, which causes dyspnea and peripheral edema, although his EF was preserved. So my assessment was that he had diastolic dysfunction, HFpEF, which was caused probably by hypertension and obesity. This further was resulted in pulmonary hypertension and diabetes and all kinds of inflammatory diseases as well. So to understand this patient, we may have to look at some data. I will start with the obesity and hypertensive risk. This is a very seminal study from the Poirier group. They showed that BMI was associated with the risk of hypertension. So as you can see in this slide, they divided the patient groups into 3 tertiles of BMI. And regardless of the BMI tertiles, you can see that if you have a increased circumference of our abdomen, the risk of hypertension is higher. So higher BMI and waist circumference is associated with the risk of hypertension. And we all know that the waist circumference is associated with hypertension, but in some data you can see that the baseline and delta waist circumference all associated, regardless of the multivariable adjustment, is associated with the risk of hypertension at baseline and follow-up. So to understand obesity of the abdomen, we have to look at some compartments. Abdominal fat is composed into mainly two components: the subcutaneous fat, which is the fat outside of your abdominal core muscles. Within the core muscles, you can see that this is the intraperitoneal fat. Which is better, which is bad, we may look in the following slides. And an important thing that I want to point out today is the renal sinus fat and how it's associated with hypertensive risk. And another compartment of fat is located in the outside of the heart. It's called the epicardial fat. We'll talk about this briefly. So this is a very important slide. They looked at visceral and subcutaneous abdominal fat and tried to relate it with hypertension. So as you can see, visceral fat was highly associated with the risk of hypertension, whereas the subcutaneous fat, which is outside of the abdominal muscles, had no difference between hypertension and non-hypertension groups. The mediastinal fat, which is the epicardial fat, was also highly associated with the risk of hypertension. We're going to talk about this in the later slides. So abdominal visceral fat is associated with the risk of hypertension. What else? The abdominal visceral abdominal fat was also inversely related with insulin sensitivity. So as you can see here, as the fat mass grows in the abdominal visceral fat, the insulin sensitivity goes down. Right, over here too. The mean arterial pressure was inversely related with insulin sensitivity. So abdominal visceral fat is associated with risk of insulin resistance. And now we're going to talk about the renal sinus fat. This is the fat located in the middle, in the sinus area of the kidney. The way you can assess this is you can draw a line of these, the area of the renal sinus, and you can measure the total amount of renal fat. And in this study, they looked at 51 to 60-year-old people and saw that they divided the groups into patients with fatty kidney, which is a renal sinus fat kidney, and those without it. And the body mass index was different between these two groups, visceral adipose tissue as well. And they did a multivariable analysis, and they found out that those with fatty kidney had a higher blood pressure, both in the systolic and diastolic phases, and the kidney functions were worse. So the risk of hypertension and CKD was higher in patients with a higher fat component in the kidneys. So renal sinus fat is associated with the risk of hypertension and CKD. And in another study from the Japanese group in 2016, they also showed that in middle-aged groups, as you can see here, the renal sinus fat volume here is associated with the risk of developing coronary artery calcification, which is a marker of atherosclerosis. So in the multivariable logistic regression, they showed that there was a higher odds ratio. So renal sinus fat is also associated with coronary calcium, which is coronary atherosclerosis. So in summary of these data, this is a very good summary from the Japanese group. They showed that visceral adipose tissue was associated with insulin resistance, type 2 diabetes, and dyslipidemia, and also hypertension. Renal sinus fat especially had a high correlation with hypertension and also atherosclerosis. And in another study, they also showed that with increasing renal fat, sinus fat, the number of antihypertensive medications increased as well. So this is two patients that I compare in our hospital. I found these two patients side by side, which are almost same in age, and BMIs were similar. And as you can see in this woman over here, which is who is a 49-year-old female, she had a very high mass of subcutaneous fat, not visceral fat. Whereas on the right side, you can see this woman had very high amounts of visceral fat. Well, how would this lead to clinical outcomes? Well, this woman, although she had a high BMI of 27.5, she did not have hypertension or diabetes, probably because she did not have a lot of visceral fat. Whereas on the other side, this woman had a high amount of visceral fat. The cutoff value is around 100, and she had hypertension and atrial fibrillation. Okay, I'm going to move on to inter and intramuscular fat and insulin resistance. This is a study published in 2002 in the Diabetes Care. This was published from a Korean group in Severance University. They looked at around 40 to 45-year-old people who had obesity. The baseline BMI was around 29. And what they found was abdominal visceral fat area was associated with higher insulin resistance. So muscle fat is associated with insulin resistance. The underlying mechanism may be complicated, but it is thought that there is a complex interplay between the adipocytes secreting all kinds of adipokines, and these may result in hypertension and insulin resistance. As you can see here, the adipocytes lead to the secretion of angiotensin system. This may lead to hypertension and more cardiovascular outcome, adverse events. Another thing, the last thing that I want to point out is the epicardial fat and the cardiovascular diseases. Epicardial fat is the fat located outside of the heart. In one study, they found that increasing epicardial fat was associated with decreasing diastolic function. So they found that an inverse relation between epicardial fat and diastolic function. And to understand this, we may have to understand that epicardial fat has no barrier between this tissue and the myocardium in the heart. Usually in the abdomen, there is a barrier or membranes that divide the tissue and the adipose fat side, but in the heart, they're intertwined and connected right here. So it means that these adipose tissue can directly affect the heart tissue by secreting cytokines or paracrine systems. So this is a paper that we published last year, and we found that adiponectin is a very, we call it a good adipokine secreted from the adipocytes from the heart tissue. These reduce the risk of hypertension and also increase the insulin sensitivity. But in heart failure or hypertension, we think that this signal is disrupted probably due to NT-proBNP, and we suggested a mechanism in both HFrEF and HFpEF. And to understand the risk of as I already talked about, the adipose tissue increases the risk of hypertension. Hypertension in a normal heart without hypertension, when the heart relaxes, the LV-EDP reduces and the blood flows from the LA into the LV. But when you have hypertension, the LV-EDP is increased and the flow from the LA to LV is reduced because of the diastolic dysfunction. This further causes the dilation of the LA and the swirling of the blood within the LA, and this further causes atrial fibrillation and stroke. So to understand the cardiovascular diseases caused by obesity or hypertension, this is the cascade you may have to understand. Hypertension leads to diastolic dysfunction. This further results in blood stasis in the left atrium and development of atrial fibrillation and stroke. So we found in one study that in patients with atrial fibrillation, diastolic dysfunction was a better predictor compared with LVEF. So going back to our patient, he was only 45 years of age. He had hypertension. He developed diabetes, but he was very obese. And you can, we could suggest that this obesity from all the bad adipokines that is secreting, it may affect the blood vessels, insulin sensitivity, and also diastolic dysfunction. These adipose tissues and the renal sinus fat over here, these may affect the systemically, causing hypertension and diabetes. This may further result in LVH, which also leads to HFpEF and pulmonary hypertension, further causing dyspnea and peripheral edema. What I did was I only prescribed this patient with mild hypertensive medication, but we talked about his obesity causing this condition, and he promised me that he would reduce his weight by 20 kilograms. So within 60 days after he was discharged of cellulitis, he exercised very hard and also went on a very good diet. He reduced almost 30 kilograms within 60 days. And he had a rapid improvement of hypertension and heart failure symptoms. And also his psoriasis and atopic dermatitis was also improved. So this is the follow-up echocardiography, and you can see that the D shape was much alleviated. There's no pericardial effusion. The epicardial fat has also reduced, and it seems that the longitudinal motion has also improved, probably due to the reduced epicardial fat and systemic adipokine release. So IVC is also improved, and the TR was greatly reduced. So his EF was pretty much normal, but his concentric LVH was improved. His diastolic function also improved, and his dyspnea causing pulmonary hypertension was also reduced. This is the echocardiography before and after. Much improved, and his LVH was also reduced significantly. So my take-home message is that abdominal visceral obesity, especially renal sinus fat, is associated with the risk of hypertension and insulin resistance. Epicardial fat is strongly related with the hypertension and cardiovascular disease, and muscle fat is also shown to be related with insulin resistance. Thank you very much.
Thank you, Professor. Wonderful presentation. We will discuss in panel discussion later. Next speaker is Professor Yukio Yamori, who graduated from Faculty of Medicine, Kyoto University, and Graduate School of Medicine, Kyoto University. He was a professor in Kyoto University. Now, he is president of Hyogo Prefectural Health Promotion Association, professor emeritus in Kyoto University, and director Mukogawa Women's University Institute for World Health Development. He will give a talk about how to eat wisely, our Asian diet for living healthy, long life with a less cardiovascular risk. Professor Yamori, please.
Thank you very much for your kind introduction. Mr. Chairman, resident doctors. It's my great pleasure to talk how to eat wisely. And our Asian, particularly the Japanese and Korean diets, who are living a healthy long life, we have no financial conflicts of interest to disclose concerning this presentation. As you see, in the left, 3 top countries with the longest average life and healthy life expectancy in the world. Japanese and Korean people are enjoying the first and the third longest average life expectancy and healthy life expectancy. The right figure showed the extension of average life expectancy and males and females in Japanese. And for the last 28 years, the average life expectancy of the Koreans and the Japanese are 83.3 and 84.3, nearly equal each other. We will consider today what common nutritional merits are contributory to Japanese and Korean longevity. Firstly, we could develop from spontaneously hypertensive rats the new model of stroke-prone spontaneously hypertensive rats, which suffered from stroke like humans in 1974, nearly 50 years ago. Genes causing stroke and the nutrition for preventing stroke have been studied since then. High salt diets cause stroke within 2 months in stroke-prone rats, but diets containing soy and fish nutrients could prevent stroke, and they could survive for 1 year or longer. This was the first evidence indicating stroke, the most common cause of death in humans, could be prevented. On the other hand, if genes causing stroke could be detected, stroke would be predicted and prevented. Therefore, current diagnostic and therapeutic medicine will be changed into predictive and preventive medicine of stroke in the future. Based on Jay's experimental studies, I proposed to WHO cardiovascular disease and alimentary comparison study and could start worldwide health examination. In 1985, thanks to the great cooperation of many researchers in 61 populations of 25 countries, including the regions well known for longevity, marked with green circle, or known for relatively shorter lifespan, marked with red circle. About 100 males and 100 females aged 48 to 56 were randomly invited to health examination, including blood pressure measurement, blood sampling, and also 24-hour urine sampling. For collecting 24-hour urine samples from free living people, we developed a special device, a special double-bottomed cup, as shown here. Urine is boiled into the upper compartment. Yes. And just pushing this rod once, we collected successfully 22.5% of the daily urine samples. And by repeating this at each time of voiding for 24 hours, 2.5% of the daily urine samples is collected for estimating salt, vegetables, seafoods, soybeans, grains, and so on. Our first health survey for Maasai in Tanzania, free-living Maasai people in 1987 revealed that they had no hypertension, and their salt excretion in 24 hours urine was very low, only 2.5 grams in average, the lowest in the world. Maasai used no salt at that time, and their sodium was taken from milk. In contrast, Tibetans living at the foot of Mount Everest, 40% of the participants suffered from severe hypertension, and the average 24-hour urine salt excretion was 16 grams, highest in the world. As shown by 24-hour urine analysis, the mortality rates of stroke caused by hypertension were positively related with populations' urinary salt excretion. This data indicates the reduction of daily salt intake down to 5 grams as recommended by WHO, should greatly contribute to the prevention of stroke and the extension of the average life expectancy. Now, we quickly reviewed the better diets for longevity in the world by showing the dietary customs in 4 regions famous for long life: Georgia, Silk Road, Guizhou province in China, and Japanese immigrants living in Hawaii. I'll shortly talk about Georgia and Hawaii today. This is a Georgian diet, good for longevity. Much fruits and vegetables were served at the table, indicating enough intake of potassium and magnesium. The fatted meat served after the boiling and baking. Fresh water fish and well-known yogurt were good source of protein. Our worldwide health examination clearly indicated high cholesterol levels in the blood were positively related with high mortality rates of coronary heart diseases. Japanese serum cholesterol levels were lower because our main source of energy was rice and not from fat. Japanese immigrants living in Hawaii reaches the longest average life expectancy among Japanese living outside Japan in 1980s. Since they moved from Okinawa, they had a custom to eat bean curd with bitter melon rich in antioxidants and enjoyed low salt diets cooked by steaming. They enjoyed eating daily fresh fish from the Pacific Ocean by mixing sesame or seeds containing antioxidants. They were always taking fruits from fruits rich in antioxidants. Their blood level of the vitamin E was twice as high as the Japanese. Our epidemiological studies, for the first time, the biomarkers of soy and fish intakes, 24-hour urinary isoflavones and taurine, were significantly inversely associated with the age-adjusted mortality rates of coronary heart diseases, indicating soy and fish intakes may prevent coronary heart disease. Our worldwide 24-hour urine analysis reveals the obvious characteristics of Japanese diet. 24-hour urinary biomarkers of soy and fish intakes, isoflavone and taurine by creatinine ratios were divided into 5 groups, each from small to large quantity intake, and all participants of the health examination in the world were divided into 5 by 5 in total 25 groups. And this graph indicates the ratio of the Japanese in each one of 25 groups. In the highest soy and fish taking groups, nearly 90% of our Japanese, indicating Japanese are commonly taking both soy and fish. In contrast, in the lowest soy and fish taking group, there were no Japanese. The data indicate Japanese protein intakes are so well balanced between soy and fish. This nutritional balance is apparently similar to the shape of Mount Fuji. Therefore, we further studied the effect of concomitant intake of soy and fish in the Japanese. Soy and fish intakes were divided into 3 groups: low, middle, and high intakes, according to 24-hour urinary isoflavones and taurine excretions. In the group consuming the highest amount of both soy and fish, folic acid in the blood was the highest. Folic acid is a kind of vitamin B important in the development of the nervous system in the baby and is expected to prevent dementia in the elderly. In the group taking the highest amount of soy and fish, HDL cholesterol levels were significantly higher in the group taking the highest amount of both, indicating both soy and fish intakes would prevent atherosclerosis and therefore decrease the mortality rate of coronary heart diseases. However, salt intake was significantly higher in the group taking the highest amount of the both soy and fish than in the group taking the lowest amount of both. Therefore, the enough intake of both soy and fish contribute to the healthy long life because of the low mortality rates of coronary heart diseases, but higher intakes of both from traditional diets result in high salt intakes, causing stroke. These results indicate the importance of low salt, soy, and fish diets for the extension of healthy life expectancy. Since our cooperative studies with the group of Professor Sin, chairman of this symposium, revealed Korean people were eating soy and fish with excess salt. Low salted soy and fish dishes are recommendable to both Japanese and Korean people. Moreover, we confirmed 24-hour urinary isoflavones from soy were inversely associated with body mass index worldwide, indicating isoflavones with weak estrogenic activity would control appetite, and common soy intakes would improve insulin resistance. Therefore, the more soybeans are eaten, the less the severe obesity. Moreover, cardiac study data also showed 24-hour urine histidine was inversely associated with body mass index, and histidine contained rich in red meat fish attenuates appetite when histidine is converted into histamine in the brain, as shown by animal experiments in early 2000. Therefore, Japanese diets contained both soy isoflavones and fish histidine reduced obesity. Since severe, I cannot show the histidine data. Sorry, it doesn't move. Could you please help me? Okay, this is a histidine inverse relationship between the body mass index and the histidine, urinary histidine excretion. Since severe obesity, BMI 30, is less in Japanese and Korean people, and this is regarded as the merit of the Asian diets, we finally compared Japanese diet with Mediterranean diets, which were regarded as the best diet in Euro-Western countries. The final answer to the question, which is better, Japanese or Mediterranean diet, may be given by the current pandemic of severe COVID-19 infection. This figure indicates the association of percentage of severe obesity with a mortality rate of COVID-19 per 1 million in 20 major countries in the world. The mortality rates of Japanese and Korean was actually very low, obviously lower than Mediterranean as European countries, as shown in the blue and red colors. The left figure shows the rate of the severe obesity in Japan is very low, number 182nd among over 190 countries and the regions in the world, as WHO data indicate. Therefore, the prevalence of less obesity seems to be associated with a lower mortality of COVID-19 in the Japanese. Since soy and fish, common diets in the Japanese, contain magnesium, and our worldwide quintile analysis of magnesium clearly showed the association. And magnesium in 24-hour urine inversely related the obesity. And magnesium associated with less obesity and less hypercholesterolemia. Higher magnesium level in the serum might attenuate inflammatory response and cytokine storm of severe COVID-19 to decrease the mortality rates. In conclusion, Mr. Chairman, Japanese and Korean diets have had the common merits containing fish and soy nutrients, which were first proven to prevent stroke in stroke-prone rats, and both diets have common demerits of excess salt intake. Japanese diets and also Korean diets are concluded as better diets among Asian countries because of less prevalence of obesity than in Mediterranean and Euro-Western diets. Therefore, low salt, soy, and fish-rich Japanese and Korean diets are recommended for extending healthy life expectancy with less obesity. This goal will be hopefully achieved by self-nutrition check and self-nutrition care by urine analysis. Thank you very much for your kind attention. Thank you.
Thank you, Professor Yamori. So very nice presentation. So we will discuss later in panel discussion session. So please, question.
Next topic would be presented by Professor Lee-Jung-koo from Chungbuk National University, Korea. She will talk about visceral fat reduction and improvement in blood pressure. Please, Professor Koo.
Thank you for your kind introduction. I'm Yu-Jung-koo from Chungbuk National University, and I'm happy to present today's my talk. My talk today is visceral fat reduction and improvement in blood pressure. As you can see, previous lecture, visceral fat. Can you help me? Okay. Sorry. As in the previous lecture, visceral fat and blood pressure is a very associated relationship, as well as metabolic diseases. Let's look at the effects of control BP in terms of how they have demonstrated significant visceral fat reduction. First, there are mainly 5 methods to measure visceral fat as followed. Even CT and MRI, considered gold standard for measurement of visceral fat, having protocol limitations, many of the studies I will discuss today use various tools to measure their central obesity or visceral fat and visceral adiposity in each studies. In Korean NHIS data showed that for every 1 increase in BMI, hypertension develops as high as 45% in people over 40 years of age. In particular, even with the same BMI, abdominal obesity, defined as waist circumference, is significantly associated with a higher risk for cardiometabolic risk, including hypertension. Looking at the relationship between body fat and hypertension reported about 2 decades ago, visceral fat, but not subcutaneous fat, was directly related to mean BP. This model predicted that an increase in visceral fat adipose tissue mass of 1 kilogram is associated with an increase in mean BP of 10 millimeter mercury. The putative mechanisms are discussed already, but as summarized, the putative mechanisms underlying obesity-related hypertension are considered complex and entailed interactions between renal, metabolic, and neuroendocrine pathways. That's why we focus the way of visceral fat reduction for improvement of visceral blood pressure in obese patients. And this slide showed that loss of weight is frequently associated with decreased BP. Relatively shorter-term studies indicated a 101 drop in BP and with weight loss, but long-term studies showed that they, based on the studies with follow-ups of 2 years old or more, demonstrated BP decreases less than this after weight loss. The models suggested that for 10 kilogram weight loss, decreases of 4.6 millimeter mercury and 6 millimeter mercury in diastolic and systolic blood pressure respectively may be expected, about half of that predicted from the shorter-term studies. Hypertension. This is an old study about the relationship between changes in BP and fat distribution after a 12-week low-calorie diet in 26 obese hypertensive middle-aged women in Japan. As shown in this study, on the effect of the ratio of visceral fat to subcutaneous fat on BP control using CT, it throws a message to us that it's more important to know where the weight loss occurred rather than just anthropometric changes. The subsets of case 1 and case 2 lost 10 and 12 kilograms during the study, respectively. Interestingly, the VS ratio in case 1 was lowered considerably, and in case 2 was unchanged even after weight reduction. Authors emphasized that a significant fall in BP was observed only in case 1. As reported by Korean researchers, when the visceral fat area of about 30 square centimeters decreased, systolic and diastolic BP reduced by 10.4 millimeter mercury and 5.6 millimeter mercury respectively. In this study, a lifestyle modification program and appetite suppressants were allowed if necessary. To date, several dietary patterns have been tried to control BP. The most representative diet among them is the DASH diet, which was developed to lower the risk of cardiovascular diseases. This balanced diet consists of fruit, vegetable, grains, low-fat dairy products, and nuts. The DASH diet reduced systolic BP by 5.5 more and diastolic BP by 3 millimeter mercury more than the control diet did. This was significantly higher effect than the diet rich in fruits and vegetables only. Subjects with hypertension had greater reduction in BP than subjects without hypertension. However, as in the case of all diet programs, the higher the adherence to DASH, the lower the visceral fat and lower BP. In parallel with an increased focus on climate changes and carbon footprint, the interest in plant-based diets and its potential health effects have increased over the past decade. That's why the vegan diet is all the rage these days. The effect of vegan diet over 12 weeks on cardiometabolic risk factors in overweight or type 2 diabetes patients was conducted. In comparison with the control diets, hemoglobin A1C and body weight, total and low density lipoprotein cholesterol was significantly lowered, but some parameters, including BP, did not show the big difference between diet patterns. Some of this effect, the macronutrient may be contributed to differences in the macronutrients composition and energy intake for reducing visceral fat in the vegan versus control diets. Therefore, more research is needed regarding vegan diets and cardiometabolic health based on changes in visceral fat. Then how about Mediterranean diet, one of the healthiest eating plans worldwide? The Mediterranean diet may be a useful tool to reduce body fat, especially when the Mediterranean diet is energy restricted, associated with physical activity, and with a follow-up or more than 6 months. This figure shows the most recent summary of the Mediterranean diet for BP control. Systolic BP adherence to was found to be lowered in the high adherence to this diet program, whereas no difference regarding diastolic BP were this group. Therefore, higher adherence to certain eating plan is needed for long-term cardiometabolic effects, but further research is also needed to this field due to the heterogeneous definition of a high and low adherence and the type of studies used. Healthy diet habits. The figure shows the most recent summary. Healthy diet habits is inevitable for weight loss, especially in visceral fat reduction. However, only some studies directly investigate the importance of visceral fat reduction and its effect on BP. This study was conducted with 168 participants in China. Changes in visceral fat was significantly associated with systolic and diastolic BP in men, but not in women after adjustment for the potential confounding factors. After multivariate adjustments, the association between visceral fat reduction and improvement in systolic and diastolic BP was increased in male subjects, indicating that association between visceral fat reduction and BP decrement in men was independent of body weight, BMI, and other potential confounders. However, such association was not found in females, which shows that gender difference may exist when exploring the effects of visceral fat reduction by diet plan on BP controls. In summary of the various healthy diets, this meta-analysis showed that the consumption of dietary patterns characterized by high consumption of fresh food, vegetables, whole grains, seeds, nuts, fish, and dairy, and low consumption of meat, sweets, and alcohol resulted in significant reductions in BP. Next, let's check out for anti-obesity drugs on BP control. In the case of short-term obesity drug, such as phentermine, one of the main side effects is an increase in BP, so I will not deal with it today. Some long-term anti-obesity drugs may have varying effects on BP. For instance, bupropion, naltrexone ER, reduces weight by approximately 4 to 5% and as also effective in visceral fat reduction, but can raise BP and heart rate, and is not recommended for use in hypertensive patients. So I will only look at liraglutide, a GLP-1 receptor agonist now. Although many studies showed that liraglutide, GLP-1 receptor agonists, had a positive effects on cardiometabolic and renal aspects, recent study investigate the effect of liraglutide on visceral fat reduction and multiple cardiometabolic parameters. Liraglutide showed a significant reduction in visceral fat by 12.5% compared to placebo, but they failed to show the significant differences in absolute systolic or diastolic BP changes between the liraglutide and placebo-treated group, according to the visceral fat reduction. Metabolic, also known as bariatric surgery, encompasses some of the fastest growing GI procedure worldwide, showing hopeful results in significant reduction of visceral fat and diabetes reduction in 10-year follow-up after round 1 gastric bypass surgery. The most powerful anti-obesity treatment modality so far, significant reduction in visceral fat continues for 10 years, and systolic and diastolic BP decreased by about 5 millimeter mercury at 10 years respectively. Another study shows also patients with reserved hypertension are characterized by high reduction in visceral adipose tissue. In summary, the global burden and severity of obesity and hypertension continue to increase. Visceral fat accumulation is associated with multiple mechanisms, including nervous system, RAS activation, as tissue dysfunction, so resulting in inflammation and also kidney pressure. So obesity-related hypertension can be resolved by weight loss, especially in visceral fat reduction. As we can combine this multiple modality to patients. Thank you for your attention.
Thank you so much, Professor Koo. We will have a discussion and a panel discussion. We'll move on to the next topic. The next topic will be presented by Jong-han Choi from Konkuk University of Korea. Professor Choi graduated from Jeonnam National University School of Medicine. Now he is working in the Division of Endocrinology and Metabolism in Konkuk University Hospital. His topic is what is the effective treatment of obesity in patients with hypertension. Please, Professor Choi.
Thank you for warm welcome and kind introduction, Professor Shin. It's a great honor to be here and talk at this annual meeting of Korean Society of Hypertension. Today, I will talk entitled, What is the effective treatment of obesity in patients with hypertension? As you know well, the prevalence of obesity is increasing sharply and becoming the most important non-communicable disease all over the world. Obesity is a major risk factor of hypertension and CV disease. Conversely, CVD is a major complication of obesity. Obesity accounts for much of the risk of primary hypertension through the several mechanisms: neurohormonal activation and systemic inflammation and renal dysfunction. Therefore, obesity treatment is essential for the prevention and treatment of cardiovascular and renal disease. Lifestyle modification, including healthy diet, increased physical activity, regular aerobic and muscle strengthening exercise, these are certainly and continuously recommended for the overall management of obesity. Furthermore, this healthy lifestyle is helpful in improving multiple risk factors of CVD simultaneously. In this meta-analysis, weight loss and blood pressure lowering efficacy by intensive lifestyle intervention were significant, and those have strong correlations. The systolic blood pressure decreased by 1.05 millimeters of mercury for every 1 kilogram weight loss, and diastolic blood pressure 0.92 millimeters of mercury for every 1 kilogram of weight loss. However, maintaining the efficacy of a lifestyle intervention is extremely hard for a long time. In a recent meta-analysis, the weight loss effect of intensive lifestyle intervention was maintained just 2.29 kilogram for 12 months. That is not a satisfactory result. Therefore, we need more options. Currently, and fortunately, there are remarkable advances in the pharmacological treatment for obesity. So I will talk focusing on this field. Possible therapeutic target of anti-obesity medications are increasing energy expenditure, decreasing food intake, and increasing energy loss through the GI tract or kidney. Among them, most of currently used anti-obesity drugs are targeting appetite regulation through the central nervous system. This table shows the mechanism of action of currently approved anti-obesity drugs. Except of orlistat, the main mechanism of drug is appetite regulation through the central nervous system. However, several anti-obesity drugs was withdrawn because they primarily increased the risk of psychiatric disorders or cardiovascular disease. The reason that these drugs increase the risk of CVD has been considered sympathetic activations. Therefore, the safety of obesity treatment for CVD is critical, and the European Medicine Agency requires CV outcome trial before approval of anti-obesity medications. Even among the drugs approved for long-term use, phentermine topiramate and naltrexone bupropion combination are associated with norepinephrine and dopamine actions. So they have the potential to increase the risk of CVD. This table shows the common adverse event and the precaution of currently approved anti-obesity medications. Among them, phentermine topiramate or naltrexone bupropion combinations are needed precaution in patients with uncontrolled hypertension or CVD. Fortunately, naltrexone bupropion showed safety in the CV outcome trial, and that was approved by the EMA. Phentermine topiramate CV outcome trial is also currently ongoing. In a clinical trial, phentermine topiramate also significantly lowered blood pressure for a long time by 7 years. Furthermore, in a post-hoc pooled analysis of data from the efficacy trial, phentermine topiramate slightly increased heart rate is about 1 BPM, but significantly decreased blood pressure. Therefore, there is no need to worry excessively about the risk of cardiovascular disease for these sympathomimetic anti-obesity drug. From now, I will introduce GLP-1 receptor analog anti-obesity medication with other mechanism than sympathomimetics. Currently, intestine and pancreatic hormones are promising target for anti-obesity drugs. Among the GI hormone, GLP-1 is at the forefront, followed by GIP, glucagon, and amylin analog. Liraglutide is the first human GLP-1 analog for the treatment of type 2 diabetes and obesity. Interestingly, liraglutide has different therapeutic indications depending on the dose. The low dose, 1.8 milligram, approved for the treatment of type 2 diabetes, and the high dose, 3 milligram, was approved for the treatment of obesity. The reason that the same drug has a different indication depending on the dose is due to the unique characteristics of GLP-1. At low dose, GLP-1 stimulates insulin secretion and inhibit glucagon secretion, thereby reducing blood glucose. However, At higher dose, liraglutide plays on the brain, suppressed appetite, and decreased food intake, consequently weight loss. However, liraglutide has lower efficacy for weight loss than phentermine topiramate. The reason that we pay more attention to the liraglutide is because of its CV benefit. In the RIDA trial, liraglutide reduced the 3-point MACE by 13%, CV deaths by 22%, although it was a low dose for the treatment of type 2 diabetes. Unfortunately, there is no CV outcome trial for high-dose liraglutide for treatment of obesity. In a post-hoc pooled analysis from the efficacy trial, liraglutide high dose showed a lower event of 3-point MACE compared with the placebo, despite there is no statistical significance. Until now, I introduced the efficacy of currently available drugs in Korea. However, the efficacy was disappointing, and it is difficult to achieve the goal of weight loss, more than 10 kilograms. So we still need more options. Next, I will introduce another GLP-1 receptor agonist, semaglutide, which is not yet available, but it was recently approved in Korea only for the treatment of type 2 diabetes. Semaglutide is more potent once-weekly GLP-1 analog that is resistant to degradation by DPP-4 enzyme and dissociate more slowly due to its strong binding to albumin. Similar to liraglutide, semaglutide has been also approved for the treatment of type 2 diabetes in low dose and obesity in high dose. Ozempic, low-dose semaglutide, was approved as an anti-diabetic drug in Korea this year, and this is expected to be used in practice and next year, maybe. In SUSTAIN program, low-dose semaglutide also showed significant weight loss. Similar to liraglutide, low-dose semaglutide also showed superior CV outcomes, reducing 3-point MACE 26%, and stroke by 39% in SUSTAIN 6 trial. Wegovy, high-dose semaglutide, has been not yet approved by Korean FDA, but this is expected to be available soon. In the STEP program, high-dose semaglutide shows about 15% weight loss at 68 weeks. This is more than twice the weight loss effect compared to all the drugs. In the STEP 6 trial, semaglutide also showed an equivalent weight loss effect, even in East Asia, including Japan and Korea. In STEP 8 trial, semaglutide showed nearly 3 times higher efficacy for weight loss compared to the liraglutide. Unlike liraglutide, semaglutide is currently ongoing CV outcome trial for high dose. To rule out the effect of glycemic improvement on CVD, only participants with obesity or overweight without type 2 diabetes were included. Although the mechanism of CV benefit of GLP-1 analog is not yet clear, many research results shows some evidence of the systemic effect through the improvement of glycemic control and lipid metabolism, and direct effect on the blood vessel and myocardium. Next, I will introduce tirzepatide, a GLP-1 and GIP dual agonist that has been recently approved by US FDA as a treatment for type 2 diabetes. This drug has been not yet approved by the FDA for the treatment of obesity. Tirzepatide is a dual agonist GLP-1 and another incretin hormone, GIP. Tirzepatide is also injected once weekly subcutaneously. In the recent announced SURMOUNT trial, tirzepatide shows a weight loss effect of more than 20% at 72 weeks. CV outcome trial is also currently in progress. In this slide shows the weight loss effect of intensive lifestyle intervention and anti-obesity drug introduced so far, and bariatric surgery. As these powerful methods of treating obesity are developed, we can understand that greater weight loss has greater clinical benefit. Next, cagrilintide, a once-weekly amylin analog, is also showing promise as an obesity management. In a recent phase 2 clinical trial, cagrilintide showed a weight loss effect of more than 10%, and a greater effect is expected because the plateau was not reached until 26 weeks. Rather than cagrilintide alone, we pay more attention to combination with semaglutide and cagrilintide combination. This combination therapy shows a weight loss about 18% at just 20 weeks. When you consider weight loss of tirzepatide was just 13% at this time point, and this has not yet reached the plateau, we expect that this combination has superior efficacy compared to tirzepatide. So far, we can see the weight loss effect, GLP-1 analog, semaglutide, GLP-1 and GIP dual agonist tirzepatide. Currently, the development of GLP-1 and GLP-1, GIP, and glucagon triple agonist is in progress. Recently, preclinical and small clinical study result of this triple agonist has been published in Cell Metabolism. This triple agonist showed a greater body weight reduction effect than tirzepatide, and additional increase in energy expenditure also, and have good safety profiles. Finally, I will summarize today's talk. Encouraging healthy lifestyle is the most crucial at any stage of obesity management. If your patient is unwilling to make lifestyle change, advice should be given prior to prescribing the anti-obesity medications. If this does not produce satisfactory results, we can try currently approved medications safely, even in patients with hypertension. Also, anti-obesity drugs that will be available soon will be more effective and safer. If that is not also enough, we can safely achieve a greater effect with bariatric surgery. Finally, we will see anti-obesity drugs that have a greater weight loss effect than those that we've talked about this, at this time. I'm really hoping that we can see the drugs as soon as possible. Thank you for your attention.
Thank you, Professor. So we have now open for questions or comments from excellent scholar panelists. So please, Professor Chung first.
Thank you. Thank you for great lectures. Obesity is an important pathophysiology, not only in hypertension, but also in heart failure. And in particular, the relationship between epicardial fat and heart failure with preserved EF, diastolic heart failure, is an interesting research area. Epicardial fat is involved in the development of cardiovascular disease by influencing various neuroendocrine and immune systems. And several studies reported that accumulation of epicardial adipose tissue is strongly associated with poor prognosis in patients with heart failure with preserved EF or mildly reduced ejection fraction. And we can suggest that the measurement of epicardial fat should be considered in patients with heart failure with preserved EF or mildly reduced EF, and as a part of real clinical workup. And Professor Chang, do you routinely check up or measure of epicardial fat in cardiac imaging study in your practice?
Thank you for your kind, very interesting question. I do not routinely measure the body fat composition, but as I prepared for this talk, I am now confident that I will almost routinely check the body fat CT or body fat index examinations. The epicardial fat we can see through the echocardiography usually. I think Dr. Joe is here today. He is an expert in epicardial fat, and I think that's the dysfunction as well. So yes, I think you can routinely check it from the echocardiography.
Thank you.
I appreciate all speakers' important presentation. Dr. Yamori's research was really inspiring. According to the WHO cardiac study, low salt and high fish soy intake is important for longevity. So the physiologic association between salt intake and stroke is well known. However, I wonder, how can isoflavone or taurine reduce the risk of coronary heart disease? This is my first question. And my second question is, it is hard to change our patients' eating behavior. So do you have any tips in clinic changing food behavior in your clinic? So first question is, how can isoflavone and taurine reduce the risk of coronary heart disease? The mechanism.
Yes, isoflavone actually affect the endothelial function, accelerate NO, nitric oxide production, so that vascular dilatation occurs. And as far as the taurine is concerned, the taurine suppresses the sympathetic tone, and also taurine accelerates the cholesterol excretion into bile acid, so that the beneficiary taurine affects hypertension and also hypercholesterolemia.
Yeah. And
the second question?
Yeah, second question is, how do you change your patient's food behavior? Do you have any tips for education, or are you performing any public campaign?
Yes, we tried some kind of intervention studies. We offered the high-risk participants the bread containing soy protein, soy protein and containing isoflavones. And also, we recommended the people taking the bread containing DHA or EPA, omega-3 fatty acids. And we could observe the effect. And the atherogenic index, the LDL by HDL ratio improved. Thank you.
Professor Yamori, excellent talk. Thank you very much. I like your talk a lot. Just a quick question, because your recommendation is that a low salt, high soy, and high fish diet and all that is good for long life. How would you answer food manufacturers, those who make food to sell, like soya sauce? They say to us, why are you targeting soya sauce when the Japanese live such a long life eating all that salt? Okay. Food manufacturers, the people who make soya sauce, say to us, why are you targeting soya sauce, the salt in soya sauce, when the Japanese and the Koreans have lived such long life with a high salt diet? How to answer that question?
You mean the soya sauce?
Yes.
We are using, your people, Korean people also using.
Yes. The manufacturers, the people who make soya sauce, ask, why do we need to reduce the salt when the Japanese and the Koreans eat a lot of salt and they live a very long life?
So that the soya sauce containing salt, so that the nowadays Japanese government recommended to decrease salt content of the soya sauce. And Of course, you may know the salt substitute, potassium, magnesium, such substitutes used. Yes.
Okay, never mind. Thank you.
Yes, Professor Ho, short question, please.
Yeah, thank you for lecturers, and I have a question to Professor Che. And now we are introduced by all those very promising agents for reducing fat or the weight. And for us in clinical daily practice, what kind of patient should we refer to you to use those agents? Like, what will be the optimal target patients?
Thank you for good questions. I talked about many pharmaceutical agents for treatment of obesity, but the most important thing is lifestyle modifications. So I think the best candidate to treat pharmaceutical treatment, the patients had been tried too many times for health diet and exercise, but the patients was failed only this method. So I also I don't also prescribe at first. So at least over 10 minutes I educate about the healthy lifestyle. Anti-obesity drugs can boost your motivation. So anyway, that is the best choice to treat anti-obesity drugs.
So lifestyle modification first, and if it fails,
Yes,
I can refer. Okay, thank you.
Thank you, our speakers, our distinguished panelists for hot discussion. So before closing this session, we have special ceremony for appreciation to Professor Yukio Yamori. Please.
Plaque of appreciation, Professor Yukio Yamori. The deepest appreciation for your dedication and contributions to the Korean Society of Hypertension as an invited speaker of Hypertension Seoul 2022 in conjunction with the 57th scientific meeting of the KSH, November 4th, 2022. Korean Society of Hypertension.
Thank you very much indeed.
할까요? 네, 여러분 반갑습니다. 런천 심포지움을 시작하겠습니다. 런천 시스템은 셀트론 제약과 동아 SG에서 후원하는 심포지움입니다. 우리가 그 CVD 리스크를 감소시키기 위해서 인텐시브하고 콘시스턴트한 BP 컨트롤이 중요한데 이것을 잘 달성하기 위해서 이 회사에서 발매하는 이달비의 효과에 대해서 알아보는 시간입니다. 먼저 인텐시브 쪽에는 아마 경희의대 정혜문 교수님께서 발표해 주실 것이고요. 아마 콘시스턴트 쪽에는 한림의대 이숙진 교수님께서 아마 강연을 해 주실 것 같습니다. 먼저 첫 번째 연자이신 한림의대 이숙진 교수님을 소개해 드리겠습니다. 이숙진 교수님은 96년도에 한양대를 나오시고 주로 에코 쪽으로 연수를 많이 다녀오셨고요. 지금 아마 심장 이식까지도 관여하시는 그런 일을 하고 계십니다. 2022년 3월까지 부천 세종병원에 근무하시다가 올해 4월부터 한림대학교 동탄성심병원에 근무하고 계십니다. 이수진 교수님께서 오늘 Importance of 24시간 BP Control for Reducing CVD Risk라는 제목으로 강의를 해주시겠습니다. 이숙진 교수님 부탁드리겠습니다.
예, 감사합니다. 안녕하십니까? 예, 한림대학교 동탄성심병원 순환기내과 이숙진입니다. 이렇게 그 큰 학회에 초대해 주셔서 고혈압 학회와 그다음에 이제 셀트리온 그리고 동아대학에 감사드립니다. 오늘 제가 말씀드릴 내용은 그 24시간 혈압 조절에 대해서 어떻게 하면은 좀 더 잘할 수 있을까에 대해서 말씀을 드리겠습니다. 순서는 먼저 이제 24시간 혈압에 대해서 혈압 조절에 대해서 말씀을 드리고 그다음에 그 모닝 BP 서지 그리고 녹터널 BP 그다음에 BP 베리어빌리티에 대해서 간단하게 말씀을 드리겠습니다. 먼저 24시간 혈압은 그 여러 가지 리뷰와 그런 그 전문가들은 다음과 같은 스텝으로 24시간 혈압을 좀 더 잘 조절할 수 있다고 권장을 하고 있습니다. 먼저 그 아침 혈압을 잘 조절을 하고 그 다음에 그 야간 혈압, 야간 고혈압이 있는지 확인하고 그것을 조절하고 그리고 모닝 서지를 컨트롤하는 것을 권장을 하고 있습니다. 이 세 가지 단계를 잘 하면 이제 24시간 혈압 조절이 잘 될 것으로 생각이 되는데요. 24시간 혈압은 그 여러 가지 우리가 이렇게 잘 조절을 해야 되는 이유가 다음과 같이 있습니다. 먼저 이제 저희가 보통은 이제 그 진료실에서 혈압을 재가지고 그걸 가지고 이제 환자분이 이제 잘 되는지 안 되는지 이렇게 하지만 약을 조절을 하지만 사실 굉장히 부족하다는 걸 저희도 잘 알고 있습니다. 뭐 몇 달에 한 번 와가지고 한번 재는 그런 혈압은 그 일단은 화이트 코트 하이퍼텐션의 그런 위험도도 있고 그 다음에 마스크 하이퍼텐션이라고 실제로 화이트 코트 하이퍼텐션과 반대로 진료실 혈압은 괜찮지만 실제 혈압에서는 높은 고혈압이 있는 그런 경우도 놓칠 수 있고요. 그 다음에 이제 그 원래 가지고 있는 그런 그 혈압의 변동성을 체크하기 어렵습니다. 그리고 야간 혈압도 당연히 체크하기 어렵고 아침에 모닝 서지도 체크하기 어렵습니다. 그래서 이런 것들을 잘 조절하기 어렵기 때문에 그러니까 이런 것들이 그 클리닉 BP에 한 번 재는 거 가지고는 조절이 어렵기 때문에 최근 가이드라인에서는 24시간 혈압 모니터링 그리고 홈 BP를 적극적으로 권장을 하고 있습니다. 24시간 혈압 측정 그리고 홈 BP는 뭐 번거로운 면도 있고 그렇지만 여러 가지 이런 그 24시간 혈압에서 우리가 놓칠 수 있는 이런 것들을 알 수가 있고 또 그 예후에 있어서도 클리닉 BP에 비해서 좀 더 좋은 예후를 반영할 수 있는 것으로 연구 결과가 많이 나와 있습니다. 그래서 이제 그 24시간 동안 이런 것들을 잘 조절을 해서 이렇게 혈압이 변동이 많지 않고 꾸준히 잘 조절이 되게 하는 것이 굉장히 중요하겠습니다. 그러기 위해서 또 한 가지 이제 우리가 생각해야 되는 거는 뭐 일단 약의 효과가 얼마나 잘 지속이 되느냐 하는 건데요. 우리가 TP 레이쇼라는 트로프 픽 레이쇼를 가지고 이 약이 얼마나 그 방광기가 길고 효과가 오래 지속되는지 이제 보는 지표인데, 다음과 같이 우리가 이제 대표적인 ARB들을 이렇게 보면 그 TP 레이쇼가 많이 좀 차이가 나는 것을 알 수 있습니다. 물론 제일 짧은 건 맨 밑에 있는 캡토프릴이고요. 그 외에도 그 여러 가지 약들이 이제 차이가 많이 나는 것을 알 수 있고, 특히 이제 그 점점 더 최근에 나온 약들일수록 TP 레이쇼가 길고 개선이 된 것을 볼 수 있습니다. TP 레이쇼가 1에 가깝다는 얘기는 결국은 이제 이 그 트러프 레벨이 피크 레벨하고 큰 차이가 없다는 얘기이기 때문에 효과가 지속될 것으로 생각을 할 수 있습니다. 그 이제 이랄비, 즉 그 아질살탄은 그 우리가 이제 많이 쓰고 있는 발살탄 그리고 올메살탄의 고용량들과 비교를 해 보았는데, 발살탄 320ml 그리고 올메살탄 40ml 등 그 맥시멈 도수와 비교했을 때도 그 아질살탄 40ml, 80ml 공이 좀 더 그 각 모든 시간대에서 더 혈압 강화 효과를 더 효과적인 혈압 강화 효과를 보여주었습니다. 그리고 이제 이달비와 같이 이렇게 병합되어 있는 클로로살리돈은 우리가 이제 더 흔하게 지금까지 많이 써왔던 이제 하이드로클로로사이아자이드랑 비교를 해봤을 때 비슷한 약이지만 더 반감기가 길고 효과가 더 그 강력한 것을 보여주는 약입니다. 그리고 이제 그 두 가지가 합쳐진 그 아실살탄, 그다음에 클로로살리돈, 그다음에 복합제와 올메살탄과 하이드로클로로사이아자이드가 합쳐진 많이 쓰는 그 약을 비교했을 때 24시간 동안 혈압 강화 효과가 더 강력한 것을 보여주었습니다. 그리고 우리가 이제 그 진료실에서 요새 많이 보는 메타볼릭 신드롬에 대해서 잠깐 말씀을 드리면, 이 메타볼릭 고혈압은 메타볼릭 신드롬의 굉장히 중요한 팩터입니다. 그 고혈압 환자들 중에는 이제 메타볼릭 신드롬이 있는 환자들도 많이 있고요. 그리고 메타볼릭 신드롬이 있는 환자들 중에도 고혈압이 굉장히 많이 있습니다. 이제 이 메타볼릭 신드롬은 여러 가지 그 심혈관계 위험도가 높은 것은 다 잘 알고 계실 것입니다. 특히 근데 이제 메타볼릭 신드롬 환자가 왔는데 뭐 당도 높고 고지혈증도 있고 비만도 있고, 그런데 혈압이 유난히 괜찮다 이런 경우가 가끔 있는데요. 실제로 정말 괜찮은지 한번 체크를 해볼 필요가 있다고 생각이 됩니다. 이 메타볼릭 신드롬 환자는 그 마스크 하이퍼텐션도 빈도가 높고, 그다음에 그 non-diper 환자도 굉장히 빈도가 높고, 아침에 BP 서지가 높은 경우도 많다고 합니다. 그래서 실제로 클리닉에 와서 한번 잰 혈압이 괜찮다 하더라도 이 메타볼릭 신드롬 환자는 24시간 고혈압이나 홈 BP 이런 적극적으로 활용을 해서 혈압이 실제로 높지 않은지 체크를 해봐야 됩니다. 그리고 이제 저희가 우리 이제 혈압계로 이렇게 자동 혈압계 오실로메트리 같은 걸로 재면은 시스톨, 다이아스톨 그리고 밑에 또 민BP가 나오게 됩니다. 그 민BP 보통 그냥 이렇게 안 보고 지나가는 경우가 많은데요. 근데 실제로 이 연구에서 보면은 우리 민BP도 그 이 카디오바스큘러 리스크를 리스크의 위험도를 반영해주는 좋은 지표라고 합니다. 그래서 이 민BP가 92 정도 이상이 되면서부터는 해저드 레이쇼가 이렇게 증가하는 것을 보여주었습니다. 그리고 이 연구에서는 그 민BP와 24시간 민BP와 24시간 수축기 혈압을 이렇게 플러스를 했을 때 두 개가 다 높은 경우에 굉장히 카디오바스큘러 10년 위험도가 굉장히 높아지는 것을 보여주어서 24시간 혈압 또는 뭐 클리닉에서 재는 혈압이라도 우리가 민BP도 유의하게 보는 것이 좋겠습니다. 그래서 요약을 하면 그 24시간 혈압을 굉장히 그 스무스하게 변동이 별로 적게 유지하는 것은 굉장히 중요한 일이겠습니다. 그러기 위해서는 BP 베리어빌리티 이런 것도 신경을 많이 써야 되고요. 또 그렇게 하기 위해서는 가능하면 TP 레이쇼가 높은 롱액팅 안티하이퍼텐시브를 선택을 하는 것이 좋겠습니다. 그리고 메타볼릭 신드롬 환자 같은 경우는 혈압이 있는지를 잘 체크를 하고 혈압이 고혈압이 있다면은 롱액팅인 약 것과 그다음에 이제 컨비네이션 약제를 적극적으로 활용을 하는 것이 예후를 개선시키는 데 도움이 되겠습니다. 두 번째로 모닝 BP 서지에 대해서 말씀드리겠습니다. 모닝 BP 서지는 이제 여러 가지 이제 심혈관계 사고들, 뭐 급성 심근경색 아니면 뇌졸중 그런 것들이 이제 주로 아침이나 오전에 많이 발생하는 것이 알려지면서 이쪽 혈압과 관련이 있을 것으로 생각이 되고 많이 연구가 되었는데 다음과 같이 여러 개의 그런 크라이테리아가 있습니다. 그래서 모닝 BP 서지는 여러 가지 형태로 이렇게 우리가 체크를 하는데요. 연구마다 좀 차이가 많이 있기 때문에 실제 이제 똑같은 연구를 다 비교하기가 조금 어려운 점이 있긴 합니다. 대표적인 게 이제 슬립 트로프 서지라고 해서 아침에 일어나서 한 2시간 동안의 혈압과 그다음에 이제 수면 동안의 가장 낮은 혈압 한 3-4개의 평균을 차이를 본 것이 슬립 트로프 서지가 되겠고, 프리웨이킹 서지는 아침에 한 2시간 동안의 혈압과 기상하기 직전에 한 2시간 동안의 혈압을 차이를 본 것이 되겠고요. 라이징 BP 서지는 일어나기 직전 혈압, 그다음에 일어나서 눈 뜨고 기상하기 직전에 혈압의 차이를 본 것입니다. 이렇게 좀 다양한 걸 가지고 연구들이 되어 있습니다. 이 모닝 BP 서지가 일어나는 원인으로는 여러 가지가 다 관여를 하는 것으로 생각이 됩니다. 환경적인 요인, 뭐 스트레스라든가 뭐 흡연, 그다음에 음주, 그다음에 기온, 그다음에 염분 섭취 이런 것들도 관련이 될 것으로 생각이 되고, 그다음에 노화와 뭐 그 외에 당뇨, 고지혈증, 그다음에 또 이제 중요한 것 중에 하나가 이제 수면 무호흡증도 관련이 있는 것으로 생각이 되고, 이런 것들에 의해서 이런 엔도셀리알 디스펑션, 아테리얼 리모델링, 그다음에 바로 리플렉스 디스펑션, 아테리얼 스티프니스 이런 것들이 문제가 발생을 해서 발생을 하는 것으로 생각이 되고, 또 결국에는 이제 심파세틱 너브 시스템의 작용을 항진시켜서 이런 모닝 서지가 일어나는 것으로 생각이 됩니다. 이런 것들에 의해서 이 모닝 BP 서지는 이 심혈관계 위험도를 높이는 것으로 생각이 됩니다. 이 연구는 이제 일본의 카리오라는 분이 이제 처음에 모닝 서지를 가지고 보고를 한 논문인데, 모닝 서지 그룹과 모닝 서지가 없는 그룹을 비교를 했을 때 세레브랄 임팍, 그다음에 스트로크 이런 것들이 위험도가 증가하는 것을 보여주었습니다. 그 이후에도 이제 이 모닝 서지를 가지고 연구한 논문들이 많이 나왔는데요. 또 여기는 이제 인터내셔널 데이터를 가지고 한 것을 보면은 서지가 높은 90% 이상인 환자군과 90% 이하인 군을 오랫동안 이렇게 경과를 보았더니 이렇게 토탈 모틸리티와 카디오바스큘라 이벤트가 차이가 많이 나는 것을 보여주었습니다. 그래서 모닝 서지가 이런 심혈관계 위험도를 높이는 것으로 받아들여지고 있습니다. 또 이 논문에서는 역시 모닝 서지를 가지고 연구를 했는데, 여기에서는 이렇게 올커즈 모탈리티, 그다음에 넌 카디오바스큘라 모탈리티, 그리고 카디오바스큘라 모틸리티, 코로너리 이벤트 이런 것까지 다 이제 리스크가 높아졌는데, 이제 세레브로바스큘라 액시던트에 대해서는 리스크가 의미 있게 나오진 않았습니다. 그래서 이 연구에서는 지금까지 우리가 이제 알고 있던 거랑은 조금 다른 결과라는 이 이유는 이게 인터내셔널 스타디고 아마 이제 아시안들이나 이런 사람들은 이게 좀 더 높을 것으로 생각이 된다고 하였습니다. 그래서 이제 이 모닝 서지가 결국은 이제 이런 타겟오겐 데미지나 캐로티드 아테로스클레로시스, 키드니 알부미누리아, 아테리얼 스티프니스 이런 것들을 다 유발을 하는 것으로 생각이 되고, 그래서 이제 스트로크의 위험도도 올라가고, 특히 이제 아시안에서는 헤모라직 스트로크의 위험도가 더 올라갈 것으로 생각이 되고, 그 외에도 올커즈 모텔리티, 메이저 카디오바스큘라 이벤트, 코로나 이벤트까지 다 높일 수 있는 것으로 받아들여지고 있습니다. 근데 이제 이달비 아질살탄과 칸테살탄을 이렇게 비교를 해보면 칸데살탄 8mg에서 12mg와 아지살탄 20에서 40mg를 이렇게 비교를 했을 때 24시간 동안 더 효과적으로 혈압 강화가 이루어졌고 그리고 모닝 서지도 더 효과적으로 조절이 되는 것으로 생각이 보고가 되었습니다. 여기에서도 얼리 모닝에 보면은 그 아질살탄이 더 혈압 강화 효과를 더 효과적으로 하는 것을 보여주었습니다. 그리고 아까 말씀드린 그런 모닝 서지 두 가지 그런 그 방법으로 보았을 때도 그 아질살탄이 칸데살탄에 비해서 더 효과적인 혈압 강화를 보였습니다. 세 번째로 이제 야간 혈압에 대해서 말씀드리겠습니다. 야간 혈압은 역시 마찬가지로 여러 가지 그 팩터가 다 이제 관여를 하는 것으로 생각이 됩니다. 교감신경계의 자율신경계의 그런 임밸런스, 그다음에 볼륨 리텐션, 그다음에 그 여러 가지 슬립 에이프니아, 그 외에도 여러 가지 그 디프레션 또는 어떤 스트레스 이런 것들도 관여를 다 할 것으로 생각이 됩니다. 유전적인 요인도 관여를 할 것으로 생각이 돼서 혈압이 야간에 더 떨어지지 않고 계속 지속적으로 올라가 있거나 아니면 오히려 더 올라가는 그런 상태를 말하겠습니다. 그래서 이거 야간에 혈압이 떨어지는 걸 우리가 이제 그 정상적인 패턴이고 그 디퍼라고 얘기를 하는데요. 이 디퍼는 이제 그 데이타임 혈압에 비해서 야간 혈압이 10%에서 20% 감소하는 것을 이제 정상적인 반응으로 보고 제일 이제 레퍼런스로 잡을 수 있는데 이거보다 더 많이 떨어지는 거를 이제 익스트림 디퍼, 그다음에 10% 미만으로 떨어지는 거를 이제 넌 디퍼, 그다음에 오히려 더 야간 혈압이 올라가는 것을 리버스 디퍼라고 이렇게 얘기를 하는데 그 이 넌 디퍼는 이 디퍼를 비해서 볼 때 이런 그 엔도간 데미지가 더 높은 것으로 알려져 있고 특히 더 이제 리버스 디퍼 같은 경우는 더 위험도가 높은 것으로 생각이 됩니다. 이 익스트림 디퍼도 좀 약간 디베이트가 있지만 디퍼에 비해서는 퍼퓨전 같은 것이 감소하면서 좀 더 예후에 안 좋은 영향을 줄 것으로 생각을 하고 있습니다. 그래서 아까 그 네 가지 디퍼의 이 형태를 비교를 해보면 확실히 그 리버스 디퍼, 라이저라고 얘기하는 리버스 디퍼의 경우에 이스케미아, 세레브랄 이스케미아, 세레브랄 헤머리지 위엔트가 훨씬 더 높은 것으로 되어 있습니다. 그래서 이렇게 그 토탈 모탈리티, 카디오바스큘러 모탈리티, 카디악 하이퍼트로피, 세레브랄 인팍션, 마이크로알부민 이런 것들 모든 카디오바스큘러 리스크가 더 높아지는 디퍼와 리버스 디퍼에서 높아지는 것으로 넌 디퍼와 리버스 디퍼에서 더 높아지는 것으로 생각이 되고 이 연구에서는 그 계속 지속적으로 디퍼가 아닌 넌 디퍼 서스테인 하이퍼텐션 또는 이제 그 우리가 잘 몰랐지만 마스크 넉터널 하이퍼텐션 환자에서 그렇지 않은 디퍼이면서 이제 낮에만 혈압이 높은 환자 아니면 이제 혈압이 잘 조절되는 그런 환자들에 비해서 팔로우업 기간 동안 서바이벌 엑센트가 카디오바스큘러 엑센트가 더 높아지는 것을 보여주었습니다. 역시 마찬가지로 이 서스테인 하이퍼텐션과 마스크드 넉터널 하이퍼텐션이 이 데이타임 하이퍼텐션이나 이 혈압 조절이 잘 되는 환자에 비해서 카디오바스큘러 리스크가 높아지는 것을 보여주었습니다. 이 연구는 이제 일본 사람들이 그 실제로 한밤중에 그냥 보통은 이제 우리가 나이타임 BP를 보기 위해서는 24시간 혈압을 측정을 하는데 이 사람들은 이제 한밤중에 환자가 자기가 일어나서 스스로 이제 홈 BP를 재서 그걸 가지고 연구를 했더니 그렇게 해서 측정한 것도 역시 그 나이타임 하이퍼텐션은 카디오바스큘러 리스크를 더 높여주는 것을 보여준 연구입니다. 그리고 이제 여기서는 이제 그 아질살탄과 칸데살탄을 비교했을 때 그 넌데핀 그룹과 디핀 그룹에서 모두 그 SBP와 SBP를 다 더 그 아질살탄이 더 효과적으로 감소시켜 주는 것을 나이타임 BP도 감소시켜 주는 것을 보여주었습니다. 마지막으로 BP 베리애빌리티에 대해서 말씀드리겠습니다. BP 저희가 이제 외래에서 진료를 보면 환자분들이 이제 혈압이 변동이 굉장히 많고 지난번에는 높았는데 오늘은 낮고 뭐 이런 경우도 많고 굉장히 그 변동이 많아서 뭐 어떤 걸 기준으로 잡아야 될지 좀 그럴 때도 있는데 그 이 베리어빌리티가 굉장히 높은 그런 환자들은 이렇게 토탈 모탈리티, 그다음에 코로나리 하트 디지즈, 스트로크, ESRD 이런 그 엔도간 데미지가 더 높은 것으로 알려져 있습니다. 그래서 이거는 에코 파라미터인데 에코 파라미터도 그 베리어빌리티가 높은 환자군일수록 더 안 좋은 것으로 나와 있고, 역시 이런 그 카디오바스큘러 디지즈, 코로너리 하트 디지즈, 스트로크, 하트 페일리어, CKD 다 그 이 베리어빌리티가 높을수록 더 증가하는 것으로 알려져 있고, 컴포지트 엔드포인트도 마찬가지고 이 SBP의 그 스탠다드 데비에이션이 10mm 이상 차이가 날수록 이런 질병들이 다 이렇게 리스크가 높아지는 것을 보여주었습니다. 이거는 이제 중국에서 나온 논문인데 아시안들을 가지고 했을 때 아시안에서는 특히 서구에 비해서 더 이런 위험도가 높아지는 것으로 보여주었습니다. 마찬가지 데이터입니다. 그래서 이거는 우리나라에서 나온 데이터입니다. 우리나라에서도 역시 그 베리어빌리티를 가지고 카디오바스큘러 아웃컴을 봤는데 이 스탠다드 데비에이션이 낮은 군과 높은 군을 10 이상 되는 군과 이하 되는 군을 비교했을 때 갈수록 그런 그 서바이벌이 감소하는 것을 보여주었고, 그 각 그 세 개로 나누어서 그 비교를 했을 때도 역시 그 이 스탠다드 데비에이션이 높은 군일수록 서드 터타일일수록 이 리스크가 더 높아지는 것을 보여주었습니다. 이렇게 BP 베리어빌리티가 많이 증가하는 이유도 역시 나이가 드신 분들이 더 많이 생기고요. 그다음에 혈압이 높은 사람들, 그다음에 당뇨나 뭐 메타볼릭 신드롬 있는 환자들, 그다음에 술 담배 많이 하시고 이모셔널하게도 좀 언스테이블 하신 분들, 그다음에 염분을 많이 섭취하시는 분들, 그다음에 이제 수면 잘 못 취하고 뭐 이런 분들, 특히 이제 또 환경의 영향도 뭐 스트레스를 많이 받는 월요일이나 아니면 겨울이나 이런 경우에도 좀 더 증가하는 것으로 알려져 있습니다. 그래서 이 BP 베리어빌리티는 사실 우리가 간과하는 경우가 많고 사실 이걸 다 체크하기도 어렵고 그렇습니다. 하지만 이상의 논문들에서 이 베리어빌리티가 실제 카디오바스큘러 리스크를 반영하는 하나의 지표가 될 수 있다는 것은 우리가 꼭 기억해야 될 것 같습니다. 그리고 가능하면 이것들을 감소시키는 쪽으로 약을 조절을 하고 환자와 이렇게 라이프스타일 모디피케이션을 하는 쪽으로 도와드려야 될 것 같고, 이런 것들이 결국은 이제 BP 베리어빌리티가 타겟 오건 데미지랑 관련이 있다는 것을 꼭 알고 있어야 될 것 같습니다. 그래서 이제 아지살탄과 역시 이제 그 아지살탄을 가지고 비교를 했을 때 이렇게 이 스탠다드 데비에이션과 그 베리어빌리티 코에피션트를 이렇게 보면 이 다른 ARB를 쓰다가 이제 아지살탄으로 바꿔서 이렇게 그 BP 베리어빌리티를 보니까 이렇게 감소를 했다, 이런 논문들도 있습니다. 그래서 이 아지살탄이 이제 롱액팅 그리고 이제 모닝 서지도 좀 감소시키고 그러면서 베리어빌리티도 좀 감소시키는 것으로 생각이 됩니다. 그것도 이제 SBP와 다이스톨릭 BP를 그 이제 다른 ARB에서 아지살탄으로 바꿨을 때 그 이런 그 디퍼런스, 아침 저녁 그런 베리어빌리티 디퍼런스를 감소시켜 주는 것으로 이제 연구가 있고요. 그다음에 세이프티에 뭐 이런 그 세이프티에 있어서도 다른 ARB랑 비교, 특히 발설탄, 얼매설탄과 비교를 했을 때 크게 문제는 없었고, 그 이제 뭐 많이 들으셨겠지만 이런 그 제조 과정 중에 생기는 이런 불순물들 때문에 몇 개의 ARB가 그 좀 리콜도 되고 이제 주의가 이렇게 그 주의 사항이 나가고 했는데요. 근데 이제 이게 저는 이제 이거에 대해서는 잘은 모릅니다. 근데 그 이 ARB에 있는 어떤 그런 환원기가 그 문제가 좀 더 유발을 할 수 있다고 되어 있는데, 이제 그 ARB에는 그런 그 기가 아닌 다른 것인 것으로 이렇게 다른 데는 다 이런 테트라졸 링이 이렇게 있는데 아지살탄은 다른 이런 게 있고, 이게 그 이제 그 AT1 리셉터에 좀 더 강력한 그 친화력을 가지고 라이포필릭한 캐릭터를 보여주면서 흡수도 잘 되고 효과를 더 좀 강력하게 보여주는 것으로 생각되고, 아까 말씀드린 이런 그 부작용의 발생도 좀 더 감소시켜주지 않을까 하는 그런 보고들이 있습니다. 그래서 마지막으로 썸머리 말씀드리겠습니다. 결국 우리가 이제 혈압을 조절을 할 때 뭐 그냥 환자 아침에 와서 클리닉 혈압 쟀는데 괜찮으면 계속 이제 똑같이 이렇게 약을 처방을 하게 되는 경우가 많은데, 실실 바쁘고 진료실에서 그러다 보면 그렇게 되는 경우가 많은데, 조금 더 한 번 더 좀 생각을 하시고, 만약에 이제 우리가 정기적으로 뭐 알부민 유리아도 체크하고 LVH가 있는지도 체크하고 뭐 IMT도 체크하고 하면서 우리가 생각했던 것과 다른 그런 결과를 보인다면 이 환자분이 아침 혈압은 조절이 잘 되고 있는지, 또 나이타임 혈압은 잘 조절되고 있는지, 그리고 모닝 서지는 없는지, 이런 것들을 한 번씩은 체크를, 그리고 베리아빌리티는 높지 않은지 이런 것들을 체크를 해보는 게 좋겠고, 그 체크하는 방법은 이제 그 24시간 혈압 측정 또는 홈 BP 측정, 이런 걸 적극적으로 이제 환자한테 설명을 하고 권장을 해서, 환자들이 굉장히 불편해하고 싫어하고 하지만 잘 설득을 해서 하는 것이 중요하겠습니다. 그리고 또 이제 롱액팅, 효과가 좋은 약을 잘 골라서 컨비네이션 테라피를 잘 해서 효과가 지속적으로 있을 수 있게 하는 것이 좋겠습니다. 그래서 다시 한번 말씀드리면 24시간 동안 혈압을 잘 조절하는 방법은, 첫째는 아침 혈압을 조절을 잘 하고, 그리고 야간 혈압 조절을 하고, 아침에 혈압이 상승하는 모닝 서지를 잘 잡는 것이 24시간 혈압을 스무스하게 잘 조절하는 방법이 되겠습니다. 감사합니다.
네, 이숙진 교수님 훌륭한 강의 감사드립니다. 그동안 우리는 어떻게 보면 혈압을 정지화면으로 치료를 했습니다. 병원에서 측정한 진료실 혈압만 측정했지만, 아시는 것처럼 혈압은 하루에도 수백만 번이 나오죠. 쉽게 말해서 동영상입니다. 이 동영상을 보고 우리가 치료를 해야 되는데, 그동안 정지화면으로 치료하다가 이숙준 교수님께서 말씀하신 것처럼 이렇게 그 모닝 BP라든지 모닝 서지라든지 또 BP 베라빌리티를 잘 조절해야만 환자에게 시브 리스크를 확실히 줄일 수 있다는 것을 또 강조해 주셨습니다. 그러기 위해서는 우리가 그 숏액팅 드럭보다는 TP 레이시오 높은 롱액팅 드럭을 사용하는 것이 전략적으로 좋다는 이야기도 함께 해 주셨습니다. 감사합니다. 두 번째 연재를 시작하겠습니다. 두 번째 연재는 경희대 정혜문 교수님께서 발표해 주시겠습니다. 인텐시브 트리트먼트 스트래티지에 대해서 말씀해 주시겠습니다. 정혜문 교수님은 2008년도에 연세대를 졸업하시고 2016년부터 경희의대에서 근무하시면서 심초음파 쪽에 많은 일을 하고 계신 분이십니다. 오늘 좋은 강의 부탁드리겠습니다.
네, 선생님 소개 말씀 감사드립니다. 안녕하십니까. 저는 경희의대 심장내과에서 근무하고 있는 정혜문입니다. 오늘 저는 고혈압에서 인텐시브 트리트먼티지에 대해서 말씀드리도록 하겠습니다. 아젠다는 다음과 같고, 첫 번째로 BP 타겟의 변화에 대해 말씀드리겠습니다. 고혈압의 정의는 아시다시피 미국, 유럽 그리고 한국에서 나온 가이드라인은 저희가 많이 참고하는 가이드라인들인데요. 2017년에 ACC/AH 가이드라인에서 고혈압의 기준 스테이지 1 하이퍼텐션의 기준을 SBP 130, 다이어스토릭 BP 180으로 낮추어서 굉장히 이제 화제가 된 적이 있습니다. 그래서 이때 스테이지 1 하이퍼텐션을 미국에서는 130에 80으로 정의했고, 하지만 그 다음에 나온 ESC 가이드라인에서는 여전히 그레이드 1 하이퍼텐션을 140에 90, 그리고 한국에서 나온 2018년 대한 고혈압학회 진료 지침에서도 여전히 140에 90을 고혈압의 정의로 하고 있습니다. 그래서 이 고혈압의 정의는 이렇게 되는데, 그렇다면 타겟을 2017년에 이때 이제 130에 80으로 기준을 낮췄던 미국 가이드라인에서 보시면은 논 CVD 또는 10year AS CVD 이벤트 리스크가 10% 이상인 이제 하이 리스크 환자에서는 130에 80 이하로 낮출 것을 클래스 1으로 권고를 하고 있고, 하지만 그냥 하이퍼텐션에 다른 에디셔널한 인크리스드 리스크 팩터가 없더라도 클래스 2B로 130에 80을 타겟으로 하도록 이렇게 레코멘드를 하고 있습니다. 2018년 그 다음에 ESC 가이드라인에서는 처음에 목표는 고혈압 치료의 목표는 140에 90으로 하되, 톨러러블하다면 130에 80까지로 이제 타겟을 할 수 있다라고 클래스 1으로 레코멘데이션을 하고 있고, 65세 미만의 환자들에서는 BP 레인지를 120에서 129, 130 미만으로 타겟을 하도록 하고 있고, 65세 이상의 경우에는 130에서 139 사이, 즉 130은 넘으면서 140 미만으로 조절을 하도록 레코멘드를 하고 있습니다. 다이아 BP 타겟도 제시를 하고 있는데 80 미만으로 컨시더 하도록 제시를 하고 있습니다. 그렇다면 국내 고혈압 가이드라인에서는 2018년에서 이제 2022년에 약간의 이제 업데이트와 이제 조금 모디파이가 되었는데요. 큰 변화는 없고 합병증이 없는 고혈압에서는 중저위험도 고혈압은 여전히 140에 90을 타겟으로 하고 있고 올드에이지에서도 140에 90을 타겟으로 하고 있습니다. 그리고 하이 리스크 환자에서 130에 80으로 하고 있고 당뇨병에서도 이제 위험도에 따라서 타겟을 조금씩 달리하고 있고 합병증이 동반된 심혈관 질환이 있는 경우는 130에 80 그리고 CKD 스트로크 환자에서도 조금씩 이제 세분화해서 권고를 하고 있고 여기 권고 수준과 근거 수준을 같이 추가를 하였습니다. 그래서 노인 환자에서 앞서 한국에서 140에 90으로 타겟을 하였는데 이 고혈압의 기준을 낮춘 2017년 미국 가이드라인에서는 노인에서도 65세 이상에서도 SBP 130 미만으로 권고를 하고 있고 ESC 가이드라인에서는 말씀드렸다시피 130에서 140으로 65세 이상의 경우 권고를 하고 있습니다. 그래서 여러 가지 가이드라인이 있는데요. 대표적으로 미국과 유럽의 가이드라인이 있고 시간이 지나면서 이전에 비해 뭐 스테이지 그레이드 그리고 타겟 BP 모두 약간씩 낮아지는 경향을 보이고 ISH 가이드라인과 그리고 한국 뭐 다른 여러 나라 가이드라인도 크게 보시면은 이전에 비해서 점점 타겟을 낮추는 그런 경향으로 가는 것 같습니다. 그래서 보시면은 이런 인베이시브한 BP 매니지먼트가 카디오베스큘러 아웃컴에 어떤 영향을 미치는지를 알아본 여러 큰 트라이얼들이 있었습니다. 그래서 이런 스터디들은 주로는 이제 BP 로어링 타겟을 이제 130에서 150 사이에 이제 어디로 스탠다드 BP 로어링 타겟과 이제 그 인텐시브 BP 타겟을 비교를 한 연구들인데요. 어떤 트라이얼들에서는 이제 인텐시브한 BP 로어링이 이제 스탠다드 케어에 비해서 이제 베네핏을 보여준 것으로 이제 보고를 하였습니다. 2010년에 보고된 이제 아쿼드 BP 트라이얼은 다만 이제 DM 페이션트를 인로를 하였는데요. 이 트라이얼에서는 SBP 120 미만으로 이제 인텐시브 BP 컨트롤을 한 군이 더 좋은 아웃컴을 이제 보여주지는 못하였고 홉3 트라이얼에서도 이제 그 안티 하이퍼텐시브 메디케이션을 한 군에서 이제 그 유의하게 CV 이벤트를 낮추지는 않았었습니다. 하지만 스프린트 트라이얼과 그리고 2021년 최근에 나온 스텝 트라이얼에서는 인텐시브 로어 BP 타겟 120 미만 그리고 130 미만으로 낮추는 것이 그 스터디 파퓰레이션에서 CV 이벤트를 낮추는 것으로 보고가 되었고요. 스프린트 트라이얼의 이런 결과는 이 2017년에 나온 ACC AHA 가이드라인을 이 타겟과 그 데피니션을 바꾸는데 큰 영향을 주게 되었습니다. 그래서 이런 트라이얼들을 간단히 비교를 해보시면은 크게 아컬드 BP 트라이얼 아까 말씀드린 DM 페이션트 그를 인로를 하였고 SBP 120 미만과 스탠다드 케어를 비교를 하였고요. 타입 2 DM 환자를 인로를 하였습니다. 그리고 스프린트 트라이얼이 있고 홉3 트라이얼, 스텝 트라이얼이 있는데 이 스프린트 트라이얼은 DM 페이션트를 익스클루전을 하였습니다. 그리고 스텝 트라이얼에서는 올드 에이지 60에서 80 비교적 에이지가 조금 높은 환자들을 인로를 해왔다는 특성이 있고 이 어콜드에서는 이런 이제 올드 에이지가 그 80 이상인 환자들이 빠졌고요. 프라이머리 아웃컴에는 약간의 차이가 있습니다. 여기서는 퍼스트 어커런스, 메이저 CV 이벤트, 뭐 MI, CV 데스 등을 넣었는데 이 스프린트에는 조금 더 많은 이벤트들이 프라이머리 아웃컴으로 들어갔었습니다. 그리고 이 스텝 트라이얼은 이제 차이니스 아시안 페이션트로 이제 이루어졌다는 그런 차이가 있었고요. 그래서 결과는 아까도 말씀드렸다시피 아컬드 BP 트라이얼에서는 CV 이벤트 감소시키지는 않았고 스프린트 트라이얼에서는 인텐시브 케어 그 군에서 CV 이벤트를 굉장히 유의하게 감소시켰고 여기서 아질살탄 클로살리돈이 이제 사용이 되었었습니다. 그리고 홉3 트라이얼에서는 CV 이벤트 감소시키지 않았고 스텝 그 트라이얼에서는 CV 이벤트를 유의하게 그 SBP 130 미만으로 낮춘 군에서 유의하게 감소시키는 그런 약간씩의 다른 결과를 보여주었습니다. 어콜드 BP 트라이얼은 프라이머리 엔드포인트를 만족시키진 못했지만 스트로크 엔드포인트를 했을 때는 이 스트로크에서는 렐러티브 리스크 리덕션 이펙트를 유의하게 보여주었습니다. 그리고 스프린트 트라이얼에서는 아까 말씀드렸다시피 프라이머리 아웃컴을 리스크 리덕션 25%로 굉장히 유의하게 하였고 애니코즈 데스 또한 굉장히 유의하게 리덕션하는 효과를 보여주었습니다. 그 스텝 트라이얼이 이제 스프린트 트라이얼의 이제 연장선상에서 이제 비슷한 결과를 보고를 하였다고 되어 있는데요. 프라이머리 엔드포인트도 유의하게 낮추었고 또한 이 이제 스트로크나 ACS 리스크도 낮추었습니다. 이 어컬드 트라이얼에서는 아까 스트롱 리스크를 낮추었다고 했는데 스프린트에서는 스트롱 리덕션 효과는 보여주지 않았습니다. 그래서 이 스텝 트라이얼은 인텐시브 BP 케어가 이런 리스크도 같이 낮춘다는 조금 더 애디티브한 결과를 보여주었다고 할 수가 있겠습니다. 그래서 이 스프린트 트라이얼과 스텝 트라이얼은 이제 공이 그 인텐시브 BP 케어가 굉장히 좋다는 그런 결론을 보여주었는데 디자인에서 약간의 차이가 있습니다. 이 스프린트에서는 DM이 익스클루전 크라이테리아에 있었고요. 스텝 트라이얼에서는 그렇지 않았기 때문에 약 19% 환자가 이제 타이프 DM 환자였습니다. 그 스프린트 트라이얼은 이제 상대적으로 이제 리스크가 높은 환자들이 인롤이 많이 되었고 CKD 환자가 무려 28% 포함이 되었었는데 스텝 트라이얼에서는 2.4% 정도 되는 이제 적은 숫자가 포함이 되었었고요. 이 스프린트 트라이얼 결과에서는 키드니 인저리 환자가 인텐시브 케어 유닛에서 그 그룹에서 조금 더 많았는데 스텝 트라이얼에서는 뭐 키드니 인저리에 유의한 영향을 미치지는 않았었습니다. 그리고 이제 아시안이 당연히 스텝 트라이얼에서는 이제 아시안으로 이루어진 스터디였었고요. BP를 메저하는 방법에 있어서 스프린트 트라이얼은 많이 아시겠지만 이게 이제 그 환자 혼자 그 자동 혈압계를 가지고 방에서 그 배기 고혈압을 그 배제할 수 있도록 방에서 자기가 혈압을 측정하는 그런 측정 방법이었고 스텝 트라이얼은 그냥 이제 잘 트레이닝된 스텝들이 병원에서 이제 그 혈압을 재주는 그런 이제 시스템이었습니다. 우리 그 일상 프랙티스와 조금 더 가까운 그런 메저먼트라고 할 수가 있겠습니다. 그래서 이런 이제 스트릭트 BP 컨트롤의 이점에 대해서 보고한 스터디들이 있고 또한 이제 고혈압과 CKD가 있는 환자에서는 어떨까 봤더니 이제 여러 가지 연구들의 이제 메타 아날라이시스를 보면은 오버럴 아웃컴이 CKD 환자에서 인텐시브 BP 컨트롤 한 군이 조금 더 좋았다라는 보고가 있고요. 국내 가이드라인에서는 이제 CKD 환자에서 기본적으로 140에 90 미만으로 타겟을 설정을 하는데 알부민료가 동반되면 130에 80, 당뇨가 있으면 130에 80으로 이제 약간 분류해서 권고를 하고 있습니다. 요 미국 가이드라인에서는 역시나 CKD에서도 130에 80이라고 이렇게 BP 고를 설정을 해놓고 있습니다. 그 KD고 가이드라인 네프롤로지 쪽의 가이드라인인데요. 2021년에 오랜만에 나왔었는데 이때 SBP의 타겟을 120 미만이라고 이제 권고를 하고 있습니다. 그래서 굉장히 이제 아주 스트릭트한 것을 가이드라인 수준에서 권고를 하고 있는데 이제 본문에는 스프린트 트라이얼 이제 서브그룹 from 이제 원 RCT라고 스프린트 트라이얼을 이제 기반으로 이렇게 레코멘드한 것으로 되어 있습니다. 그래서 요 뭐 여러 가지 가이드라인을 종합적으로 생각을 해서 이제 케어를 해야 되겠습니다. 그리고 당뇨 환자에서 트라이얼 보시면은 예전에 아코드 트라이얼이 이제 그 네거티브 스터디가 나왔다고 했는데 약간 이제 스프린트랑 이제 일롤이라든지 아웃컴이 조금 달랐는데요. 요 이제 아코드랑 스프린트 환자들을 이제 풀드 아날라이시스를 해서 요 프라이머리 아웃컴을 스프린트의 프라이머리 아웃컴으로 했더니 요 이제 그 풀드 아날라이시스에서 유의하게 그 인텐시브 케어 BP 컨트롤 군이 CV 아웃컴을 개선을 시키는 것을 볼 수가 있었고 스트로크와 핫페일러 리스크 역시 줄였습니다. 그래서 DM 페이션트에서도 이제 그 스트릭트한 그 BP 컨트롤, 인텐시브 BP 컨트롤이 어느 정도 이제 좋지 않을까라는 그런 이제 생각을 하게 되었고 미국 가이드라인에서는 역시 당뇨에서도 130에 80 미만을 권고하고 있고 ESC 가이드라인에서도 130 미만으로 일단 권고를 하고 있습니다. 다만 국내에서는 아까도 말씀드렸다시피 140에 90 리스크 팩터가 있는 사람 고위험도에서는 하이 리스크에서 130에 80으로 하고 있는데 저희 그 국내 내분비학회에서 나온 당뇨병 진료 지침에서도 아직은 목표 혈압을 140에 85 미만으로 하고 있고 심혈관 질환을 동반한 당뇨병 환자에서는 130에 80이라고 이렇게 권고를 하고 있습니다. 그래서 본문에는 이제 뭐 아콜드 트라이얼도 충분히 참고를 했고 아콜드 연구에서 이제 네거티브로 나왔는데 그 뒤로 나온 스프린트 연구라든지 미국에서 나온 가이드라인에서 뭐 타겟을 내린 것도 모두 고려를 하였지만 이 스터디들은 모두 이제 일반적인 DM 환자에서 이루어진 것이 아니라서 일반적인 당뇨병 환자에서 SBP를 130 미만으로 낮추는 경우가 명확히 이득이 있다라고 보이는 연구는 없었다고 이렇게 이렇게 기술을 하면서 아직은 140에 90으로 140에 85로 권고를 하고 있습니다. 그래서 현재 그러면 고혈압 커런트 매니지먼트는 어떻게 하고 있느냐를 보시면은 2018년 고혈압 진료 지침을 보시면 고혈압 전 단계에서는 하이 리스크인 경우 이제 약물 치료를 고려를 할 수가 있지만 그렇지 않은 경우에는 일단은 생활습관 교정으로 그 권고를 하고 있고요. 1기 고혈압에서는 위험인자가 없는 경우에는 그 생활습관 교정 또는 약물 치료이고 위험인자가 있는 경우부터 약물 치료를 하도록 하고 있고 2기 고혈압에서는 리스크 상관없이 약물 치료를 하도록 하고 있습니다. 또한 2기 고혈압에서는 소량의 이제 컴비네이션으로 이제 그 투약을 하도록 권고를 하고 있습니다. 미국 가이드라인에서도 이런 면에서는 클래스의 약을 시작하도록 하고 있고요. 아까 그 고혈압의 기준이 낮아졌다고 말씀을 드렸었는데 그 여전히 그 스테이지 1으로 분류된 그 고혈압에서도 미국 가이드라인에서 이제 고혈압으로 하기는 하지만 이제 바로 약물 치료를 하도록 하고 있지는 않습니다. 그래서 그 라이프 스타일 모디피케이션 하면서 리피트 이벨루에이션을 하도록 권고를 하고 있고요. 유럽 가이드라인에서도 보시면은 이 비슷한데 하이 노말 환자, 여기 이제 미국에서 기준으로는 이제 스테이지 1 고혈압인데요. 유럽에서는 아직은 고혈압으로 정의는 하지 않고 있는 이 단계에서 이전에는 아예 약물 치료를 레코멘드 하지 않았는데 2018년에는 이런 이제 하이 노말 환자에서도 베리 하이 CV 리스크 있는 경우에는 이제 약물 치료 고려하도록 레코멘드를 하고 있습니다. 그래서 대개는 비슷하고 그레이드 1, 2, 3에서 이제 그 그레이드 1에서 하이 리스크 환자에서는 약물 치료 바로 시작하고 그레이드 2에서는 바로 약물 치료를 시작하는데 유럽에서는 이런 환자들에서 그 이니셜 듀얼 드랙 콤비네이션 세라피를 이니셜 트리트먼트로 이제 프리프하는 것으로 권고를 하고 있습니다. 그래서 아예 이제 원필의 듀얼 콤비네이션 세라피를 권고를 하고 있고 그 약제로는 많이 쓰시는 에이스 이니비터 또는 ARB 플러스 CCBO와 다이우레틱스로 권고를 하고 있고 모노세라피는 이제 그레이드 1 하이퍼텐션의 이제 로우 리스크 환자에서만 또는 이제 베리 올드하거나 프레일하거나 이런 환자에서 하도록 권고를 하고 있습니다. 마지막으로 아질살탄의 이제 역할에 대해서 말씀드리겠습니다. 아질살탄은 앞에서 이숙진 선생님께서 잘 설명해 주셨다시피 이제 굉장히 혈압 강화 효과가 좋은 약제인데 겹치는 내용도 있어서 빨리 넘어가겠습니다. 올메살탄 대비 아질살탄 80이 굉장히 유의하게 SBP 리덕션 더 많이 강화를 시켰고 세이프티 면에서 별 문제는 없었고요. 요것도 이제 아질살탄 80mg와 40mg가 요 40mg만 돼도 발살탄 320mg에 비해서 더 큰 이제 BP 리덕션 이펙트가 있었던 것을 알 수가 있고 세이프티 면에서는 다른 어드버스 이벤트에 유의한 차이는 없었습니다. 그리고 여기서 이제 아질살탄의 클로로살리돈을 에디션하는 것을 말씀을 드리겠습니다. 클로로살리돈은 요 이제 요 글씨가 잘 안 보이는데요. 사이아자이드와 클로살리돈이 있는데 이 사이아자이드와 이 설포나마이드를 이제 같은 구조를 갖지만 이 바깥의 구조가 다릅니다. 그래서 이 구조들이 이제 그 CA 이니비션 효과를 더 높여서 더 큰 혈압 강화 효과와 그리고 방광기가 더 길게 하고 있습니다. 그래서 클로살리돈이 더 많이 더 오래 떨어뜨리는 약이라고 생각을 할 수가 있는데요. 같은 용량이라고 해도 이 사이아자이드에 비해서 클로살리돈이 더 SBP를 리덕션을 시키는 것으로 이렇게 보여집니다. 그래서 이런 클로살리돈이 CV 아웃컴에 이제 베네핏을 보인다는 여러 가지 트라이얼들이 있는데요. 셉 트라이얼은 이 플라시보 대비 클로살리돈을 투약했을 때 5year 리절트에서 뭐 스트록, 그 코로나리 핫디지즈, CVD 그리고 뭐 컴바인드 요 스트로크나 MI, CV 데스 이벤트 모두 낮추었고 22년 리절트에서는 CV 데스가 약간 이제 이쪽으로 클로살리돈 페이버한 것으로 나타났습니다. 그리고 올해 트라이얼에서도 이렇게 세 가지 약제 비교한 연구에서 클로살리돈을 그 리시노프릴이라는 요 약제와 비교하였을 때 스트롱 리스크를 유의하게 낮춘 것으로 나타났습니다. 그래서 이 클로살리돈이 이제 하이포칼레미아가 사이아자이드에 비해서도 뭐 좀 많고 이런 이제 말이 있었는데 사실 이 이제 용량의 문제였고 이제 사이아자이드에 비해서 크게 클로살리돈이 더 하이포칼레미아를 같은 용량 대비 일으키지는 않는 것 같고요. 요 이제 그 BP 리덕션 효과가 워낙 좋아서 12.5나 25까지 이제 투약을 해도 BP 리덕션이 웬만큼 많이 되면서 하이포칼레미아는 용량 디펜던트하게 이렇게 늘어납니다. 그래서 적당한 용량을 해서 사용을 하게 되면 하이포칼레미아 크게 문제되지 않게 이제 잘 조절할 수 있다는 그런 데이터를 보여드리고요. 그렇다면은 요 클로살리돈과 아질살탄은 컴바인해서 쓰게 되는 경우 클로살리돈 단독에 비해서 요 복합제가 더 유의하게 BP 리덕션 이펙트가 있는 것을 보실 수가 있고요. 세이프티 면에서도 어드버스 이벤트는 별 문제는 없었습니다. 그리고 요 아까 선생님께서 다 보여주신 거라 금방 넘어가겠습니다. 24시간 동안 요 아질살탄 클로살리돈 복합제가 요 단일제에 비해서 유의하게 지속적으로 BP 강화 효과가 지속된다는 거고 올메살탄에 비해서도 더 좋다는 것을 나타내고 앞에서 다 보셨습니다. 그리고 클로살리돈이 롱텀하게도 이제 4년, 7년 하게도 요 메이스를 유의하게 더 낮췄다라는 스터디들이 있어서 이제 그 가이드라인들에서는 이것은 유러피안 가이드라인인데요. 다이레틱스를 그러니까 권고하고 있는 고혈압 약제 중에서 사이아자이드보다는 이런 이제 클로살리돈이나 인다파마이드 같은 사이아자이드 라이크 드럭을 투약하도록, 왜냐하면 BP 로어링 이펙트와 그 롱 듀레이션을 고려해서 투약하도록 하고 있고, 또한 이런 이제 CV 아웃컴 개선 효과도 같이 거론을 하면서 요 약제들을 권고를 하고 있습니다. 그 미국 가이드라인에서도 클로살리돈이 이제 프리퍼 된다라고 되어 있고요. 특히 이제 저항성 고혈압에서 3 드럭을 레지멘을 할 때 여기 이제 CCB 라스 이니비터와 클로살리돈을 이제 병합하는 요 구성을 언급을 하고 있습니다. 그리고 아질살탄에 대해서는 이제 다른 ARB나 에지미터 라인프릴 같은 것에 대비 24시간 ABPM을 4에서 8ml 머클리 정도 포더 SBP 리덕션 효과가 있다라고 언급을 하고 있습니다. 그래서 마지막으로 케이스 보시고 끝내겠습니다. 34세 여자 환자이고요. 혈압이 높아서 받고 굉장히 이제 오비스한 환자였습니다. 2기 고혈압이었고 다른 스모킹 알코올 히스토리는 없었고 처음에 이제 2기 고혈압이었고 복합제로 시작을 하였는데요. 이렇게 시작을 하다가 혈압이 잘 조절이 되면서 체중을 굉장히 천천히 20kg나 감량을 했습니다. 그러다 보니까 어느 날 한 115에 70 그리고 집에서도 한 110대 정도 자가혈압이 나온다 그래서 자가혈압 요 정도라 그래서 여기서 요 지금 색깔이 깨졌는데요. 아모디핀을 빼고 아질살탄 40ml로 유지하면서 현재 120 정도로 잘 유지되고 있습니다. 그리고 38세 남자 환자분이신데 5년 전에 고혈압 진단받았지만 약을 안 먹다가 한 달 전부터 고혈압 약을 복용을 시작하였습니다. 즉 한 5년 이상 그냥 고혈압이 있는 굉장히 하이 BP 상태로 이제 타겟 루멘 데미지 다 갔을 것으로 생각이 되는 사람인데요. 크레아티닌이 상승해서 워크업 위에서 네프로에 입원을 하였고 보시면은 에코는 굉장히 이제 전형적인 하이퍼텐시브 하트의 그런 이제 에코 소견을 볼 수가 있고요. 요때 이제 방문을 해서 요런 약제로 네프로에서 이제 시작을 했습니다. 그러다가 이렇게 해서 혈압 조절도 잘 되지 않고 이제 크레아틴이 조금 떨어지는 걸 보고 이제 아질살탄 그때 ARB 애들을 하였고요. 그때부터 이제 뭐 롱텀하게 보면은 크레아틴이 점점 떨어지고 현재는 혈압도 이제 잘 유지되면서 120에서 130 정도로 유지되면서 잘 지내고 있습니다. 그래서 서머리를 말씀드리겠습니다. 인텐시브 BP 로어링은 CV 아웃컴과 모탈리티를 개선을 시키는 게 가장 이제 중요한 메시지라고 할 수가 있겠습니다. 인텐시브 BP 로어링은 굉장히 유의하게 메이스 스트로크 코로나리 이벤트 CV 모탈리티를 감소시키고 이것은 이제 특히 하이 솔트 센시티비티를 갖고 있는 이런 아시안 파퓰레이션에서 BP와 CVD의 링키지가 굉장히 스트롱한 아시안 파퓰레이션에서 중요하다고 할 수가 있겠고 스프린트와 스타입 트라이얼에서 얻을 수 있는 파인딩은 이제 BP 타겟의 이제 변화를 어느 정도 이제 그 정보를 제공해 주지 않을까라는 그런 이제 생각이 들고요. 아질살탄과 아질살탄 클로살리돈은 굉장히 24시간 혈압검 BP 컨트롤을 지속시키고 CV 아웃컴을 개선시키고 이제 웰 톨러러블한 그런 약제이고 레지스턴스 하이퍼텐션에서도 요 3제 중에 클로살리돈을 고려하는 것이 권고된다라고 정리를 할 수 있겠습니다. 경청해 주셔서 감사합니다.
네, 정혜문 교수님 훌륭한 강의 감사드립니다. 최근에 그 가이드라인에서 타겟 BP가 점점 130에 80으로 떨어지는 배경을 잘 설명해 주셨습니다. 사실은 우리가 혈압은 너무 처음에 출발할 때 타이트링이 필요합니다. 올드에이지 환자들에게 너무 갑작스레 혈압을 떨어뜨리는 것은 오히려 안 좋을 수도 있죠. 또 컴플라이언스도 안 좋아지고요. 그렇지만 보시는 것처럼 충분하게 떨어야만 혈압으로 인한 베니핏을 얻을 수가 있습니다. 그래서 인텐시브하고 그다음에 컨티뉴스하게 컨시스턴하게 혈압을 조절했을 때 환자의 리스크를 충분히 줄일 수가 있습니다. 그러기 위해서는 우리가 숏액팅보다는 롱액팅의 드럭을 환자가 어느 정도 타이트레션이 되고 안정된다면 롱액팅의 드럭을 쓰는 것이 좋습니다. 롱액팅 드럭 중에서 우리가 흔히 쓰는 게 암로디핀 같은 그런 칼슘천을 블루커를 많이 사용하는데요. 아시는 것처럼 올드에이지에게 다리 부종 같은 그런 부작용이 생기면 사용하기 힘들 때가 있죠. 그럴 때 이런 아지살탄이 대체제로 중요하게 또 작용할 수도 있을 것 같습니다. 두 분의 훌륭한 명강의를 듣고 또 혈압 치료에 대해서 많은 통찰을 얻었으리라 생각이 듭니다. 참여해주신 모든 분들께 감사드리고 특히 두 분 스피커에게 깊은 감사를 드립니다. 이상으로 런천 심포지움을 마치겠습니다. 감사합니다.
Seoul is the complete convention city with its vast infrastructure, makes planning for business events convenient for us.
I visited many cities for business events, but no other city has one card for all to compete with Seoul with its accessibility.
In Seoul, your events can happen where modernity meets tradition, or joyful bustling flows on the peaceful water.
I just love Seoul for its industry tours. It almost feels like traveling to the future with high technology happening right before your eyes.
Seoul is truly dedicated to supporting business events with its customized experience services.
Team building activities in Seoul were very special, and before you know it, you became one team acting towards the same goal.
Seoul takes care of you, even after the hectic meetings. Authentic experiences may excite you more or relax your mind and body.
Good morning, ladies and gentlemen. Welcome to Hypertension Seoul 2012. This is the third session of the first day of Hypertension Seoul 2012. This session will deal with precision medicine and artificial intelligence. I am Haeok Jung from Seoul Saint Mary's Hospital, and my co-chair is
Haeyoung Lee from Seoul National University Hospital.
Yes. So I will introduce first two speakers, and third and fourth speaker will be chaired by Dr. Lee. So I will introduce first speaker, Dr. Seung-Chan Yoon from Yonsei University. Dr. Yu, please.
Hello, and thank you for the kind introduction. I'm Chan from Yonsei University, College of Medicine. The title of this presentation is Heterogeneity of Treatment Effect in Hypertension. And this is the disclosure of my. I'd like to start with a SPRINT trial. I think that all of you know about the SPRINT trial, which demonstrated that intensive BP control resulted in lower rates of the fatal and non-fatal major cardiovascular events and deaths from any causes, even though it has more events of several other adverse events such as hypertension, syncope, electrolyte abnormality, acute kidney injury, or acute renal failure. And STEP trial from China confirmed this finding that intensive BP control can be better in old patients in China, although it also related with more events of hypertension. It was published in the New England Journal of Medicine in 2021. In the last week, the Enchanted trial was published in Lancet. And in this trial, intensive blood pressure, they concluded that intensive blood pressure control should be avoided in patients receiving endovascular thrombectomy for acute ischemic stroke due to intracranial large vessel occlusion. You can see that the risk, the neurological results is worse in the more intensive treatment arm compared with the less intensive treatment arm. Why this happened? Because there is heterogeneity of treatment effect in the real world. So the responses to a given intervention or treatment may vary across patients. So the intensive blood pressure control is beneficial in the participation in the SPRINT trial or STEP trial, but it is harmful in the Enchanted 2 trial. In fact, the clinical trials only provide evidence for the average treatment effects, which assumes one-size-fits-all treatment. However, in the real world, treatment effect varies by patient's condition, and we call this as heterogeneous treatment effect, or ATE. So as a clinician, we want to know about the conditional average treatment effect, CATE, or individual treatment effect, ITE. When you draw causal inference, we usually leverage potential outcome framework by Nyman and Rubin. The true causal effect is the difference between actual outcome for the treated if treated versus potential outcome for treated if not treated. This counterfactual outcome actually cannot observed in the real world. We do not actually live in the metaverse or multiverse. So in our universe and in our real world, we can only observe that actual outcome for treated if treated and actual outcome for untreated if not treated. And by estimating this difference, we estimate the average treatment effect. So 3 assumptions is required for this potential outcome framework by Nyman and Rubin, that no hidden confounder, positivity, and stable unit treatment value assumption, which can be certified in the most clinical trials. Again, the clinical trials usually provide evidence for average treatment effect, whether we want to know about the subgroup level, conditional average treatment effect, or individual level individual treatment effect. To estimate the subgroup level effect size, we usually conduct the subgroup analysis, which is usually pre-specified in the trial. But most positive subgroup effects can be false or overestimated. The The other way to estimate the HTE is estimate the baseline risk. And previous studies show that the reperfusion therapy for STEMI patients actually only beneficial in those with higher risk. The majority of patients do not have the benefit from the reperfusion therapy because they do not have high risk of mortality from the STEMI. So in many cases, the baseline risk is proportional to the HTE. But there are other methods to estimate the HTE. So there are several papers regarding HTE in BP treatment after the SPRINT trial, because SPRINT, as you know, SPRINT trial showed that the intensive BP control can increase the risk of the several adverse events. So Sanjay Basu at Stanford and his colleagues identified the subgroups of patients who have higher absolute risk reduction of GVT events with intensive BP control, and those who had higher absolute risk increase of its serious adverse events by using Cox regression with elastic net regularization. Later, Brass and the Sanjay Basu and other SPRINT research team also found that SPRINT participants with higher baseline predicted GVT risk gained greater absolute benefit from intensive treatment by using Cox regression with the elastic net regularization. But they also found that these patients actually with the higher baseline risk and the higher absolute benefit actually have the higher risk of the adverse events from the intensive BP control. So later, Duan and Sanjay Basu, including Andrew Ng, who is the guru in deep learning field at Stanford, published this paper. They used XLearner, which is machine learning. So they compared conventional logistic regression to the XLearner for 3-year GVT disease event risk reduction from intensive versus standard BP treatment. They predicted individual treatment effect from trial data, and they revealed that patients may experience a absolute risk reductions not simply proportional to baseline GVT risk. Machine learning method can improve discrimination and calibration of individual treatment effect estimates from clinical trial data. So there are the method to estimate the HTE, and one of them is MetaLearner. MetaLearner is non-parametric HTE estimation method by imputing missing counterfactual outcomes. And in the MetaLearner group, there is XLearner, and another thing is balanced representation learning, which is a deep learning method. It is quite flexible, even though it only works with discrete treatment. So I'd like to explain only XLearner here. So there is 2 steps in XLearner, and that's why it is MetaLearner. In the first phase, it predicts the counterfactual outcome. So what happens if the patient is not treated, even though he was actually treated, and vice versa. And the second step, it estimates the difference of the treatment effect when the patient is treated and versus when the patient is not treated. Again, the RCT can provide the evidence for average treatment effect, and then we can estimate the HT by using this data. We emulate RCT by using usually propensity score model, and we also leverage this system to estimate HTE by using real-world data, which is not random, where the treatment is not randomly assigned. There are things to consider when estimating HTE using real-world data, and which model and which assumptions will be violated, and the quality of data. When we use RCT data to estimate HTE, then we don't need to think about the hidden confounders. This is the pilot result from my study using XLearner to identify the HTE in the short versus long-term depth strategy. So there are 5 clinical trials regarding the short versus long-term depth strategy conducted by several hospitals, and we aggregated these data into one single data format, and then we trained X-learner by using 4 clinical trials participants, and then we validated or tested this model against the TICO trial, which is the most recent trial and was published in JAMA in 2020. And we also applied this algorithm in the real-world registry, which was COMATE cohort. In the first step, we fit the model to predict bleeding outcomes, and then in the second step, we imputed outcomes using bleeding models and compared predicted versus observed outcomes to refine the predict ARR through repeated subsampling and validation. And finally, we use this model to predict absolute risk reduction. There is no difference in the baseline risk for bleeding, ischemic events, or primary outcomes between the benefit group versus no benefit group. But in the benefit group, the short-term depth is beneficial to reduce bleeding outcomes, and it does not increase the ischemic events, and it actually decreases the primary outcome events. It is not replicated in the non-benefit group. There is no risk difference between short-term versus long-term depth in the non-benefit group. When you apply this model in the COMATE registry, which represent the real-world patients, then the model defined 70% of them as benefit group. We also validate the precise depth score, which predicts the bleeding risk in the patients, and then it is recommended by the guidelines to decide whether the patients should have the short-term versus long-term depth strategy. Of course, when we use this algorithm, the baseline risk is different because precise depth score is trained to predict the bleeding risk itself. So the benefit group has lower bleeding risk versus the no-benefit group. Even though in the benefit group, the short-term depth can reduce the bleeding risk, but it does not reduce the primary outcomes. And we found that our model, X-learner, is slightly better than precise depth score to discriminate the benefit from the treatment. So this is the final remark of mine. The clinical trials usually provide the evidence for average treatment effect, while we need to predict individual treatment effect for the patient in front of us, and there is heterogeneity of treatment effect. These can be estimated based on the baseline risk, but recently several machine learning models and statistical algorithms are proposed to identify a subgroup of patients who will have benefit from the intervention. And secondary use of RCTs is critical in this system, although it is possible to use observational data if it is large enough and well curated enough. Thank you for your attention.
Thank you. Thank you, Dr. Yoon. Thank you for your very difficult lecture. So Q&A will be open after all lecture. Thank you, Dr. Yoon. I'm very sorry to announce that order of lecture will be changed due to the emergency procedure of Dr. Gang. So let me introduce second speaker, Kazuomi Kario, Jichi Medical University, Japan. He's a well-known, renowned doctor in the field of hypertension research. So he will be lecture using video file. Video file ready? Please.
Hello, this is Kazuomi Kario from Japan. I'm very honored to have this lecture on hypertension digital therapeutics updated to 2022. Disclosure. So this shows the 7-action approach for the management of hypertension in Asia. So we recommend this 7-action approach. So within this, the home BP guided approach, strict salt reduction, and strict blood pressure control, and the first target is morning hypertension, and the second, the nighttime hypertension, especially for the high-risk patient. The choice for the preferable drug is the calcium antagonist and also natrium, sodium, the releasing drug. And also widespread the mass screening is important for us. And finally, the use of telemedicine strategy. So today, I'd like to focus on the digital hypertension area. So it's an area of the research and clinical practice using the information technology, the communication. So among the digital health, the medical medicine area is a digital medicine. And also within this, the software as a medical device, SAMD, is a program for the medical purpose, including the analysis and the diagnosis, which are approved by the regulatory authorities. And also focusing on the therapeutics, it's a digital therapeutics. So now, in October issues, we released this paper. This is a review paper published in the Hypertension Research. So first, the software as a medical device of evidence-based hypertension digital therapeutics for clinical practice. In the 2021, the open label randomized HERB digital hypertension first the trial. They showed the first time digital therapeutics is effective for hypertension management. It significantly reduced the 24 blood pressure levels and also morning hypertension. I'll show you later. And based on this, the trial, in Japan, this is the first global approval of this application for the management of hypertension. So I'd like to show you the result of the HERB DH1. So this software encourage and help implement through lifestyle improvement the application, aiming at the lowering blood pressure. So this application through the mutual communication with doctor and virtual nurse, this application facilitate to support the experience of non-pharmacological interventions, 6 interventions which were validated the efficacy in previous studies, and also all these 6 components were documented in the guidelines for the non-pharmacological treatment. First, salt reduction, body weight control, and exercise, and sleep condition, and the alcohol reduction, and the stress management. These 6 are very much important. So patient and also doctors could recognize time trend of the blood pressure reduction. So this is a study design. As shown here, primary endpoint was a change in the 24 systolic blood pressure by ABPM at the 12 weeks, before and after. The home BP were consecutively measured. The first, we randomized into the control group and the digital therapeutics group, application group. So drug-naive patients were randomized. Control group, they consist of the intervention was the standard lifestyle modification only, guided by doctors, only doctors. And the application group, on the top of the standard modification by doctors, but also it induce the application hub system to communicate the day by day and also continuously facilitate the knowledge and practice to keep the motivation. So this is a result. As shown here, the application significantly reduced the 24 blood pressure levels compared to the control by minus 2.4 millimeters of mercury. It was significant. And also very clinically importantly, the morning home blood pressure. So application group significantly reduced by 10 millimeters of mercury for morning home systolic blood pressure. And here, the control group also reduced 6.2 millimeters of mercury. So home blood pressure monitoring was conducted for both these two groups, and even only by doctors guided home blood pressure monitoring significantly reduce the home blood pressure in the morning. But the digital therapeutic group further reduced systolic home blood pressure in the morning by 4.3 millimeters of mercury. And this is a time trend of the morning home systolic blood pressure. Control group and the application group. Application group significantly reduced the morning home systolic blood pressure, even after the medication initiated. Medication tend to be lower rate, but in the digital therapeutic group. And this shows the change in the body weight in two groups. As shown here, the application group significantly reduced body weight compared to the control. And also, self-reported sodium intake was significantly reduced in application group compared to the control group. Both reduction of the body weight and the sodium, degree of the sodium reduction, were significantly reduced in the application group. And also, the degree of the reduction of these two components were significantly correlated with the reduction of the home systolic blood pressure and also ABPM reduction. So one of the mechanisms of the reduction of the home BP and blood pressure are partly accounted for the body weight reduction and sodium reduction. This shows the progress of the application supported lifestyle modification. First, the step one, to input the knowledge, the accurate and precise knowledge into the each patient. So for the information on the 6 non-pharmacological intervention. And the step two is the executives of the practice. So facilitate each patient the practice the priority of the practice was selected by the patient themselves, and if the practice was perfectly completed, the next step the patient could choose. And let's see the minus 4.3 reduction by application. So based on the STEP study, this is a strict blood pressure control, that its efficacy was compared with the standard blood pressure reduction in the elderly hypertensive patients. So STEP study, the standard blood pressure control group and the strict blood pressure control group, their difference was 7.5 millimeters of mercury for morning home blood pressure. When this result of the cardiovascular event reduction, have the DH1, the 4.3, account for the reduction of the stroke and coronary artery disease, the 21% reduction. And the acute heart failure, almost half were calculated to be reduced. So this is a new strategy, the therapeutic approach for the hypertensive heart disease, digital therapeutics, the renal denervation, and also new medications, selective MR blockade, and the SGLT2 inhibitor and ARNI, all could be reduce the 24 blood pressure levels, including the morning and the home blood pressure, morning, home, and also nighttime blood pressure. This should reduce the progression of the CKD, LVH, and the atrial fibrillation. These should reduce significantly in the heart failure. So this shows the seamless digital approach from the disease prevention to aggravation. So digital health, it could be include the digital behavioral modification. This could prevent the occurrence of the hypertension prevention. And digital medicine, digital therapeutics in the area of SAMD, this reduce the hypertension treatment, this induce hypertension treatment to prevent organ damage and the cardiovascular events. So we should connect the blood pressure levels, and also the partly modified by the behavioral modification. So based on the big data with time series, we can speculate the individual change and efficacy of the blood pressure reduction intervention. So this should be the personalized anticipation medicine. So ladies and gentlemen, this is the conclusion. Current aspect of digital therapeutics for the management of hypertension. Digital therapeutics is one of the promising options in antihypertensive treatment strategy. Second, validated application will support better lifestyle modification at individual levels, resulting in the effective blood pressure reduction. The main residual issues that challenging are identifying the responders, efficacy to multiple risk factors, combined use with antihypertensive drugs and long-term efficacy and prognosis. Finally, stabilization of evidence-based better lifestyle in earlier stage will prevent the aggravation of the hypertension and subsequent cardiovascular disease and organ damage. Thank you very much for your attention.
Yes, thank you. Now we move to the third speaker. Then I would like to introduce Professor Shin Dong-ho, Yonsei University. He graduated Seoul National University, and currently he's associate professor in Severance Hospital. His title is Digital Therapeutics, Blood Pressure Management in the Digital Era. Professor Shin, please.
Thank you for the introduction. Good afternoon, ladies and gentlemen. I'm Dong-ho Shin of Severance Hospital. Today I'm going to talk about digital therapeutics and blood pressure management in the digital era. From the title, you could imagine what I prepared, but I was planning to present what digital therapeutics are and to introduce some smart devices for blood pressure measurement and digital therapeutics for blood pressure management. And 2 weeks ago, I found the topics of the other lectures in this session, and I was confused. Of course, it's my honor to listen to Dr. Kario's lecture, but what topic should I talk about now? What do you expect from me after Dr. Kario's lecture? So today, I'd like to humbly talk about my small experiences. With a small IT company, I'm developing an application for hypertension. The company is well known for a skincare application, and it tries to expand the area to digital therapeutics. As you might already know, hypertension is a very common disease, and it could make serious complications when a patient falls or slips down. But it's not that easy to diagnose hypertension because the symptoms are non-specific and office blood pressure is not definitive. And after the diagnosis of hypertension, the most important treatment is education and non-pharmacological therapy, but it's not that easy in most clinical situations either. So we thought an application for hypertension might be helpful. This application will help diagnosis and education, treatment of hypertension. These are some example screenshots of the application: home screen, blood pressure measure screen, and educational list. And these are examples of educational contents. We expect to start a pilot study and a following random trial next year. Developing an application is not easy. It feels like drawing a picture with someone else's hands. Miscommunications always happen. The programmers always dissatisfies me, and likewise, I always say no to their ideas or designs. For example, the company wanted to include a fall detection and alarm algorithm, but I disagreed. Smartphones and smartwatches already have fall detection functions. Making an algorithm better than Apple or Samsung might not be easy. And also, I'm worried if we cannot afford the monitoring with small manpower and money. Especially, we need to consider blames or even legal problems when fall detection does not work. Anyway, I hope my app would work these roles listed here. I'm not telling the details how we will treat hypertension with digital therapeutics. Actually, the contents are already in the guidelines. These roles, monitoring, education, and non-pharmacological therapy are not only for hypertension, but for all digital therapeutics. Digital therapeutics will help to fulfill the unmet need in daily clinical practices. This patient recorded her blood pressure in a very organized way, but in many situations, self-recordings fail to deliver useful information. Communication about symptoms are not easy either. This menu was from the restaurant in my hospital. I asked my friend their preferences, and this was the result. All these 3 marks meant 1 coffee. The same message with 3 different expressions. Digital therapy will have self-recordings and the symptom expressions in organized ways, and it will also make them easier to deliver useful information. Communications about recommendation are not easy either. When you say do exercise to a patient, it would mean very differently for different patients. During the busy clinics, we usually skip the information of what exercise and how. And I find myself preferring prescribed drugs rather than recommending lifestyle modification because it is easier and more time-saving for me. We often evaluate the compliance of patients, but for patients, it might be doctors who fail to teach or lead them. Doctor fails to persuade them, not they fail to follow. In this regard, I'm sure that the future of digital therapeutics is very promising because it has the power to fulfill these unmet needs in clinics. Besides lifestyle modification, mental and metabolic disorders are considered as good candidates of digital therapeutics with cognitive behavioral therapy. During the app development, I came up with one question. Digital therapy for hypertension and hypotension, will they work the opposite way? Like an antidote against the other? Actually, they might be, and they need to be, very similar. Both will have blood pressure monitoring and very similar contents. Of course, there might be some small differences in detail. What if patients have both? Do they need both apps? Where should they record blood pressure? Hypertension app or hypotension app? This is a real medical record of a patient. Counting only chronic conditions, he might need kidney app for hemodialysis. He also has liver, lung, and spine problems. Plus, heart failure, arrhythmia with pacemaker, peripheral artery disease, and history of 2 cancers. I guess he might be interested in blood pressure control and anemia and body weight control too. Maybe he has to quit smoking, and he's very highly likely to have tooth and sleep problems. Maybe he is worried about dementia, eye and knee joint for the future. How many apps does he need? Can you guess? Can you suggest? Can he control all these digital therapeutics? These many apps would be redundant, inefficient, and time-wasting. Actually, these 3 words have the same meaning. These 3 words are very redundant. Too many alarms and notices will bother him, and I doubt he could control all these apps, and the apps would be unused eventually and wasted for a long time. A bigger problem is inconsistent recommendations. The different apps could tell numbers differently and even the conflicting recommendations. To prevent these problems, I came to conclude that digital therapeutics should be a platform. The digital therapeutic platforms gather and integrate personal information and provide personalized recommendation in a consistent and organized way. The key of success of digital therapeutic platforms would be various disease coverage and various programs including lifestyle modification. Of course, better user experience, flexibility, and integration. External factors including regulations and payment and insurance problem will also affect the success of digital therapeutic platform. I think the example of digital therapeutic platform is like this. At first, the app monitors users' blood pressure. If the blood pressure goes up, the app recommends to meet a physician and lifestyle modification. then it monitors blood pressure for hypertension treatment and provide blood pressure information to the physician. Later, the patient can be diagnosed as diabetes. Then the application recommends to lower blood pressure more strictly and monitors sugar levels too. A few years later, the patient has diabetic CKD, and DA recommends to lower blood pressure more strictly and monitors body weight and salt intake. If the patient gets older or have some hypertension symptoms, now the app teaches the blood pressure not to maintain blood pressure too low and can recommend some hypertension application. Digital therapeutic platform could recommend the personalized and exercise according to the patient conditions too. With basic monitoring and lifestyle modification module, the platform will offer digital peers like OTC and ETC, I guess. And people could use or buy some basic lifestyle modification or small smoking cessation program like OTC drug. And if they have disease, digital peers are ordered by their doctors and added to the platform. At this stage, I guess the distinction of digital health device and digital therapeutics will diminish. Digital therapeutic platform will evolve by convergence, including all these features. So I'm sure the result might be clear as the smartphone replaced the old phones. Thank you for listening.
Thank you very much. Now we move to the last speaker. Last speaker will be connected by internet. Professor Hyuk Kang from Seoul National University Bundang Hospital. His title is Novel Technology for Blood Pressure Measurement. Professor Kang, are you ready?
Yes, I'm ready here. Firstly, I'd like to deliver my apologies that I wasn't able to participate in person. I had a STEMI patient and had to rush back to the hospital and just finished my primary PCI. My talk today is novel technology for blood pressure measurement, and I'm from Seoul National University Bundang Hospital. Why is blood pressure measurement difficult? I'd like to first mention about it that blood pressure inside something, measuring pressure inside something is very difficult. Blood pressure lies inside our human body, so it is hard to measure it without invading into the body. And the pressure changes over time, but technologies also takes advantages of this feature. I will talk about it later. And measurement methods matter. You should take some time of rest, and the measurement point should be at the same level with your heart. That features makes blood pressure measurement very difficult. Let me first talk about current technologies for blood pressure measurement. Invasive blood pressure measurement is the only ground truth for continuous blood pressure monitoring. But as you may know, this is a very invasive procedure, so it cannot be done for every patient, only for blood pressure measurement. Auscultatory method takes advantages of auscultating nature of blood pressure. And this method is considered the standard method for blood pressure measurement and validating new technologies for blood pressure measurement. But it still has shortcomings. You have to go to the hospital and you have to go and see experienced people, doctor or nurse, or other healthcare personnel. And it used to use mercury manometry. These days we don't use them, but it was another issue. And oscillometry method, I think, was a very important innovation in this field. It made possible to measure your blood pressure at home. This technology uses automated cuff, and measures pressure changes delivered to the cuff. Cuff is surrounded your arm, and artery is somewhere very deep in the muscles. So the pressure is not directly delivered to the cuff, but the pressure while the pressure goes down from somewhere very high to zero, uh, some of the pressure is delivered to the cuff. So it is shown as uh, oscillations in the cuff. So you can change it into a waveform and envelope. So you can calculate blood pressure from this envelope. The assumption there's the biggest assumption with this technology is that the maximum point of oscillation corresponds to mean blood pressure, as previous studies showed. And systolic blood pressure is calculated based on this envelope. As you can see here, oscillation starts somewhere very above systolic blood pressure, and oscillation ends somewhere very below diastolic blood pressure. So it doesn't directly measures systolic or diastolic blood pressure as auscultatory method does. Instead, it calculates systolic blood pressure in relation with mean blood pressure. The, the coefficients are based on statistical studies. The algorithms differ between devices to devices, and different devices uses different coefficients, but basically all the devices uses coefficients and these assumptions. But what is the problem yet? The problem we have is, the problem we have is that people don't measure blood pressure even with such technologies. People don't measure blood pressure at home, even though they have the home BP device. Globally, hypertension awareness is no higher than around 50%, and hypertension control rate is even lower. So we hope novel technology can help blood pressure measurement even easier and comfortable. How it should be, what features should it have? We expect novel technologies to be easier to use, yet accurate, and enables continuous monitoring. There have been advances recent years, and several devices have come to the market. And recent trends is going down to wearables and cuffless approach. So let me introduce novel technologies in two ways. Firstly, cuff-based approach, and secondly, cuffless approach. Dr. Carillo made a huge contribution in this field. I'm very respectful of him. Omron Heart Guide is the only US FDA approved device. This is a cuff-based approach. Omron put all the device into a small watch device, and cuff this watch inflates the cuff and deflates it. And the algorithm is almost the same with our conventional oscillatory device. The most important feature of this device, I believe, is it enables blood pressure measurement at a certain position called auto positioning sensor of heart guide. Blood pressure is activated when you put your wrist near the heart, measuring arm angles and height. So it enables measuring blood pressure at heart level at resting point. Dr. Carillo validated the accuracy of this device compared to standard auscultatory method as well as 24-hour ambulatory blood pressure monitoring devices. again, I'd like to stress that this is the only US FDA-approved device among those devices I talk about today. This is another interesting approach. This is also cough-based approach, but it measures blood pressure at finger level. CNAP, continuous non-invasive blood monitor, is put on your fingers, and it is composed of two components. One is PPG using infrared light, and the other is pressure chamber. The pressure chamber changes over time with blood pressure, and it acts in a way that PPG flattens in a not oscillating in a continuous wave. So blood pressure is calculated based on the changes of the chamber. But as you may be aware, this measurement is not very simple. You have to do it in the hospital. So it is CE approved, but it got approval from CE, but only used in surgical room or in the ICUs. The researchers last year published an interesting study. They put all of them into a small device and made into a ring. So they showed that it can be a wearable device, but as you can see here, this is not very compact. This is still it looks still awkward to me, and it still measures pressure from the fingers. So pressure, you may know pressure from your upper arm and wrist and finger is very different. So we cannot still consider blood pressure from fingers is correlates to what we believe is high blood pressure. Secondly, many efforts these days are focused on cuffless approach. One is applanation tonometry, and second is photoplethysmography. Applanation tonometry, one device got approval from CE and is in the market. The company is from Singapore, this technology uses tonometry, which measures pressure changes and usually uses superficial artery on a bone. So usually it uses radial artery. So to use this device, you have to detect the radial artery on the radial bone and uses patches. You have to fix the area and put the device on the artery. You have to calculate the device first with conventional oscillometric blood pressure device. And after calibration, blood pressure is measured by tension transducers. They also proved accuracy and published their accuracy according to ANSI criteria, but there are still potential issues. Accuracy largely depends on the location of the artery. It should be located at the right position, and the contact force. It can, as the patient moves, it can move over time. So fixed very well is very important. So studies have shown that reduced accuracy with ambulatory setting, and in patients with increased calcium loads, such as chronic renal failure, and heart guide enabled blood pressure at this position, but this device doesn't have such an algorithm, so it can measure blood pressure with lower position than heart or even higher position. So the accuracy is quite good at night while the patient is sleeping, but it is not very accurate during daytime. Lastly, photoplethysmography, as used in Galaxy Watch, it uses PPG, the same technology we use in the hospital for oxygen saturation, but it uses instead of transmissive absorption, it uses reflection, and LED is almost the same. This technology uses pulse transit time. With ECG, you can detect the time point of heart contraction, and with PPG, you can measure the time point at the pulse comes to the wrist. So using the time difference, you can measure blood pressure transit time, and the assumption is that pulse transit time is inversely correlated with blood pressure. As blood pressure goes up, transit time goes down, and with blood pressure goes down, pulse transit time goes up. And with the data from Samsung submitted to Korean FDA, they showed quite good accuracy. R square is over 0.8, and yeah, accuracy was quite good according to their data. And it looks a little degraded at higher levels of blood pressure. But one independence, I'd like to stress that there are very limited number of studies, published studies in peer-reviewed journals. Samsung didn't publish the data in a peer-reviewed journal. And there are very limited data using such PPG-based devices in peer-reviewed journals. One independent study recently published validated Samsung Watch's blood pressure values. They compared it with 24-hour ambulatory BP device in 40 patients. As you see here, data points are not very correlated. It looks just concentrated in the center. So the conclusion of this study was that there was a systematic bias toward a calibration point. When you calibrate a blood pressure with conventional oscillometric device, this device tends to measure blood pressure to the calibrated point. So when blood pressure goes high, it tends to measure it to the calibration point. Even though the blood pressure goes down, it tends to show it at the calibration level. Why is that? There are too many assumptions in this technology. Like elastic modulus of your vessel differs between people to people, and it is not fixed over time. Thickness, radius of the vessel, and blood density are not fixed values. It changes over time. So I think there are too many assumptions to use pulse transit time. Studies also show that blood pressure and pulse transit time, in general, have inverse correlation, but there are high variation from people to people, and even in one person, the relation is not very good. Correlation is not very good. So Fitbit and Apple Watch, they don't want to show blood pressure directly, and Apple Watch plans to show blood pressure variability instead of BP values. But it was 1 year ago. They haven't put BP function in new Apple Watches. Lastly, this is a very smart approach. They took advantage of pressure strain sensor in Apple Watch. So they trained the user should be trained on the iPhone screen to apply pressure continuously. So when the user accomplishes the task, increases pressure slowly and decreases slowly, then you should put your finger on the camera. You can measure PPG from the camera. So it works like oscillatory methods. So it is a very smart and interesting approach, but still have limitations that it measures blood pressure at fingertips, very small capillaries. So I doubt there are very reliable blood pressure changes at fingertips. There are many other interesting approaches like radar-based approach. It is similar with tonometry, but radar can be more reliable in ambulatory setting. Another study published in Nature used ultrasound sensor to measure blood pressure. And there are recent advances in material science. Enabled pressure sensor directly measures pressure from the human skin. So I believe that new technologies have convenience, but I still think that we should be more cautious. We need accuracy, and one big limitation is need for calibration. So we expect them to enable easier measurement of blood pressure, but I think we need more data to use them in our clinical practice. Thank you for your attention.
Yes, thank you very much. Now we have 40-minute panel discussion time. Also, Professor Kang and Professor Carrier will be joining with us in online. We have three panelists: Professor Kim Dae-hee, Professor Park Jun-bum, and Professor Lee Soo-young. Please start, please.
I have thank you for your lectures. I have one question with Dr. Yu. Yes. It's very impressive to adapt to RCT to real-world data. As you said, the actual outcome and potential outcomes are different. Nonetheless, a physician have treated patient based on potential outcome. So, which in the future, which practice or shift change and occur in the future?
Is there any mic available? Okay. Yeah. So I think that we are pursue the personalized medicine, which is not well implemented in current clinical practice. So. Usually in the previous, we found some subgroups with very distinctive clinical situation, such as as I shown that the ischemic stroke, very after the ischemic stroke, we will not use the intensive blood pressure control in these patients. But the machine learning algorithms can specify more delicate subgroup features by using more covariates or more data. So it will be essential that to revise or change our EMR system. So we need to revise the IT infrastructure for the implementation of personalized medicine, because we have the tools and machine learning algorithms which can be applied, but current EMR system cannot support this implementation.
Okay, I have another question to Dr. Yu. I can clearly see in your data the improvement in the prediction performance after some trials of machine learning algorithm. But the problem is we are already focused on the statistical significance. I think there may be a statistical significance, but in clinician's viewpoint of view, but the change in the prediction performance measured by C index are just small. But in the clinician viewpoint, the change, the number itself seems grossly same. Is there any other suggestion for interpretation of your data in clinician's viewpoint?
That's really accurate comment. So even though there is a slight improvement in the machine learning compared with the precise depth score, it does not really outperform the precise depth score. So we have to admit that. But I'd like to show that it is possible and feasible to apply the machine learning algorithm to identify some subgroups that who will have the benefit from the treatment and without any increase of harm. So that is my purpose. And actually, when we validated precise depth score in Korean data, we found that that score is not really works well, such as in the Western countries' data. So, but again, I need to admit that the improvement is really slight, so it is not really outperformed in current data set. But we need to think about that. I aggregate 5 different clinical trials across the time span. So that there are really heterogeneities in the trial population and then and the intervention too.
I have one simple question, Professor Yu. You introduced the interesting calculation method to HTE. I have one simple question. Can we use the HTE regardless of database type? For example, the prospective randomized database or the cohort, the retrograde database, and so on. Regardless of, can you use this method?
So as I told in the final remark that we can use the observations data or non-randomized data to estimate HTE. But again, in this situation, when we estimate the counterfactual outcome, we need to adjust the hidden confounder. So we usually use the propensity score model to balance the 2 arms, intervention and control arms. So if we can balance these 2 arms sufficiently by using observation study data, either using propensity score model or either using representation learning or deep learning, it is possible to estimate HTE. But in the real world, if when we want to compare the intensive control BP control arm and versus standard control arm, I'm not sure that we can really balance these 2 arms, but there are many cases. So if we can find some very good balanced treatment arms and the control arms, and then it is possible to estimate HTE by using real-world data.
Thank you very much. I have one question, Professor Kang Seok. Yeah. Your lecture is very interesting. I'm interested in the corporate BP monitoring in daily life. However, the corporate BP monitoring, including PPG and so on, have some limitation because of motion defect and noise and accuracy and so on. However, during procedure, for example, intervention and so on, patient is stable and supine position. During procedure, can you use the non-invasive BP monitoring, including PPG? And so, can you use this? How about,
thank you. Yeah, thank you for the very good question. Yes, in short time, the variables I said early in the presentation can be assumed fixed, like vessel diameter, vessel wall thickness, and blood density. So accuracy may be higher in fixed position, like during procedure or surgery, but there haven't been studies validated this method in clinical practice. Like during surgery, blood pressure may go down very extremely, or blood pressure go up during PCI very extremely. I think it is a good approach, but I don't think we have enough data on that.
Thank you very much.
Professor Kario, this is Hae-young Lee from South Korea. May I ask your know-how how to digitalize home blood pressure data from patient? When patient visit our clinic, the patient write down 2 pages, 3 pages of their home blood pressure data. But for the analysis, we have to digitalize that data into our medical record. But frankly, it takes too much time for me to write down all the one. How can you do in
Yes.
your analysis
Yes,
for home blood pressure data?
Thank you very much for important, very clinically important comments and questions. So we usually use using the home blood pressure monitoring device with the Bluetooth. Bluetooth could transmit the data, home BP data into the smartphone, and then through the smartphone, we can collect the server of each individual's home blood pressure data. So we can see the cloud computer data of the trend of the home blood pressure. This is the most easy way. But the elderly people still does not have the smartphone. In such a case, we are now developing the low power energy, which could be directly transmitted to the cloud computer, and we can correct the time trend of the home blood pressure. This is a newest one. So the direct, even smartphone, the patient doesn't have the home BP data transmitted to the cloud database through the low power energy, the home blood pressure monitoring device. This is the A&D device.
Thank you very much.
And also the concerning the questions of the last two the commentators for the second so transient blood pressure increase. This could be important. The most directly method to detect such a transient surge is the direct method, but the second is the tonometry. Tonometry could be relatively accurately detect the surge blood pressure because of the tonometry is the signal of the pressure to translate this signal to the absolute value of the blood pressure. So this does not depend on not so much depend on the characteristic of each patient, the arterial characteristics. So thank you.
May I ask a question to Dr. Caio?
Yeah.
Yes.
Yeah. I read your paper with a lot of interest. It was very interesting. One of the limitations I thought was that you enrolled drug-naive patients. Drug-naive patients, the system was helpful, but do you think it is helpful to patients on antihypertensive medication?
Yes, for digital therapeutics, you mean?
Yes.
In our prospective study, first phase is a drug naive, but after the 12 weeks, we still the difference between the digital therapeutic group and the control group significantly remained. So I think even on med group treated with medication, the patient they still have the benefit by digital therapeutic group, but we analyze which drug is most have the benefit to synergistically reduce blood pressure, but we couldn't find out the class difference of the drugs. But definitely even on med patient will have the benefit of the digital therapeutics. But we should consider about the adherence of the drug, because of med group we can identify the power of the efficacy of the blood pressure reduction by digital therapeutics without any effect of the drug adherence. So we expect not only digital therapeutics, but also the renal denervation trials. A lot of patients, the partial non-adherence. Somehow, drug adherence should be the very big problem to evaluate the efficacy of the new device if we target the unmet patient.
Thank you for the response. I expect more publications from your research group on this subject.
Thank you.
Thank you very much. Now due to the limitation of time, we have to wrap up this session. Thank you very much all for excellent speakers and panelists and all the audiences. We will close this session.
Thank you. Thank you very much for inviting.
everyone. Now we have two special session, the epidemiology working group session. The title is Epidemiology of Hypertension in East Asia. My name is Hyunchang Kim from Yonsei University, Korea, and my co-chair is Dr. Yuichiro Yano from Shiga University of Medical Science in Japan. So for this session, we have 4 excellent speakers from UK, China, Japan, and Korea, and also 3 panel discussants. And I'll introduce first 2 speakers, and Dr. Yano will introduce last 2 speakers and moderate the panel discussion. First speaker is Bin Zhou from Imperial College of London, UK, and he's a doctor. He got a doctoral degree from Imperial College of London, and he got a master's and bachelor's degree from Tsinghua University. Currently, he is working as an active member of NCD Risk Factor Collaboration, and today he will talk about the worldwide trend in hypertension prevalence and progress in treatment and control from 1990 to 2019. Dr. Zhou, please go ahead.
Thank you. Thank you, Professor Kim. And I'd like to thank all the organizers and for inviting me here and for making this experience so smooth and enjoyable. And it's a great honor for me to be here to present on behalf of the NCD Risk Factor Collaboration about our work on the global trends in hypertension prevalence and the progress in treatment and control from 1990 to 2019. So this is my disclosure. So I don't think this is the audience where I need to stress much about the importance of hypertension in the context of global disease burden. But just a reminder, this blood pressure is responsible for over 8 million deaths annually from cardiovascular and renal diseases. And in recent years, there's been a renewed attention to hypertension management in the global efforts to reduce the burden of non-communicable disease, or NCDs, mainly because of the fact that blood pressure can be measured pretty straightforward in the clinical setting, and there is proven medication for its treatment, and which is also very cheap to use. So there are a lot of efforts recently to see how, on this background, how we can we improve its treatment to reduce the huge burden from uncontrolled hypertension from different countries, especially in resource-limited settings in low and middle-income countries. So on this background, we set out to understand on a global level what's the prevalence of hypertension, how it's been changing over time in different places, and how well different countries are treating their patients with hypertension and bring them under control. So this work is based on the platform of the NCD Risk Factor Collaboration, which is a worldwide network of over 1,500 collaborators. We pool and analyze global data on a population-based measurement of cardiometabolic risk factors, including body mass index, obesity, blood pressure, diabetes, and blood lipids. So we work very closely with the World Health Organization, and we have developed a website here at www.ncdrisk.org, where we host our country results and a very carefully designed set of visualizations for users to explore and use our results. So at this point in time, we have nearly over 3,400 studies that has measured height and weight on 200 million people from different parts of the world. And we also have over 2,000 studies that measure blood pressure on 120 million people, and over 1,000 that has had blood measurements for diabetes and blood lipids. So for the results I'm going to show you today will be based on a subset of the data that I just showed you there, and which had covered people aged from 30 to 79 years old with objectively measured blood pressure levels and data on their treatment history from 104 million participants from 1,201 studies. And this is a map of the number of studies by country used in this analysis. As you can see, we have a lot of data in many parts of the world, but there's a scarcity of data in some other parts, notably in Sub-Saharan Africa, Eastern Europe, and Central Asia and parts of Southeast Asia. So, and based on these data, we then used a statistical model that we have developed, which is a Bayesian hierarchical model that took into account the availability, the totality of the available data, and similarity of different countries to make estimates for country and years where we don't have data, and estimate the full time series of hypertension treatment and hypertension prevalence, treatment, and control for all the countries in the world between 1990 and 2019. So here are the results. So for prevalence of hypertension, which is defined here in the text, and in 2019, the prevalence globally is around 32 to 34% age standardized. And you can see this is not distributed evenly in different places. It's higher, especially in Eastern Europe, as well as in Sub-Saharan Africa and some parts of Latin America, and it's much lower in Western Europe and in North America and some other parts in Asia and Australia and New Zealand. And in terms of change over time, we have seen a massive decline in hypertension and in places in Western Europe and as well as North America, but there's also a massive rise in especially in Southeast Asia and some other parts of Africa. So as I pointed before, we have a relatively smaller number of data sub-Saharan Africa, so we cannot say with much precision what has changed there, but we do know well that they have a very high level of hypertension. So there may be some debate on how much we should treat these people with blood pressure. Some may argue that we should look at cardiovascular risk before putting them all on medication. But I think there's a little doubt over whether we should treat people with stage 2 hypertension, which defined as systolic over 160 millimeter mercury and diastolic over 100. So, however, we are not, even in that aspect, we are not doing well in most of the places in the world. So this map shows the percentage of people with hypertension who has a stage 2 hypertension but are not being treated. As you can see globally, there's a two mode in the distribution. The lower one corresponds to the higher income countries, which has the percentage around 2%, and in the higher one around 30%, which is what's happening, we are seeing in low and middle income countries. And when we look at hypertension as a whole, and we can see that over time, since 1990, the coverage of treatment has improved in most parts of the world. However, there remains a big divide between the high-income world and low- and middle-income countries. That in the high-income countries, we are now seeing treatment coverage over 75% in places like Canada and the United States, whereas in Sub-Saharan Africa, in many parts of Oceania, we are seeing very low levels of treatment. And even among people who are being treated, there is a big variation in different places in terms of how much of them have achieved control. So we have seen, like in this scatter of countries, on the of the percentage of people who are being treated and or who are being controlled, we can see on the top right corner you have countries with high treatment as well as good control among people who are treated, and moving down here where you have a medium level treatment, but among people who are treated, they are controlled to a good level. And then here where you have, compared to the second group, they have similar level of treatment, but now they have much lower level of control due to some on the performance in achieving control among those who are currently being treated. And then in the lower left corner, you have countries who are doing poorly in both treatment and control. And taken as together, we are now seeing, again, very large variations in terms of the level of control of hypertension in different countries. So again, it's high in North America, Western Europe, where we have achieved control levels over 55%, which is high compared to other countries, but still with much room for further improvements. And in Sub-Saharan Africa and South Asia and Southeast Asia, some countries have achieved control rates as low as single digits. We may see that hypertension, you might think that hypertension is already being treated well in high-income countries, but as we can see here, it's not exactly the case. So in the global leaders in Canada, which are the black points here, again, I should say these are the national surveys done usually by the National Statistics Office, and this is for men aged 60 to 69 years old. So in each point is a survey, and over time you can see this improvement since 1980s. But in the recent decades, since around the year 2008 or 2009, there seems to be plateauing in all of these, most of these countries. So in the global leader in Canada, I've seen they have achieved 75% control, but it has not improved since like 2010. And similarly at UK for the lack of improvement, but they are plateaued at about half of the percentage of control as we are seeing for Canada. And these are the levels for South Korea. And for Japan, again, not improving much in the recent years. And there's a big difference between these two countries, which are neighbors and share many similarities. And this paper did not include China because we focused on high-income countries, but if we had China on this chart, we would have seen them around here. So at the same time, we have seen in some regional programs, this is not like a small clinic, but rather a regional program administered by Kaiser Permanente in Northern California in the United States. We've seen that they have achieved 90% of control by doing some very well-designed, coordinated and well-designed programs. So we see that although there are a lot more difficulties to achieve such high percentages at national level, but there's certainly a lot of room for improvement even in these high-income places. So in order for us to improve control, we need to know where in the treatment cascade that people are not we are losing patients. So this is like a flow diagram, if you like, for the cascade of treatment for starting from 100% of people with hypertension, moving on to around 50% who have been diagnosed, which is global average, and to 30% who are treated, and down to 12% who have achieved control. And gray sections show the percentage of people who are lost during this process, who are not diagnosed, who are diagnosed but not treated, and who are treated but not controlled. So for each of these gray sections, we have a menu of strategies that could be used to improve, to close the gaps. So for example, by implementing universal coverage of health insurance, we can improve the patient's contact with the health systems, that does improve their chance of being diagnosed, and remove some or even all of the barriers to treatment, and by implementing opportunistic screening in clinical settings, or targeted screening in, for example, cardiovascular risk screening programs with hypertension measurement, blood pressure measurement, we can improve diagnosis rate but not necessarily treatment or control. And clinical guidelines is at the center of all these, and having one that is suitable for the context of the country is crucial for its successful uptake. There are many others that I have not mentioned here, and of course we should not forget public health intervention to reduce hypertension to start with, for example, by salt reduction. So now this is the same chart, but now for individual regions. I'm not now showing just first for high-income Western countries, now rotated 90 degrees. And so this is a region made of Western Europe, North America, Australia, and New Zealand. We can see that there in these countries, the biggest gap in the biggest leakage in the treatment cascade is in among undiagnosed as well as people who are treated but not controlled. Whereas in high-income Asia Pacific, which is a region that we basically made up of South Korea, Japan, and Singapore, where we have seen similar patterns compared to high-income Western countries. Whereas when we move to East and Southeast Asia, which is dominated by China here, you can see there's nearly half of the patients there have not been diagnosed, and a big part are being treated but not controlled. When we move to some other poorer regions in the world, the gap in undiagnosis is even bigger, and in some other parts of the world, they are somewhere between these two extremes. And in the interest of time, I'm going to skip this. And we have seen also some interesting age patterns between different parts of the world. So different colors shows the percentage of people who have achieved diagnosed, treated, or controlled hypertension. And you can see that in high-income Asia Pacific here, we have achieved quite good control in the older ages. However, the performance in the younger ages are not as good as we have seen in regions like high-income Western countries, whereas in East and Southeast Asia, the performance is like poorer across all the ages. And for women, generally achieving better treatment and control than men. This is happening in almost all the countries in the world. And this is a summary. So we have seen hypertension decreasing in high-income countries, but increasing in some low and middle-income countries. I've got to say that we have seen some very good performers, not in the high-income world, but in the middle-income countries. For example, Chile and Kazakhstan and Costa Rica, which has done better, even better than many of the high-income countries. So it shows that this is possible to achieve with a very carefully designed program. So this acknowledgement goes to our worldwide collaborators as well as the central pooling team who are mostly at Imperial College London. And I should say ancillary risk is at the moment actively expanding and updating. So we welcome all studies with population-based measurement to join us. If you are interested, please speak to me or email this email address. And thank you very much. Looking forward to the discussion later.
Okay. Thanks for the wonderful presentation. I'm sorry for not giving enough time. And at the discussion time, you can have a question and comments. And we are moving to our second speaker. Our second speaker is Jiguang Wang from China. He's director of the Shanghai Institute of Hypertension and director of the Department of Hypertension in Louis-in Hospital and professor of Shanghai Jiaotong University School of Medicine. Actually, he's very familiar face to the member of Korean Society of Hypertension. He gave us many excellent lectures, but unfortunately, today he cannot come, and we have the pre-recorded lecture, and he will join the discussion online later. Please go ahead.
It is a pleasure for me to give a short presentation on epidemiology of hypertension in China. I should first thank the online committee for this very kind invitation to give this presentation in this year's Korean Society of Hypertension meeting. If we look at the global data, we can see that high systolic blood pressure remains the leading cause of death over the world. In 1990 and 2019, it was the first cause of death. And if we look at the data from individual countries such as China, India, Russia, the United States, or Indonesia, we can see that in China and India, the number of cardiovascular deaths increased from 2010 to 2019. In other countries, either no big change or even slightly reduced. What was the reason for this substantial increase in the past about a decade in China and India? The low control rate of hypertension in these countries must have contributed to this substantial increase in the number of cardiovascular deaths, especially when we compare with several countries such as Japan, Korea. The control rate of hypertension was quite high. And if we look at the data in China from 1991 to 2012 and 2015, actually the awareness of hypertension increased substantially, and the control rates also increased. But if we look at the rate of awareness of control of hypertension, it was still quite low. The awareness was still less than half of the hypertensive patients, and the control rate was less than 20% of the hypertensive patients. Recently, we reviewed the epidemiological features of hypertension in China. If we first look at the changes in prevalence of hypertension in past years, you see the prevalence of hypertension increased substantially from about 60 years ago in 1950s and 60s to current recent survey in 2012. Along with this increase in the prevalence of hypertension, you can also see a very rapid increase in life expectancy. So it means that the prevalence of hypertension actually increased with the increase in life expectancy in China. So it means in the elderly, there are a large number of patients with hypertension. And if we compare the two different surveys in 1991 and 2012, these two surveys were about 20 years apart. And then if we look at the changes from 1991 to 2012, actually in all age groups, the prevalence of hypertension increased very substantially, especially in young and middle-aged groups. For instance, from 45 to 55 years, it almost doubles the prevalence of hypertension in the past about 20 years. Then if we look at the geographical features of the prevalence of hypertension in China, you see that actually the prevalence of hypertension was high in almost all provinces, but still you can see in some provinces the prevalence was extremely high, mainly in northeastern China and southwestern China. In these provinces, probably they have especially unhealthy lifestyle, and they have a higher prevalence of hypertension than other provinces. But actually, even in the provinces with slightly lower prevalence, it was also quite high. The lowest was about 16% of the adult population. We also look at the prevalence of grade 1, 2, and 3 hypertension in very recent 2012 China survey. You see in China's population, the prevalence of grade 3 hypertension was still very high. So it means that we have a lot of people with a systolic blood pressure higher than 180 and diastolic blood pressure higher than 110. So that's why we kept the definition of grade 3 hypertension in our 2018 Chinese hypertension guidelines. Probably we still have to keep this grade 3 or stage 3 hypertension definition in our new hypertension guidelines. And in this review, we also look at the change in lifestyle in China, and now we can see the change in sodium and potassium index from 1990s to 2010s in China. You see sodium excretion as assessed by urinary sodium excretion slightly decreased, and potassium intake remains at a quite low level. And then if we look at the protein and fat intake, then you see a very big change in both dietary nutrients with increase in fat and slightly decrease in protein. And we also look at the change in physical activity and sleep duration in hours from the 1990s to 2010s. You see physical activity substantially decreased from 1990 to 2010, and even sleep duration in hours slightly decreased from more than 8 hours to currently less than 8 hours. We also look at the lifestyle change, alcohol intake, cigarette smoking, and the prevalence of overweight and obesity. You see some positive changes in the prevalence of cigarette smoking and alcohol intake overall, but we also see a negative change in prevalence of overweight and obesity. Yet these health problems increased substantially in the past about 20 years. And we can also look at the awareness, treatment, and control rate of hypertension in past years. You see from 1991 survey to 2012 survey, and you see a very big change or increase in the awareness, treatment, and control. Then we can also look at aware and treated, and treated and controlled. You see the treatment rate in those patients who were aware of hypertension actually very high. So it means that with the nationwide health insurance coverage, actually the treatment rate of hypertension increased from less than 50% to the current around 80% of those hypertension patients. And then if who are aware of the disease, of course, and then if we look at the treated and controlled, the rate was pretty low. It increased from 23% to the current more than 37%, but remains at a quite low level. So what can we do, or what shall we do to improve the management of hypertension, and finally, of course, the control rate of hypertension? And we can do several things. For instance, these salt substitution trials show that if you use potassium-enriched salt, you may reduce blood pressure, and you can even reduce the risk of mortality and cardiovascular events. But we probably have to do more and better if we look at this very nice picture. Actually, that's what we are doing in the main measurement analysis project in China in many different measurement sites. And we used web-linked blood pressure measurement system for blood pressure measurement in those measurement sites. And we did measurements in more than 1 million people in the past few years. And in the meantime, we're establishing infrastructure for management of hypertension in tertiary, secondary, and even primary care centers for hypertension C. It is a web-based system linking those patients and physicians. So in this platform, we establishing this automated office blood pressure measurement system in the clinic, and we are also establishing this web-based ambulatory blood pressure analysis and reporting system, and this system also works for standardized home blood pressure monitoring analysis and reporting. So these days we can also utilize home blood pressure monitoring to diagnose hypertension and to do therapeutic monitoring in treated hypertension patients. And we can do more with so-called artificial intelligence technology. For instance, we can do atrial fibrillation screening in high-risk patients, those older than 65 years. So we did this randomized controlled trial. We have shown that if you do quarterly ECG recording, you can substantially improve the detection of atrial fibrillation in those elderly people. And we are also doing primary aldosterone screening in hypertensive patients, mainly in tertiary and secondary hospitals, because many actually patients, especially those with uncontrolled or resistant hypertension, they may have these primary aldosteronism, so need to do screening in hypertension patients and to treat them more properly. And of course, we also need novel anti-epileptic drugs in China. Cubatril or valsartan was approved to treat hypertension. Since we did this blood pressure learning trial some years ago, and still a very potent blood pressure learning action with this ARNI. Then we are also trying to develop even newer antihypertensive drugs. Is a endothelin receptor agonist, aprocitentan, and that's the result of this trial. Actually, the phase 3 trial has been recently completed and will be reported in the upcoming American Heart Association scientific sessions, and also will be published in Lancet simultaneously. And in China, we are also using Chinese herb medication. We hope that with this, we can also do something to improve the control of hypertension. And if those drugs can be effective in reducing blood pressure, and then we probably also should consider those herb medications in management of hypertension in this country. And finally, I would conclude that the prevalence of hypertension in China is still high, and the control rate of hypertension is still rather low. We may need to do more nationwide initiatives. For instance, the main measurement mass project. We want to utilize this nationwide initiative to improve awareness of hypertension. And we are also establishing intelligent hypertension excellence centers for decreasing treatment failure in treating hypertension patients. Of course, we also need more innovative antihypertensive drugs and devices, and to treat and manage hypertension more properly in the future. Thank you. Thank you very much.
Thank you for the wonderful presentation. And now we are moving to our third speaker.
Okay, the third speaker is Dr. Katsuyuki Miura from Japan. He's a professor and chair of the Department of Public Health, Shiga University of Medical Science. And he is also director of the NCD Epidemiological Research Center at Shiga University. So his talk title is The Trend of Hypertension Prevalence and Management in Japan. Please go ahead.
Thank you, President and chairpersons, for giving me opportunity to talk today. So I will talk about the trends of hypertension prevalence and management in Japan. nothing to declare. Okay, so this is a figure published in The Lancet in 2011, and then it showed the number of deaths attributable to various risk factors in Japan in 2007. And the top cause of the death in Japan is smoking, and about 120,000 people died by smoking. And next, second cause is high blood pressure. And it was estimated that about 100,000 people die in a year in 2007. Anyway, also in Japan, the high blood pressure is very strong and the major cause of the cardiovascular diseases. And this figure showed the long-term trend of the mean systolic blood pressure in Japanese, and the data from the national surveys and for about 60 years. And in 1960s, for example, in a man aged 60s, the mean blood pressure was the systolic blood pressure was about 160. And after that, for these 60 years, the blood pressure, mean value of the blood pressure decreased very much in both men and women and in all age groups, including younger people. But this is a long-term trend of the hypertension prevalence in Japan. And the hypertension was defined as the systolic and diastolic blood pressure 140, 90 or over, or taking antihypertensive medication. So looking at this for about past 40 years, especially in men, the prevalence of hypertension didn't decrease in the age group of 50s or 60s or 70s. And the prevalence is still high in women. And although the mean value of systolic blood pressure decreased very much, but the hypertension prevalence didn't change over time. It means that the hypertension is not yet well prevented, but in older people, they are detected and treated, and their blood pressure decreasing. But we have to prevent the hypertension in these age groups, especially. And this is a long-term trend of the treatment rate in Japan from the national survey, and it has been increasing in both men and women, but the treatment rate is lower in a younger group compared with the older group. And this is the long-term trend of the control rate, and this rate is a proportion of of those with a blood pressure less than 140/90 among treated hypertensive people, and it increased. And the control rate has been improved, but still in 2016, the control rate is still around 40%. It is not sufficient. So this is the data from the NCD risk factor collaboration, and prevalence of hypertension in Japan is lower among the 12 high-income countries, and South Korea is here. And the awareness is still lower in Japan, and our treatment rate is lower. and control rate is low. So it is not good, the control in Japan. So we estimated the number of the hypertensive adults in 2017 using national survey data. And we estimated that the number of hypertensive adults is 43 million people. And among them, only 27% are treated and also controlled. So, so the rest of the hypertensives are not controlled, and the 29% are aware but not untreated but not controlled, and some are aware but not treated, and about this part, 33% are not aware of the hypertension. And in 2019, the Japanese Society of Hypertension make a new guideline, and we renamed this category lower than 120 and 80 as a normal blood pressure. It is similar to the American guideline, and we try to make people more normal blood pressure, so we renamed this category. And this is the data from the national survey in 2016, and it shows that in younger women, a majority of the women have the normal blood pressure, but even in younger men, the proportion of the normal blood pressure is low, less than 50%. And in older women and in older men, the proportion of the normal blood pressure is very small. So, so we have to do primary prevention of hypertension by a lifestyle improvement to increase the normal blood pressure people. So in this paper, we evaluated the number of the hypertension people using a national administrative claim database study. And this is a national database of the medical claims. And the data sources from about 100 million people in 2014. And we estimated that the hypertensive disease people, a number of hypertensive diseases, 27 million people. And this estimate is similar to our estimation from the national survey. So this is the distribution of the hypertensive patients in this 27 million people, and it shows that the number of hypertensive people, especially in women, the women aged 80 or more have the many hypertensive people here. And from this survey, we also knew that about half of the patients are treated in small clinics without a bed. So we have to improve the quality of the treatment in these small clinics all over Japan. So this is a policy of the Japanese government named Health Japan 21, It was made in 2012, and the goal is for the 2022. So, and in this goals, the government said the blood pressure, mean blood pressure level 4 millimeter mercury lower in this 10 years. And this is the mean value of the total population. And to achieve this goal, these are the nutrition and the physical activity and alcohol drinking control, and as a population strategy. And also they set the goal to increase the treatment rate. And in 2017, Japanese Society of Hypertension also made a goal to control the blood pressure, to decrease the prevalence of hypertension, and also increase the treatment rate, and increase the control rate. And we estimated we can reduce the 7 million people with uncontrolled blood pressure from 35 million to 24 million. Okay, in summary, I summarized the epidemiology of hypertension in Japan, and blood pressure level largely decreased, but the prevalence of hypertension is still high. And the rates of treatment and control improved, but still not enough. So continuous efforts to prevent, treat, and control hypertension are needed also in Japan. Thank you for your attention.
Okay, thank you so much. And the fourth speaker is Dr. Ho Kyo-ri from Yonsei University. His talk title is "A Trend of Hypertension Prevention and Management in Korea." So, Dr. Ri, please.
Thank you for the introduction, and it's a great honor to participate in this this important session. So, the Korean Society of Hypertension Epidemiology Working Group produces the Korea Hypertension Fact Sheets to report up-to-date trends of hypertension prevalence and management in the Korean population. So in 2018, we reported for the first time the national trends of hypertension prevalence and management, and in 2019, we explored socioeconomic and regional disparities in hypertension management in Korea. In 2020, we focused on young adult hypertension and brought attention to unmet clinical needs in hypertension care for younger adults. And in 2021, we highlighted women's hypertension and hypertensive disorders of pregnancy. So today, we are releasing the new Korea Hypertension Fact Sheet 2022, which features a special chapter on elderly hypertension and population aging. We analyzed two national databases for this fact sheet. The first is Korea National Health and Nutrition Examinations Survey. The KNAs, so like the US NHANES, we can estimate population-weighted statistics based on multi-stage complex survey design. And the second is the Korean National Health Insurance Big Data, which included healthcare utilization data for all patients with hypertension in Korea. And in both data sets, we analyzed adults aged 20 years or older from 1998 or 2002 to 2020. So the average blood pressure of Korean adults above age 20 is 118/76, remaining relatively stable after 2008, following a slight decrease from the late 90s. And the crude prevalence of hypertension is 29%, also remaining largely stable for 20 years if adjusted for age. By sex and age, we here included the older adults above age 80. And the prevalence is higher in men before age 60 compared to women, but after age 70, the prevalence becomes higher in women. And these prevalences translates into an absolute count of 12.6 million men and women having hypertension in Korea, which has rapidly increased from 7.7 million in 1998. And the increase was most apparent above age 65, and especially in older women. The following the chapters report trends of awareness, treatment, and control in Korea by sex and age. And the awareness rates markedly increased over the last 20 years. And this more than doubled from around 30% in 1998 to around 70% overall. And this really plateaued during the last 10 years. The awareness was generally higher in women than in men, and also in the older ages than the younger ages. And these trends were similar for treatment rates, but for control, the control rates really peaked around age 60, and then it either stays similar or actually slightly decreases as more advanced ages. And this is among treated, and the trend is more obvious. So after age 60, the control rates really stay similar or actually decreases in very old men and women. The next chapter includes the healthcare utilization data from the National Health Insurance data. And over the past 20 years, the number of people diagnosed with hypertension increased more than threefold from 3 million in 2002 to 10.5 million in 2020. And the number treated also increased dramatically, and people adherent to treatment was 7.3 million in 2022 and 2020. Among people treated for hypertension, a sum of 64% were also treated for either dyslipidemia or diabetes. And this number increased rapidly over the last 20 years. And also among people treated for hypertension, about 60% were taking a combination of more than 2 classes of antihypertensive medication. By individual classes, the angiotensin receptor blockers were the most commonly used class in the Korean population, and this surpassed calcium channel blockers since 2012, and it's now the number 1 used drug. And the ARBs comprise 50%, and CCBs comprise 38% of monotherapy, and their combination constitutes around 2/3 of dual therapy. So the use of RAS blockers is really predominant in pretty much all age groups, but the shares of calcium channel blockers and diuretics relatively increase over the older ages. By number of classes, the combination therapies are prescribed for 2/3 of middle-aged men, but at lower rates among older men. Whereas in women, the combination therapy rates increase by age, and being at par with that of men above age 80. But now, if you recall the control rates that decreases by age in women and falling below men after age 60, these data together really calls for attention regarding blood pressure control in elderly women. So the final chapter, this is kind of reorganizes and summarizes the previous data in the perspective of elderly hypertension. So first, we revisited the number of people with hypertension below and over 65 by management status, and we can see that the number of elderly hypertension almost tripled over the last 20 years, but fortunately this increase was mostly due to treated and controlled hypertension. However, still about 40% of elderly hypertension are still untreated or uncontrolled. So the average blood pressure in the elderly hypertension, this is among people with hypertension, this has significantly decreased from around 160 systolic in 1998 to less than 140 in the recent years. So the Korean guidelines, the blood pressure target for older age is 140/90. So this, the average on average, this looks about right. Now the interesting thing is that this average systolic blood pressure is actually similar or even lower than that of young adult hypertension. So although this is not the main focus of this chapter, this level, and especially this very high diastolic blood pressure in young adults, is actually very concerning. Now among treated hypertension, the average blood pressure declined even further, reaching around 130 systolic and of course well below 80 diastolic among older ages. The awareness rate rapidly increased above 80% in the elderly over the last 20 years, but this really plateaued over the last 10 years. But this is still in stark contrast relative to the younger adults, which really shows almost no improvement over the last 20 years. So the trends were similar for treatment rates and for different adherence rates also. And the trends of combination therapy, this interestingly actually peaked around 2010 and 2012, and then it started declining thereafter. So we think that this change might have coincided with the more lenient blood pressure guidelines during this era after the Accord BP trial in 2010. And since we now have a more strict blood pressure target after SPRINT trial, so will the combination therapy rate increase after 2016? So this is actually yes. The rate increased more clearly in the Middle Ages, but in general, the combination therapy rate started increasing again after 2016 and 17, and we'll actually have to see the trend more in the following data. Let me now summarize our findings. A total of 12.6 million Korean adults have hypertension, and 10.5 million are diagnosed. 9.9 million are treated, and 7.4 million are adherent to treatment. The prevalence was 29.4%. The awareness, treatment, and control rates were 69.5, 64.8, and 47.4%, respectively. And among these people with hypertension, 5 million were above age 65, 1.2 million were above age 80, and the number is rapidly increasing, but mostly due to the increase in proportion of controlled hypertension. The management rates markedly improved, especially among older adults, but the growing absolute number of elderly hypertension is likely an important public health challenge for future reduction of cardiovascular disease in Korea. Thank you very much.
Okay, great talk. Thank you so much. And next, we would like to move to the panel discussion, including from Dr. Jumi Lee from Shangnam National University, and Heoku Hee, Dr. Heoku Hee Lee from the Yonsei University, and Dr. So-Min Cho from the Broad Institute of MIT and Harvard. So first of all, Dr. Jumi Lee, do you have any question or comment from on each certain presentation?
Yeah, thank you for the beautiful lectures. First of all, the very optimistic point is that management of hypertension, at least one of the index, is improved in all 3 countries, which is great that all the effort were rewarded. However, the population structure of East Asia is getting older, and young unknown hypertension is still an issue. Therefore, the prevalence of hypertension will be increased. I want to ask all the presenters, what is the priority right now to control hypertension for 10 years? What we can do additionally from what we have already done? And if there is any other form that East Asian collaborators can do.
Okay, thank you so much. Given a time, because we only have a 15 minutes panel discussion, so I would like to ask Dr. Zhao as a representative from the lecturer. So Dr. Zhao, do you have some answer from the question from the Dr. Jumi Lee?
Thank you for the question. Well, I thought it might be better for the people who have experience in the country to answer this, but I will try my best. I think where more efforts are needed really depends on where we are at the moment in different places. I think even in East Asia, we see very different patterns in current performances across even these 3 countries. So, for example, in China, I think a lot of efforts needs to be focused on like how do we detect and capture more people with hypertension with like existing health infrastructures or with some form of reform in order to do that. And that's especially important because at the moment, there are only half of the patients with hypertension are being diagnosed, meaning that if we are to improve that, the health system will deal with twice of the number of patients, and that will put huge burden. That has a lot of implications downstreams. And of course, there are like improvements needed in every stage following that. And in places like South Korea, I think you have a very good surveillance system. You can highlight a lot of where the gaps are and how well people are doing. I think I will leave it to the local experts to say what are the next priorities for the next decades. And similarly for Japan, I think like China, in Japan there's a lot of catch-up works to do to start with. So yeah, that's my answer. Thank you.
Okay, thank you so much. That's great. And Dr. Jing Wang, do you have any additional comment on top of his comment? Yeah.
I think Dr. Zhao very clearly pointed out the problem we are facing in China. I think the first priority for us is to improve awareness. That's why we are doing the Measurement Month project quite actively over the years. We hope we will do that in the next years and to reach a higher awareness, like in Korea, around 70%. That's what we are doing for.
Okay, thank you so much, Dr. Wang. So the second panelist is Dr. Dr. Lee. So do you have any question from? Yeah, come here, please.
First of all, I'd like to thank all the speakers for their wonderful talks, and I've got a question for Dr. Wang. So to my knowledge, China is very distinguished by the fact that the Chinese people eat out much less than those in Korea or those in other countries, which I think allowed the SARS trial to be conducted very successfully in China. So are there any currently ongoing initiatives or any planned strategies in China which puts a specific focus or emphasis on that particular characteristics of Chinese population? And if not, what do you think should such strategy be like, and to what degree would such strategy be helpful to improve the prevalence and treatment of those with hypertension in China?
Yeah, that's a very good question. Salt substitution is quite effective in reducing blood pressure and also the risk of cardiovascular events and even mortality. But the problem for the use of substitution, salt substitution, is the high cost, because such salt is much more expensive than the regular salt. That's probably a barrier to implement such a strategy to a very wide range in this country. But we probably can do something else in some provinces in China. For instance, Shandong province, they are now doing a government-led program for salt reduction. So probably they can utilize the influence of the government policies, then they can reduce sodium intake in general in the population, and they can achieve a much better blood pressure control in those patients with hypertension, and probably can also help prevent hypertension, or at least to slow down the increase of the increase in prevalence of hypertension. That's something in some provinces what they are doing. And the other thing is that we probably have to do more in the establishment of infrastructure. That's what I presentate. We need to establish at least more sophisticated system for the management of hypertension, as you have in Korea. Now we have much better health insurance coverage, but we probably still have to build a platform for the management of hypertension in 3 different levels of hospitals, tertiary, secondary, and primary care. So that's something we are doing. I hope that we can do better in the next few years.
Okay, thank you so much. So the last panelist is Dr. Somi-Cho. So do you have any question?
Yeah, I would like to thank all speakers for introducing very distinct but similar East Asian countries and their progress made in the hypertension research and management, as well as Dr. Zhao, who showed us global prevalences and management in hypertension, especially in resource-limited health systems where the data itself is very scarce. I have one question for Dr. Ho-Kyu Lee. First of all, congratulations on another production of the hypertension fact sheet. My question is that it is very reassuring to see that the rapid increase in hypertension prevalence in the very elderly comes mostly from controlled hypertension. But however, there still are controversy regarding intensive BP lowering in older persons due to concerns regarding hypoperfusion, frailty, and more. So do you have any data on adverse events or cardiovascular complications attributable to both uncontrolled hypertension or vice versa, in this case, excessive BP control?
Thank you for the question. It's a great question. And actually, thank you for participating. This must be 3 a.m. in Boston. Well, in this data for the fact sheet, we're not assessing the adverse outcomes or cardiovascular events. But our data in the fact sheet really shows that following intensive control for systolic blood pressure, the average diastolic blood pressure in older age really dropped almost below 70. And this might bring some challenges in the clinical setting. But this kind of really low diastolic blood pressure and its association with outcome is actually very controversial. And this so-called J-curve association is usually observed in observational core studies, whereas the randomized trials or Mendelian randomizing studies with causal inference usually shows some linear association with blood pressure and outcome, with lower blood pressure leading to a better outcome. So this still is in the middle of a controversy, but I think we need to do more studies concerning this adverse outcome that follows after intensive blood pressure control among older hypertension. Thank you for the question.
Okay, thank you so much. So we have a time to have one or two questions from the audience. Is there any question from the audience? Please feel free to ask anything. Yeah, of course.
I have a question for Dr. Miura. So overall, Japan and Korea have many similarity in the prevalence management of hypertension, but there is some difference, especially in elderly population. In Korean data, after age 60, the hypertension was more common in women than men. But in your Japan's data, until age 60 and until age 70, still the hypertension is more common in men than women. Do you have any idea about the difference between the two countries?
Okay, thank you for the question. So probably in men, I think the obesity is more strongly affected, have an effect on the high blood pressure. And in women, obesity rate is not increasing. So probably this is one of the reasons. And I think also alcohol drinking is also high in men, especially in men. So I think this is one of the reasons. Yeah.
Thank you.
Okay, so do you have any question from the audience? If not, is it this?
Yeah. So before closing this session, we have a very small ceremony. The Korean Society of Hypertension is giving the flag of appreciation to international invited speakers and chair, please Dr. Yano and Dr. Zhou and Dr. Miura come to the podium.
Good afternoon, ladies and gentlemen. I'd like to welcome you all this session. Now that it's time, let's start the through working group session on the impact of blood pressure on cognitive function. I'm a chair of this session, Professor Yong-Hyuk Ko at Joseon University Hospital. The co-chair in my left-hand side is Professor Soon-Ok Kwon, who is working at Assam Medical Center of Ulsan University. On this session, we have 4 speakers. Each speaker will have 15 minutes of presentation time. And they have 4 panels on this session. I'd like to introduce the panelists briefly. Professor Jin-Kwon Kim from Yonsei University, Professor Jae-Gun Ryu from Daegu Catholic University, Professor Il-Seok Son and Sung-Hyuk Ho from Kyung University, Korea also. At the end of the session, we have a discussion with the speakers and panelists and receive the questions from the audience for each presentation. I'd like to introduce the first 2 presentations, and Professor Kwon will introduce the last 2 presentations and moderate the discussion and Q&A. Okay, then, let me introduce the speaker and the title of the first presentation. Let me introduce Professor Sung Kang, our first speaker. Professor Kang is a neurologist who is working at Korea University Group Medical Center. The presentation title is Pathophysiological Link Between Blood Pressure and Dementia. Professor Kang, please.
Thank you. It's an honor to be invited to this conference. I'm a neurologist from Korea University Group Hospital. I'm going to present a topic on the pathophysiological link between blood pressure and dementia. There are 3 topics as shown in the slide. First, I present the relationship between hypertension and cerebral small vessel disease. Before I talk about the cerebral small vessel disease and hypertension, I'll explain the pathomechanism for hypertension-induced cerebral vascular injury. In young-aged individual, the vascular smooth muscle cell has a major role in protecting the cerebral small vessel from hypertension. That is, functional adaptation to the blood pressure include an enhanced pressure-induced myogenic constriction response of segmentally connected cerebral arteries and arterioles. This important homeostatic mechanism ensures that high blood pressure is not transmitted to the distal portion of the microcirculation. However, aged cerebral arteries do not exist hypertension-induced adaptive increases in myogenic tone, which in turn lead to myogenic protection in hypertension. The failure of proximal resistant arteries to functionally adapt to hypertension results in a mismatch between perfusion pressure and segmental vascular resistance that enables increased pulsatile pressure to penetrate the vulnerable downstream portion of cerebral microcirculation. The resulting hemodynamic burden exacerbates the disruption of blood-brain barrier, leading to exacerbation of plasma factors which promote microglia activation and neuroinflammation. In addition, microglia-derived pro-inflammatory cytokine leads to reactive oxygen species-induced neuronal damage. Neurovascular coupling is also a critical homeostatic mechanism that ensures prompt adjustment of cerebral blood flow to increase energy and auto demand of active brain regions. In individuals with hypertension, oxidative stress impairs the viability of endothelial nitric oxide availability and thereby impairs vasodilatation, resulting in impairment of functional hyperemia. This neurovascular decoupling is associated with cognitive impairment in experimental study. Hypertension causes cerebral small vessel disease via these mechanisms. Cerebral small vessel disease leads to subcortical vascular dementia. As you see in right side figure, cerebral small vessels supply the oxygen and nutrient in deep brain region, including white matter, basal ganglia, and thalamus. Thus, a cerebral small vessel disease injury occurs in these regions. As 70 MRI, we can detect the damage of cerebral small vessel in patients with subcortical vascular dementia. There are sparse lenticular stereo arteries in the left slide figure. However, it is impossible to use 70 MRI in clinical practice. Therefore, we check neuroimaging markers associated with cerebral small vessel disease using conventional MRI. There are three representative markers, including white matter hyperintensity, lacunes, and microbleeds. The patient with cerebral small vessel disease disease characterized by severe white matter hyperintensity and multiple lacunes, which lead to subcortical vascular dementia. Hypertension and other cardiometabolic syndromes causes arteriosclerosis in cerebral small vessels, which in turn lead to white matter hyperintensity and lacunes. These cerebral small vessel disease markers have gradually deposited in the subcortical region over several decades, eventually resulting in subcortical vascular dementia. In this regard, we think that there is a prodromal stage of subcortical vascular dementia, which we termed subcortical vascular MCI. Subcortical vascular cognitive impairment covers subcortical vascular MCI and subcortical vascular dementia. In addition, cardiometabolic syndrome, including hypertension, affects faster cognitive decline irrespective of cerebral small vessel disease burden. In a longitudinal observation study, high Framingham study CV risk score is independently associated with fast cognitive decline, even after adjustment for white matter hyperintensity, amyloid burden, and hippocampal volume. Furthermore, high Framingham study CVD risk score and amyloid burden have a synergistic effect on cognitive decline. Second, I will explain the relationship between hypertension and Alzheimer's disease. Alzheimer's disease is the most common cause of dementia. It is characterized by multiple cognitive impairment and neuropsychiatric symptoms. This patient was first diagnosed as having AD. When we perform the brain autopsies in Alzheimer's disease patients, compared to normal control, the sulci is noticeably widened and there is a shrinkage of the gyri. Especially atrophy is severe in medial temporal region. When we look at these brain tissues microscopically in more detail, we can find two characteristic Alzheimer's disease pathologies, amyloid plaque and neurofibrillatory tangle. Amyloid deposition compromises the neurovascular units and causes multiple cerebral microvascular impairments. Hypertension may exacerbate the progression of Alzheimer's disease by exerting synergistic deleterious effects on cells that are already stressed by overproduction of amyloid. Hypertension exacerbates microvascular damage in Alzheimer's disease and promotes blood-brain barrier disruption and consequential microactivation. Furthermore, impaired glymphatic clearance due to hypertension induced microvascular injury leads to a decrease in amyloid clearance. This graph nicely shows the temporal sequence of biomarker changes along the pathway to Alzheimer's dementia. It is now well known that amyloid and tau starts to accumulate before the symptom begins. Therefore, evidence of having amyloid and tau in the brain can be used as an early indicator of Alzheimer's disease. In this regard, the most successful development in the diagnosis of AD has been amyloid PET. As you can see here, compared to normal control, Alzheimer's disease patients showed higher PIB uptake in their brain. The distribution of PIB uptake is also consistent with that of amyloid pathology in their brain tissue. Several community-based studies using amyloid PET have found a relationship between hypertension and amyloid deposition. In the NeuroArctic study, community-based 322 non-demented participants were enrolled. Authors checked the presence of cardiometabolic syndrome, including hypertension, in visit 1 between 1987 and 1989. All participants underwent amyloid PET between 2011 and 2013 to check the brain amyloid deposition. Presence of 2 or more cardiometabolic syndrome in middle life was associated with a higher risk of brain amyloid deposition in late life. As you see in left figure, among 118 individuals without dementia, subjects with hypertension and ApoE4 have more of amyloid deposition, which suggests that hypertension and ApoE4 had a low in brain amyloid deposition. In another study, subjects with high systolic pressure and pulse pressure also had more brain amyloid deposition regardless of ApoE4 genotype. Hypertension also associated with neurodegeneration, regarded as a surrogate marker of dementia. As shown in the figure, in elderly Koreans, hypertension affects neurodegeneration in multiple regions. In the study using the UK Biobank dataset, hypertension and diabetes are associated with neurodegeneration, which causes memory impairment. Our research team investigated the ethnic and gender-specific effect of hypertension on neurodegeneration using a deep learning-based brain age prediction model. The brain age index equals 0 indicates the chronological age is the same as the predictive brain age, with higher values indicating the older appearance brain than chronological age. Among Korean, hypertension had a more deleterious effect on neurodegeneration in females than males, while among British, there was no gender difference in the effect of hypertension on neurodegeneration. Third, I will present the association between Alzheimer's disease and subcortical vascular cognitive impairment. In previous study, there are 30% of amyloid deposition in subcortical vascular cognitive impairment patients. In a recent study using a large number of clinic-based participants, amyloid positivity in patients with SBCI was 41%. These findings suggest that patients with cognitive impairment frequently have both Alzheimer's disease and cerebral small vessel disease pathologies. These are also identified in autopsy studies. In this study, about 2/3 of patients diagnosed with clinically probable AD in life also have vascular pathology in their autopsy findings. Another autopsy study has shown that more than 50% of patients with definite AD in autopsy also have vascular pathology. Several studies based on non-demented participants have found the positive association between white matter hyperintensity and amyloid deposition. In a tau PET study using SBCI patients, have found that the independent effect of amyloid and cerebral small vessel disease on tau deposition, especially cerebral small vessel disease burden, was independently associated with higher tau uptake in inferior temporal regions. These findings suggest that cerebral small vessel disease burden also had a lowering brain tau deposition. According to previous studies, Alzheimer's disease and SBCI may lie on opposite ends of a single disease spectrum. One of the main reasons is that they have shared risk factors such as age and hypertension. The other reason is showing that cerebral small vessel disease and amyloid have a strong association as shown in previous slides. This association leads to the possibility of cerebral small vessel disease decreasing the clearance of amyloid, or cerebral amyloid angiopathy, possibly accelerating cerebral small vessel disease. As you can see here, Alzheimer's disease patients showed compared to ApoE homozygote, ApoE4 is a risk factor for amyloid positivity, while ApoE2 is a protective factor. However, in SBCI patients, ApoE2 as well as ApoE4 are risk factor for amyloid positivity. These results also suggest that the principal mechanism of amyloid deposition in SBCI may differ from those in ADCI. Here are my conclusions. Hypertension leads to cerebral small vessel disease via multiple mechanisms: blood-brain barrier disruption, microglia activation, reactive oxygen species associated with neuronal damage, and neurovascular decoupling. Hypertension-induced cerebral small vessel disease gradually develops cognitive impairment over several decades. Hypertension is also associated with amyloid deposition and neurodegeneration, regarded as surrogate markers of Alzheimer's disease. Alzheimer's disease and subcortical vascular cognitive impairment lie on opposite ends of a single disease spectrum with shared risk factors including aging and hypertension. Thank you for your attention.
Professor Han, thank you for the nice presentation. Now let's move on next presentation. I'd like to introduce Professor Pedro Guimarães Cunha, our second speaker. Professor Cunha is working at the Medical School of Minho University in Portugal, who is the president of the working group on hypertension and the brain of the European Society of Hypertension and the Secretary General of the Artery Society. His presentation title is Blood Pressure, Dementia, and Cognitive Decline, a crosstalk between micro and macro circulation. Professor Cunha, please.
Thank you very much. I would like to first appreciate and acknowledge the invitation by the Korean Society of Hypertension, and also to greet the chair and the panels. It is a very honorable to be here today and to share with you my views on blood pressure, dementia, and cognitive decline. Sorry, maybe like this. So these are my current affiliations and responsibilities. I have no conflict of interests, and this is the agenda that I've prepared for you today in 4 main points. So one of the most striking news that we have received in the last few decades is in fact very well represented in this study by the HARIC neurocognitive study, showing that following more than 1,300 subjects for over 20 years, those that were exposed to high blood pressure had an increased rate of decreased neurocognitive function. And more importantly, not only those who had hypertension levels, but also those who were exposed to pre-hypertension levels had a higher risk of developing cognitive dysfunction later on in life. This is very important. I'm sorry, but this is not working. Like this. Yes, this is very important as when we are studying the prevalence of different kinds of diseases, not only do we see that patients with hypertension are becoming one of the greatest pandemic and non-communicable diseases, but at the same time, we see that dementia and dementia-related diseases are becoming one of the most prevalent, and it is thought that by the end of the year 2030, the prevalence will triple that of the one we have today, which is obviously in relations with an older population, but also because of the exposure that these citizens have had to high blood pressure. This is one of the cartoons that I like the most, as it shows exactly, for us hypertensiologists, people who are dedicated to hypertension, the 2 spectrums of our performance. On one hand, the atherosclerotic and occlusive end that we chase when we have patients that have neurological symptoms and presented themselves to the hospital because they have just had a stroke. And on the other hand, the topic that brings us here today, the effect of increased blood pressure transmitted into the brain, provoking remodeling of the arterial bed in the brain and cerebral small vessel disease that you can see as lacunar infarcts, leukoariosis, white matter hyperintensities, or microbleeds, as my colleague has already presented previously. Today, the modern approach to vascular dementia is no longer attributable either to large vessels or small vessels, but as we can see in this very nice summary, it is a joint venture from with both the effects of changes in large arteries and changes in small vessels, which are thought to act in a loop, retrofeeding themselves and provoking more and more damage to the brain, eventually leading to dementia. This is exactly what happens in big arteries, in larger arteries, where when they are young or not exposed to different cardiovascular risk factors, they have the ability to absorb the energy at each cardiac cycle and to transform the pulsatile energy into a more laminar flow that is then translated into the target organ damage. This is not what happens in older arteries or in arteries that are subjected to the action of cardiovascular risk factors that lose this ability to accommodate pulsatile energy, lose their elasticity, become more stiff, and therefore transmit most of its energy to the periphery into the target organs, namely the brain, where they'll provoke target organ damage. Of course, after looking at one of the mechanistic I'm sorry, I was lost there for a while. After looking at one of the mechanistic algorithms that can explain this loop, we should also not forget the role of small vessel disease and the effects that they are subjected to during hypertension, namely inward eutrophic remodeling with decreased lumen, increased medial lumen ratio, which will obviously lead to increased resistance, decreased perfusion, especially to areas less perfused in the brain. I will not go through the other mechanistic effects that have already been approached, but I will obviously give a very emphatic highlight to the hyperpulsatility provoked and the consequences. Even if we do look at main mechanistic effects in the brain provoked by changes in large and small arteries, we must not put aside or forget the effect of the vascular smooth muscle cell. We've seen the presentation by our previous colleague, Professor Kwan, that detail especially the role of this cell, who is able to differentiate to different phenotypes, one of them, several of them in response either to a hemodynamic or an inflammatory stimulus, and of course having a very important effect, as was described in the 20-hydroxy eicosatetraenoic acid pathway that is responsible for contraction that protects the entrance of pulsatility into the brain and decreases the risk of ruptures and the initiation of a pro-inflammatory reaction that will ultimately lead to neuroinflammation. So it is clear that we do not only have a micro and macro circulation crosstalk in the brain, we also have a round circle that occurs at the cellular level between local vascular smooth muscle cells and their environment, which in one hand is protective, and on the other, through the degeneration and the installation of different changes in the extracellular matrix remodeling, will soon be transformed in the vessels, in vessels that are not able to withstand such practical increase in pulsatility, and will therefore feed this largest circle that we are talking today about, of small arteries and large arteries, with smaller increasing resistance, increasing the blood pressure, increasing central blood pressure, pulse wave velocity, that on its hand will increase remodeling of small arteries, and so on and so on. So there's more than one crosstalk occurring at the level of the vessels, from the cellular level of the vascular smooth muscle cell to the larger level in small arteries and large arteries. And this, in fact, this effect of hypertension and aging is the great effect that creates microvascular injury, and that we will see later on as microhemorrhages, lacunar infarcts, and white matter damage that we've seen earlier. And this is one of the best summaries that I've seen relating not only macrovascular changes, but also microvascular and endothelial dysfunctional changes that in the end explain why we have neurovascular uncoupling. So why do these cerebral small vessel disease biomarkers that we have seen here are able and responsible for the development of dementia? So I used a few studies that are very elucidative of this. The first one is the Rotterdam SCAN study that's followed more than 1,000 subjects for approximately 3.5 years, showing that those that had markers of cerebral small vessel disease had more than the double of the probability of developing dementia. In fact, those that during the study were still developing new lesions in the brain were the ones that had an accelerated route to dementia. The same could be seen and proven by the Framingham Heart Study, where the extension of white matter hyperintensities and the number of lacunar infarcts, as they grew, they also increased the risk of developing dementia after a follow-up of almost 6 years in 2,200 subjects. And several other studies could be quoted, but in fact there are several, at least two more prominent meta-analyses that show clearly that cerebral small vessel disease markers like white matter hyperintensity, brain infarcts or lacunar infarcts, and later on cerebral microbleeds are definitely associated to the development of dementia and are precursors to its development. And how can the clinician nowadays without having to use CT scans or MRI. How can he look at these changes? Well, one of the hypotheses is to look at the retinal vessels and to try to identify changes that are clearly associated to the risk of cerebrovascular disease and dementia, as we can see here in this meta-analysis published 3 years ago with 28 prospective studies, more than 50,000 subjects, or in an accessory way to look at blood pressure variability, which is the topic of one of our following speakers, so I won't go into this deeply. So we've seen how do small vessel disease occur, how they are related to cognitive decline. What is the relation between arterial stiffness and cognitive decline? Is it independent of microcirculation, or does it have its own pathway? And there are 2 or 3 core studies that I must mention. One of them is the Reykjavik study with more than 700 subjects that studied pulsatility and pulse wave velocity, showing that those in the last third of pulse wave velocity, pulsatility, and middle cerebral artery pulsatility were the ones that had more prevalence of cerebral small vessel disease. And in fact, they actually showed that these subjects with increased parameters in pulsatility and pulse wave velocity had an increased change in brain structure and in cognitive function than the other counterparts. Another study was the Oxfast study that studied patients with 6 weeks after minor stroke or TIA, and they could show in more than 100 patients that those that had increased pulsatility in middle cerebral artery were the ones that had a higher probability of growing into cognitive decline and dementia. And finally, because of its difference, I wanted to show you this study from the Framingham Heart Study, that if you see, has a mean age of participants in 46 years, showing that these patients, through techniques of MRI, fractional anisotropy, if they have increased pulse wave velocity, there already are changes in the organization of white matter that occur exactly at the spots where later on we are usually seeing patients that have changes and then that have dementia. So these are precocious changes that occur in the brain, and in fact those that were at the higher third of pulse wave velocity were also the ones that had higher disarray of the white matter integrity, making it look like as if their biological age had grown faster, almost 5 years into the future, and having these changes in brain occurring more precociously. I will not go into this, but I will definitely tell you about the association that this meta-analysis uncovered between cerebral small vessel disease and cognitive impairment, showing in several tens of studies that those subjects that had at the same time high pulse wave velocity and uncontrolled hypertension were the ones that had highest changes in the executive function, thus reinforcing these associations. And we ourselves in our group have found an association between arterial stiffness and the development of cognitive decline in all the groups and areas of cognitive function. The most bizarre study that I bring it to you today is this recent publication of the Oxfast cohort, showing that if you have all the patients with a minor TIA or stroke very well controlled in blood pressure, anticoagulant, antiplatelets, and even in lipidic control, all risk factors, in fact, they still continue to have an increase in pulse wave velocity, giving us, and of course, new events, putting us the question that if pulse wave velocity itself should be one of the treatment strategies. And my final slide on this is, in fact, the news coming from the Maastricht study showing that there is, in fact, a tripod between microvascular dysfunction, pulse wave velocity, and cognitive function. And if you see it here, when we put carotid femoral pulse wave velocity in the model with microvascular dysfunction, the effect of pulse wave velocity is only explained by microvascular dysfunction in 16%, which means that there's still a lot to uncover on the influence of pulse wave velocity in the brain. I will finish with some clinical appointments. First, to let you know that if we do not look at the brain as a target organ damage, we will leave behind 37% of patients that don't have any other form of target organ damage, and thus we will not stratify them correctly or intensify their treatment. And this is particularly serious, as in the recent study from the Framingham study, first pulse wave velocity was the target organ damage that was more prevalent, 40 to 60% of patients, and then were brain changes. So if we don't measure these two, we are not correctly stratifying and intensifying treatment for patients. The European Society of Hypertension has already included cognitive function as one of its biomarkers. We in the working group have developed a tool for everyday clinicians to use in their practice and to be able to identify precociously those that are going or developing cognitive dysfunction. And why did we do this? And this is my two final slides. Because recently, as of last month, we know that in this meta-analysis of randomized control trial, double-blind, that you very well know, those subjects, more than 28,000 patients that received antihypertensive treatment, had a decrease in their risk of developing dementia by 13%. And in fact, this was obviously dependent of age, but in ages as soon as 60 to 70 years, they were already being decreased with their risk of being having cognitive decline. And so this is something very important that we must detect early and treat to avoid its progression and its future burden in society. And I finalize with this. There obviously is a crosstalk between the micro and the macro circulation, and today we acknowledge that this crosstalk has a clear effect on organ damage, namely in the brain, and that we have therapeutic options that can decrease both this crosstalk and at the same time the target organ damage. These are my conclusions. Cerebral small vessel disease obviously is the result of crosstalk between the micro and the macro circulation and should be understood on its broader and specific implication. It mediates the effects of carotid femoral pulse wave velocity on cognition, but only explains 16.2% of its predictive effect. The pulse wave velocity is associated with increased risk of cognitive decline through complex hemodynamic mechanisms, including the reduction of cerebral blood flow and increased cerebrovascular resistance. It has superior power than blood pressure to detect asymptomatic patients at risk of progression to cognitive decline. The highest category of aortic pulse wave velocity independently increases the risk of cognitive impairment by 44%. And of course, patients with optimized medical treatment still see progress in cerebral pulsatility index, and this means that maybe we should look at pulse wave velocity also as a treatment target. I'm showing you a picture of my city and inviting you all to come there. We'll be honored to welcome you and show you around. It would be a pleasure. Thank you very much.
Thank you, Professor Kuna. So I'd like to introduce the next speaker, Yerim Kim. She is a strong neurologist at the Gangdong Sacred Heart Hospital, Hallyu University. The topic of his speech is the recent evidence of blood pressure variability on cognition. Please.
Thank you, Chairman. First of all, it is a great honor for me to present my topic here in this great conference. I'm Yerim Kim from Hallyu University College of Medicine. Today, I talk about BP variability and cognition. My today's topic consists of the following 4 parts. First, what is BP variability? Second, types of BP variability indices. Third, how BP variability may affect the cognitive decline. And finally, why BP is not or less associated with cognition. Let's move on to the first topic of my subject. What is BP variability? BP variability is a complex phenomenon that includes short-term fluctuations occurring within a 24 periods, such as bit-to-bit variability or within 24 hours BP variability, as well as BP changes over more prolonged periods of time, such as day-to-day, visit-to-visit, or seasonal variations. blood pressure variability degree of the blood pressure variability may be affected, the result of the complex interactions between neural or humoral changes and superimposed effects of demographic, physiological, behavioral, or environmental effects. However, although there has been awareness of the BP variability, the clinical relevance of BP variability on clinical outcomes has not been considered until recently. So the previous review article published 2010, clinical guidelines recommend that episodic hypertension is not treated and the potential risk of residual variability have been ignored. And in 2013, ES's guidelines suggested that the clinical importance of visit-to-visit BP variability is not yet proven. However, over the past decade, higher BP variability has been increasingly recognized as a predictor of clinical events such as CVD and clinical mortality and coronary heart disease and stroke. Regarding the cognitive decline in this meta-analysis extracted from 20 studies with a total analytic sample of approximately 8 million patients, mean systolic and diastolic blood pressure and blood pressure variability were all associated with dementia and cognitive impairment. Let's move on to the next topic of types of BP variability indices. BP variability parameters can be quantified by using standard deviation, coefficient of variation, variation independent of the mean, and SD regression, and some other things. In clinical trials, the physicians can use these one or more BP variability parameters. For example, in Picasso sub-analysis trial published last year, among the 1240 Korean Picasso participants, a total of 746 participants were included in this study. BP variability was measured using SD regression, and VIM, and cognitive status was evaluated by using MMSE and MOCA. The blood pressure variability were distributed totiles. The blue line is the total 1, orange line is the total 2, the gray line is the total 3. During a mean follow-up of 2.6 years, after adjusting for multiple variables, higher BP variability was independently associated with faster cognitive decline like this over time. However, in contrast to BP variability, the temporal cognition changes over follow-up period, the mean SBP was not associated with cognitive decline by using MMSE and MOCA tests. Then we should know how blood pressure variability may affect the cognitive decline. From the pathophysiological perspectives, several mechanisms can be advanced to explain these findings. The first hypothesis is the disruptions of cortical subcortical circuits. In this interesting retrospective observational study, day-to-day blood pressure variability, indicating that midterm BP variability, is associated with cerebral arterial dilatation and white matter hyperintensity. In this systematic review and meta-analysis study, including a total of 2796 individuals with a median follow-up of 4 years, one increase of SBP variability was associated with 1.26 higher risk of odds ratio of the presence or progression of white matter hyperintensities. Maybe the potential mechanism can be suggested like this. The chronic cerebral hypoperfusion activates a molecular and cellular injury cascade that leads to breakdown of BBB, and BBB damage is related to excitotoxicity and oxidative stress, inflammation, and MMP that lead to downstream cascade effects and make the white matter changes, damages in the brain. The second hypothesis is the brain atrophy and amyloid beta and tau deposits. Dysfunctional BBB promotes amyloid beta accumulation. Oligemia can increase brain amyloidogenesis by enhancing expression and processing of amyloid beta precursor protein and activate microglia, impair neuronal protein synthesis. As a result, that may cause neuronal damage and cellular death. This may also evoke the cerebral atrophy, especially in the most vulnerable areas, such as the hippocampus. So let me introduce this interesting article published this year related to tau accumulation. In this study, 286 older adults without history of dementia or stroke were included in this study. The physicians determined the blood pressure variability from 3 to 4 blood pressure measurements collected over 12 months, and the participants underwent repeated tau PET scans at follow-up. As a result, elevated BP variability was related to tau accumulation in the temporal meta region, especially in the entorhinal cortex, and especially in the apolipoprotein E4 carriers. Very interesting. And the final hypothesis is the inflammation and oxidative stress-related theory. The damage to the endothelium and BBB induced by BP fluctuation may increase the secretion of pro-inflammatory cytokines and reactive oxygen species, such as interleukin-6, TNF-alpha, or CRP, and etc. And that makes induced microglia overactivation. As you know, it is well known that the upregulation of the neuroinflammatory cascade and the reactive gliosis are key moderators of critical events of Alzheimer's disease pathogenesis. Then we should know why blood pressure was not or less associated with cognitive decline. In some clinical trials, in this slide that I showed you previously, I mentioned that systolic and diastolic blood pressure itself and blood pressure variability are all associated with cognitive decline. However, the BP effect sizes were less strong than the blood pressure variability effect sizes, indicating that the relative contribution of BP variability exceeded that of mean blood pressure. We cannot explain the exact pathomechanism for these findings, but one suggestion is that there is a theoretical right shifts in cerebral autoregulation curve in chronic hypertension because brain has the autoregulation. A constant pressure is maintained even in patients with some degree of higher BP. However, when a patient's blood pressure increases above upper limit or decrease lower limit, autoregulation is lost. This leads to disruption of vascular endothelium or breakdown of BBB. So maybe some suggestions may suggest that the blood pressure have more larger effect on neurodegeneration or cognitive decline. In summary, let me stress my conclusion again. We know that the blood pressure variability has emerged as a novel predictor for cognitive decline, and several mechanisms can be advanced to explain these findings. But before I finish, BP variability represents neither a background noise nor a random effect phenomenon. Instead, it has been associated with anatomical and functional alterations in the brain. Thank you for your attention.
Thank you, Professor Kim. I will introduce our last speaker of this session. Seoul Kim is the strong neurology worker in the Department of Neurology of Haeundae Baek Hospital of Incheon University, Busan. The topic of his speak is what is the optimal strategy to maintain cognitive function for the patient with hypertension. Please.
Hello, everyone. Thank you for being here today. It's my great honor to present this topic at this conference. I'm Shin Kim from Haeundae Baek Hospital in Busan. Today, I'd like to talk about the optimal strategy to maintain cognitive function for the patients with hypertension. My presentation will flow as this. First, background. Next will be the association of blood pressure with cognition. And I'll talk about the optimal strategy to maintain cognitive function. And finally, summary. Let's start with the background first. As you know, vascular risk factors such as hypertension and diabetes can affect Alzheimer's disease and vascular dementia, which are the two most common causes of dementia. Hypertension promotes microvascular injury, which results in brain ischemia and neuroinflammation. This damage is visible as microhemorrhages, lacuna infarcts, and white matter damage on MRI, as you see in this picture. And when this builds up gradually, they can cause subcortical vascular dementia. Ischemic events can also lead to accumulation of A-beta amyloid, a major component of neuritic plaque of Alzheimer's disease. And ischemic events can lead to A-beta deposition by reducing A-beta clearance by BBB breakdown or decreased perivascular drainage of amyloid from brain CSF, brain interstitial fluid. And ischemic events may activate tau phosphorylation, promoting formation of the tau species. Next, I'll explain the association of blood pressure with cognition. According to a systemic review and meta-analysis of 209 prospective studies, midlife hypertension was related to a 1.19 to 1.55-fold excess risk of cognitive disorders. Midlife hypertension means hypertension in individuals about 50 years old. And those response analysis of 5 studies indicated that systolic BP over 130 millimeter mercury was related with high risk of cognitive disorders. And midlife systolic hypertension and persistence of systolic hypertension into late life were associated with an elevated risk of instant dementia. And individuals with low to normal blood pressure at midlife, a steep decline in systolic blood pressure during mid to late life was also associated with increase in dementia risk. This is because, as Professor Pedro said, as we get older, arterial blood vessel decline, elasticity declines, and it leads to impaired cerebral autoregulation and the ability to maintain adequate perfusion. So this poses to cerebral hypoperfusion and cerebral ischemia. Recently, the association of blood pressure levels and risk of dementia has been published using 4.5 million people from Korea National Health Insurance Service health screening database. The risk of dementia and Alzheimer's disease was significantly higher in the SBP over 160 and lower SBP groups. Lower SBP groups means SBP less than 100 millimeter mercury. These U-shaped associations were consistent regardless of antihypertensive use. And although adults with elevated BP variability exhibited high phosphorylated tau and total tau in CSF and low amyloid levels in CSF. Next, I'll talk about the optimal strategy to maintain cognitive function. Good news is that blood pressure lowering with antihypertensives was significantly associated with decreased risk of instant dementia or cognitive impairment. One study used brain tissue and quantified cortex amyloid and tau, and data showed that those on antihypertensives had less extensive spread of amyloid and tau pathology. As I said, those on antihypertensive medication had lower risk of instant Alzheimer's disease and dementia. And over a long period of observations, no specific antihypertensive drug was more effective than others in lowering the risk of dementia. However, recent studies show that angiotensin II stimulating antihypertensive users had a 45% lower incident dementia rate compared to angiotensin II inhibiting antihypertensive users. Angiotensin II stimulating antihypertensive means angiotensin II receptor type 2 and 4 stimulating antihypertensives. These include thiazide diuretics, dihydropyridine calcium channel blockers, and ARB. And angiotensin II inhibiting antihypertensive means angiotensin II receptor type 2 and 4 inhibiting antihypertensives. These include beta blockers, long-acting non-dihydropyridine CCB, AC inhibitors. As you know, renin generates angiotensin 1 and it is converted to angiotensin 2, and this binds to AT1 and AT2, and angiotensin 2 is further metabolized to angiotensin 4, which binds to AT4. Thiazide diuretics and dihydropyridine CCB increases renin, and beta blockers decreases renin, and long-acting non-dihydropyridine calcium channel blockers either do not affect or decrease renin. And angiotensin 2 and 4 activity have been associated protection from ischemia via activity at AT2 and AT4, and ARB selectively inhibit angiotensin 2 at AT1 without inhibiting ACE. ACE is known to degrade amyloid, and ACE inhibitors inhibit ACE. So ACE inhibitors thus facilitate deposition of amyloid. So angiotensin 2 and 2 receptor type 2 and 4 stimulate antihypertensives have greater protective effect, brain protective effect than angiotensin 2 receptor type 2 and 4 inhibiting antihypertensives. And besides, angiotensin 2 and 4 have been associated with drug effects on memory. This study extended the previous work, and it showed that antihypertensive that stimulate type 2 and 4 angiotensin 2 receptors had lower risk of cognitive impairment than angiotensin 2 inhibit type 2 and 4 receptors. In addition to hypertension, there are many modifier risk factors for dementia from early to late life. This number means percentage reduction in dementia prevalence if this risk factor is eliminated. Out of the sum is 40%, and the rest of 60% we don't know yet. And so to prevent dementia, we need to reduce neuropathological damage and increase and maintain cognitive reserve. So this can be achieved by minimizing diabetes, treating hypertension, preventing head injury, and stopping smoking, and reducing air pollution, and reducing midlife obesity, and maintaining frequent exercise, and reducing occurrence of depression, and avoiding excessive alcohol, treating hearing impairment, maintaining frequent social contact, and attaining high level of education. This study shows the intervention effects for global executive function and CDR. CDR is clinical dementia rating and severity utility. A higher CDR means higher severity. The largest improvements were observed in patients with aerobic exercise and DASH diet group than those receiving health education. And this figure shows the cerebral changes promoted by hypertension and exercise. Brain with hypertensive individual shows increased microvascular rarefaction. That means reduction in vascular density, and decreased cerebral blood flow and increased ischemia. The benefits of exercise are increased VEGF, vascular endothelial growth factor, promoting angiogenesis, and increased brain-derived neurotrophic factor of molecule associated with synapse formation and increased neurogenesis. Some studies have found that cognitive training can improve cognitive function, and computer-based cognitive training games have been developed to stimulate brain function. So it's important to control and modify these risk factors. Summary. Hypertension is an important modifiable risk factor for Alzheimer's disease and vascular dementia, which are the most common causes of dementia in the elderly. Antihypertensive therapy reduces the relative risk of dementia. The best way to prevent dementia in hypertensive patients is appropriate treatment from middle age. ARBs, dihydropyridine CCBs, and thiazide diuretics could be used over angiotensin converting enzyme inhibitors, beta blockers, and non-dihydropyridine calcium channel blockers when it comes to preventing dementia. Lifestyle changes include exercising regularly, maintaining a healthy diet, losing weight, stopping smoking, reducing alcohol consumption, and cognitive training could be performed. Further studies are needed to determine the optimal blood pressure target. Early screening and treatment for hypertension is vital to reduce the global burden of dementia. Thank you for your attention.
Thank you, Professor Kim. So we will move to the Q&A sessions with the four panels. So we have some enough time, so I wanted to active discussion. Who is the first asking? Dr. Professor Kim? Oh.
Yes. My name, I have one question to the Professor Pedro Cunha from Minong University. And thank you for your excellent presentation about the importance of pulsatile index and arterial stiffness between cognitive decline and hypertension. Thank you. I have some experience study about the prognostic value of arterial stiffness in acute ischemic stroke. And high pulsatility index is very strong prognostic factor after acute ischemic stroke patient in my publication. And I have some question about the high pulsatility index or arterial stiffness is very important in prognosis and the connection between macrocirculation and microcirculation in your seen in your presentation. I agree with the importance, but do you have some advice? Is there some potentially effective treatment method to reduce or inhibit the progression of arterial stiffness in clinical practice?
Thank you for your question. Our experience is also that we can use arterial stiffness to in stroke patients to determine those that later on will have more neurologic damage as sequelae after stroke. But going straight to your question, as you know, we have recently produced one randomized control trial called the SPARTE trial that tried to use pulse wave velocity as a treatment target. It was underpowered to determine if treating pulse wave velocity by itself would be better than treating blood pressure alone. But the fact that we used pulse wave velocity as a treatment target was able to improve the control of blood pressure on one hand, and to reduce the development of further disease in large arteries, i.e. decreasing the shift of pulse wave velocity along the years. So going back to that data and to some other minor studies, we can say that using the combination of a systematic inhibitor of the renin-angiotensin system plus a calcium channel blocker in optimized doses, which means as much as possible for the particular patient that we are seeing, we may attain a decreased level of progression of arterial stiffness and maybe even stop its progression. Unfortunately, there's still no clue on how to make it turn back.
I'm Yu, from cardiologist from Daegu Catholic University Hospital. According to the presentation of prior two presenters, vascular dysfunction and that vascular lesion is definitely associated with cognitive dysfunction and dementia. But however, I think that direct association with hypertension, between hypertension and dementia is still not clear. Most of the papers show that association of hypertension and cognitive impairment, but there are not uncommon, not uncommonly still negative result of direct association of hypertension and the cognitive dysfunction is common. Report about that is not uncommon. And some antihypertensive drugs that decrease the same degree blood pressure. Some certain drug improve cognitive impairment, but certain drugs do not improve cognitive impairment. So I think that the still hypertension and the cognitive impairment is more point to clarify. I have one question to Dr. Seon Kim. You, the end of your present, you mentioned about the screening of hypertensive patient to prevent cognitive impairment. That, and as far as I know, the screening test is MMSE. I think that the sensitivity and the specificity is still not too high, not very high to discern the hypertensive patient vulnerable to cognitive impairment. Do you think that is it sufficient to select the hypertension patient vulnerable to cognitive impairment? Is there any method to screen the hypertension patient vulnerable to dementia or cognitive impairment?
Yes, thank you for your question. Well, patients with hypertension usually have wide matter hyperintensities in their brain, and it might play a role in cognitive impairment. So when I see the patients in clinic, I usually examine the patient with MMSE. This is the cognitive test, basic cognitive test, and their brain exam and their blood pressure check and laboratory tests. And I see the patients with all of the informations, and I decide the patient's diagnosis and treatment.
Do you recommend MMSE for all the hypertension patients?
MMSE usually be checked over 65 years old, and young age, especially middle age, over 45 to 60 years old. I do not recommend the MMSC when they have no cognitive problems, when they know subject cognitive impairment. So,
Thank you.
Yeah. Thank you for your question.
Thank you, all the speakers. I'm Il Sok-son from Kyunghee University. I'm also a cardiologist. After all the presentation, I feel it is much more complex understanding the physiological link between dementia and hypertension. For the BP variability, I have a question to Yerim Kim. You mentioned much more, many hypotheses to BP variability, how BP variability to cause dementia and cardiovascular disease. Usually the BP variability translates into higher risk of stroke. So in my simple suggestion, many classes of antihypertensive drugs can reduce BP variability, such as calcium channel blocker with longer half-life, and also ARB with long half-life may reduce BP variability. But there is no well-designed randomized controlled trial to reducing BP variability can reduce dementia in complicated hypertension. So my simple question is, any antihypertensive drug to be permeable to blood-brain barrier may have better effect on the reducing dementia, because some speakers mentioned about the small or large vessel disease linked to dementia. So how do you think?
It's a very good and important question, and thank you for your question. I cannot answer exactly for your important question because it is not known well. But as you mentioned, some antihypertensive drugs such as calcium channel blocker or ARB, some ARBs are related to the less reduced BP variability compared to other diuretics or beta blockers. So as you mentioned, if we use some specific antihypertensive drugs for those vulnerable patients, then we can manage some, we can decrease some patients with development of dementia in some hypertensive patients. And as your question, what is your final question? I'm sorry.
Permeable to blood-brain barrier drugs may have positive effects.
Actually, I don't know, but as you know, some ARB-like drugs may have the pleiotropic effects, such as anti-inflammatory or anti-oxidative stress management. So maybe it may affect the cognitive decline less than other things. Well, besides that, I cannot answer.
Maybe no definite answer.
Yes. Thank you.
Dr. Kunya, how do you think about this issue? Or there is any RCT ongoing or some ideas to reduce dementia, especially with permeable to blood-brain barrier drugs?
Thank you, Professor Son. Yes, there are, we don't have any RCT at the moment. We are developing a project called the Cerebro Project, and I have presented yesterday in a meeting that we had with the stroke working group of the Korean Society of Hypertension, and we invited the working group also to join this this research strategy. It will include the collection of cognitive function in several groups throughout the world, including the treatment strategies used. And then we will be able to differentiate those that can surpass the blood-brain barrier and those that cannot, and try to find the best treatment strategy. The point for me in first is that for the first strategy will be, of course, to control blood pressure with whatever drug you need to use. And then if you can go specifically into those that seem to have a more pronounced effect in the cerebral tissue and the brain and blood, and penetrate better the blood-brain barrier, then you can move on to a more efficient and more protective way of preventing dementia. But as you say, there still is no conclusive evidence, and we hope that with this strategy that we are implementing with the cerebral study, hopefully with also the help of the Korean Society of Hypertension, we can bring some answers into the floor.
Yeah, good comments. Thank
you.
Yes, I would like to thank all the speakers for nice presentations. And I'm Dr. Ho from Kyung University. I have some comments and one question. When it comes to the treatment options in hypertensive patients, as you know, the Sprint Mind trial and Accord Mind trial, intensive BP control may induce some better effect on cognitive function, and it may prevent the progression of white matter changes in small vessel diseases. However, some post-hoc analysis showed that the Sprint Mind trial that intensive BP control may induce brain atrophy and total brain volume and decrease of some hippocampal brain volume. Can you ignore that kind of effect of intensive BP control? I think anyone can answer, please. Seun Kim or another speaker.
Thank you for your question. Several studies show that systolic BP in midlife, systolic BP over 130 millimeter mercury was significantly associated with dementia risk, so I think the intensive treatment of high blood pressure in midlife is important, but in the very elderly patients, very intensive treatment could be harmful to them because orthostatic hypertension could be a problem, and in the elderly, very elderly, their arterial elasticity declined, so their arterial stiffness progressed, and they have a cerebral autoregulation impairment, and when they have BP fluctuations, they have very problem in cerebral perfusion. So I think BP management in midlife is appropriate, but in the very elderly, intensive BP treatment is can be harmful to them.
Dr. Kuna, can you more comments?
Thank you, Professor Hyo. I totally agree with Professor Kim on one hand. I think that the applicability, the external validity of the Sprint Mind study should be also raised concerning the age of the treatment of the patients and how fast it is done, because that's also another secret. It means that from my point of view, you can treat elder patients, but you cannot achieve as fast as you do for middle-aged patients, the level of treatment that you have. But I have a curious appointment to do about the Sprint Mind study. Of course, as you said, some post hoc studies have shown this deterioration in cognitive structure and mainly in cognitive function. But another post hoc analysis also studied the Sprint patients and looked in those that were treated in the intensive group to see if their pulse wave velocity had decreased. In fact, the benefit within those treated in the intensive group only occurred for those who concurrently had a decrease in pulse wave velocity. This means that to achieve the full benefit of the intensification of treatment, you should not only reduce blood pressure, but also achieve a reduction in pulse wave velocity. We do not know if this is applicable to the post hoc analysis of the Sprint Mind. And this is something very curious that should be explored, because maybe there are some answers to your question.
Thank you for your comment.
Thank you for all the panels and the speakers. So it is a very exciting discussions. Is there any more questions from the floor? Yes.
Dr. Shimflo.
I'm Shin from Seoul. It is really interesting and elegant session, I think. Thank you for all speakers and panelists. But I would like to make a comment or a question for very delicate, burning question. Because when we try to compare the power of mean blood pressure and the blood pressure variability in terms of the influence on the cognitive outcome, if we use standard deviation, actually standard deviation has a lot of information about mean blood pressure level. Because as the blood pressure goes high, as the absolute value of standard deviation is actually increased. So in a randomized trial, such as a woman's heart initiative studies, the power of the blood pressure variability is the strongest at the blood pressure range around 125 or around 30. That means when we go intensively control of the blood pressure, in that case, the mean blood pressure is lower. At that time, when you have some variation, there is actually a bigger coefficient of variation. So coefficient of variation has no unit at all. So if we put that two, variability and mean blood pressure variable into the multiple linear regression, it is very unfair for the mean blood pressure level, because as standard deviation itself has a information for the mean blood pressure level. So as a clinician, I would like to emphasize we still are a very strong stance on the role of mean blood pressure. And when the treatment is going on, a lot of complex scenario is in front of us. So as the data speaker said, actually the coefficient of variance is not related to the outcome in one slide. Other variability factor, blood pressure variability factor was associated, but coefficient of variance was not, seems to be positive. So in these issues, I would like to ask the position of mean blood pressure. Is it more important than blood pressure variability? What do you think about it?
I agree with you. It's okay. Thank you for a nice comment about only when we control the blood pressure very well in this session, we further investigate further, consider the variability. I understand that function. Thank you for nice comment. Okay.
Is there time for question or comment?
No problem. Go ahead.
Thanks. Thank you for all the lectures, and it's pretty late, but I will make a quick comment on the ROS system that Dr. Kim mentioned. So I'm a neurologist, and probably some of the panels are cardiologists. So there are ROS system and the renin receptor, and I don't know, angiotensin receptors in our brain, including medulla oblongata, so that controls our autonomic systems, and also cerebellums and putamen, recently substantia nigra and amygdala, and also hippocampus too. So not only the regulation of the BP can impact on our memories and cognition, I believe that there are direct impact on. I think it's pretty much plays a great role. I think it needs to be investigated more though. The receptor itself. So I think Dr. Son asked really good questions about the BBB and the ARB. So if we can find or target some medication that pass the BBB and target especially AR2 and AR4, which is angiotensin stimulating receptors, then that may improve our cognition and memory. I think that's the comments that I'd like to add on. Thank you.
Okay, so it is time already over, so we should last portion of the. We wanted to show our appreciation to Dr. Professor Pedro Cunha by give a plaque for appreciation. Please come up to the podium.